Look at this rotating 3D model of the normal adult female internal reproductive system. Notice how it splits into distinct left and right halves. The structures we see, the uterus, fallopian tubes, and vagina, are the final result of a highly coordinated dual-system embryonic fusion. The first component of this dual architecture is the paramesonephric or Müllerian duct system. These ducts originate from the invagination of the coelomic epithelium and ultimately form the bulk of the female internal genital tract. The second component is the mesonephric or Wolffian duct system. While primarily responsible for male internal genital development, these ducts, derived from the intermediate mesoderm, perform a crucial role in females by acting as the structural template for Müllerian development. In this photograph of a medical lecture, you can see students analyzing a pelvic model. Mastering pelvic anatomy requires understanding exactly how these embryonic structures interact, because it is the cornerstone of accurate gynecologic diagnosis. Müllerian anomalies present as complex physical variations in adults, but they are precise manifestations of developmental arrests occurring at specific temporal checkpoints in utero. By tracking the exact sequence of Müllerian development and Wolffian regression, clinicians systematically predict, diagnose, and surgically manage the 7 major classes of anomalies. This schematic traces the early embryonic path. The Wolffian ducts physically guide the descent of the Müllerian ducts alongside the developing kidneys. Because they are embryologically inseparable, finding a Müllerian anomaly requires an immediate evaluation of the urinary tract for associated renal defects. In a female fetus, the Wolffian ducts eventually regress. As the Müllerian ducts invaginate, they carry a fold of coelomic epithelium with them, which contributes directly to the formation of the broad ligament. This illustration of the broad ligament shows what happens when Wolffian regression is incomplete. 3 distinct remnants can persist: the epiphorin at the cranial end, the parophorin, and Gartner's duct running along the lateral vaginal wall. A Gartner's cyst originates directly from that Gartner's duct remnant. While often asymptomatic, it typically presents as a swelling in the anterolateral vaginal wall. Clinicians distinguish it from a cystocele by checking 3 specific negative signs. A Gartner's cyst is not reducible, lacks the rugosities typical of vaginal tissue, and produces no impulse when the patient coughs. You also separate it from a Bartholin cyst, which appears much lower near the vestibule at the 4 o'clock or 8 o'clock positions, and from paraurethral cysts located laterally to the urethra. The definitive management of these pelvic masses relies entirely on tracing their distinct embryologic origins. Most incidental cysts require no intervention, with surgical excision reserved strictly for symptomatic Gardner cysts. Watch the 2 Müllerian ducts move to the midline and fuse from the bottom upward. The central septum then resorbs, creating a single uterine cavity. Each original duct contributes 1 fallopian tube, half the uterus and cervix, and the upper third of the vagina. There are 2 crucial exceptions to this Müllerian origin. The ovaries develop entirely separately from the genital ridge, and the lower 2/3 of the vagina develops from the urogenital sinus. This entire process operates on a strict biological clock. Complete medial fusion of the 2 ducts must occur by week 10 of gestation. The second critical deadline arrives by week 20. By this point, septal resorption and endometrial differentiation must be fully complete. Missing either the 10-week fusion deadline or the 20-week resorption deadline permanently arrests development. The exact week the sequence stops defines the exact anatomical pathology the patient will carry. In Müllerian agenesis, both ducts fail, creating no uterus, cervix, or upper vagina, though ovaries remain normal. Moving to panel 2, a unicornuate uterus occurs when 1 duct fails, creating a single tube and a banana-shaped uterus with a rudimentary horn. If that rudimentary horn is non-communicating but contains functioning endometrium, the patient will experience severe unilateral dysmenorrhea. If an embryo implants in the horn, it creates an extreme risk for an ectopic pregnancy. This anomaly carries high clinical associations, including ectopic ovaries and unilateral renal anomalies. In panel 3, uterus didelphys represents the complete failure of the ducts to fuse. The defining hallmark is two distinct surfaces dividing completely separate uterine bodies. Didelphys often includes a longitudinal vaginal septum. If this septum fuses with the vaginal wall, it completely obstructs one of the hemivaginas, trapping menstrual flow to cause hematoculpus and a palpable pelvic mass. These severe, early-stage fusion failures carry heavy secondary consequences. Specifically, the combination of a unicornuate uterus or an obstructed hemivagina carries the absolute highest predictive association with ipsilateral renal agenesis. Moving to panel 4, the bicornuate uterus is a partial fusion defect, resulting in a single cervix but a distinctly divided external fundus. Panel 5 shows a septate uterus. The ducts fuse normally with a smooth external fundus, but the internal septum fails to dissolve. The septate uterus is the most common Müllerian anomaly overall. It is also the leading anatomical cause of recurrent abortions and first trimester pregnancy loss. Conversely, an arcuate uterus represents the mildest defect, a simple, slight indentation of the fundus. It yields the best overall reproductive outcomes among all these anomalies. Beyond structural arrests, the developing fetal tract is highly vulnerable to pharmacological teratogenesis. For decades, the synthetic estrogen DES was prescribed to pregnant women. Female fetuses exposed to DES in utero developed specific defects. The most common finding is vaginal adenosis. The classic malignant association is clear cell carcinoma of the vagina, and the most specific structural defect is a T-shaped hypoplastic uterus. The teratogenic effects extended to male fetuses as well, causing cryptorchidism, testicular hypoplasia, and hypospadias. While DES exposure requires lifetime systemic monitoring, the most critical structural challenge is differentiating between a true early fusion defect, like a bicornuate uterus, and a later resorption defect, like a septate uterus. Hysterosalpingography cannot reliably distinguish these anomalies because it only captures the internal cavity. Differentiating them requires analyzing HSG angles. A septate uterus displays an acute angle, less than 75 degrees, while a bicornuate uterus shows an obtuse angle greater than 105 degrees. To eliminate the guesswork, 3D ultrasound is now the investigation of choice for viewing the fundus directly. MRI serves as the gold standard for complex cases, while laparoscopy and hysteroscopy provide definitive anatomical clarification. The general surgical principle is conservative. Incidental anomalies require no treatment. The primary indication for surgical intervention is a history of recurrent abortion. When surgery is indicated, the defect type dictates the approach. A septate uterus is treated with a minimally invasive hysteroscopic resection, cutting away the internal wall from within the cavity. A bicornuate uterus requires a highly invasive transabdominal unification surgery, known as a metroplasty, to manually reconstruct the divided uterine body. This level of reconstruction carries long-term consequences. Patients who undergo a metroplasty must deliver all future pregnancies via cesarean section to prevent uterine rupture, and they face a high risk of postoperative pelvic adhesions that can cause infertility. Achieving the correct imaging diagnosis is paramount. Confusing a resorption defect with a fusion defect leads a surgeon down a radically different and potentially unnecessarily invasive operative path. Look at this diagnostic flowchart. Step 1. Count cervices. 2 cervices means uterus didelphys. 1 cervix, proceed. Step 2. Count fallopian tubes. 1 tube indicates a unicornuate uterus. Step 3. Assess the fundus. A divided fundus indicates bicornuate. A smooth fundus confirms a septate uterus. Step 4 is the mandatory clinical failsafe. Always evaluate the urinary tract, particularly when diagnosing a unicornuate uterus or identifying an obstructed hemivagina. Keep the clinical extremes clear. A septate uterus is the most common anomaly and the leading cause of recurrent abortion. An arcuate uterus yields the best outcomes. Müllerian agenesis yields the worst reproductive outcomes, and fetal DES exposure causes clear cell carcinoma. By mastering the 10-week and 20-week embryologic checkpoints, clinicians transition from simply memorizing static anatomy to understanding the living, logical continuum of gynecologic pathology. A 46XX female presents with primary amenorrhea, cyclical lower abdominal pain, and entirely normal secondary sexual characteristics. Menstruation is actively occurring, but the blood is trapped internally, unable to exit the body. This condition is known as cryptomenorrhea, literally hidden menstruation. It is the direct result of a mechanical outflow tract obstruction, where the endometrial lining sheds on schedule, but a physical barrier prevents external drainage. Because the patient exhibits normal secondary sexual characteristics, the underlying endocrine function is intact. The hormonal profiles in these typical presentations are entirely normal, making extensive endocrinological testing unnecessary. The active presence of regular, trapped menstruation, combined with a functioning endocrine system, isolates the diagnosis. The failure is strictly structural and anatomical. 3 distinct structural anomalies cause this exact clinical triad: vaginal agenesis, a transverse vaginal septum, and an imperforate hymen. While these 3 pathologies share an identical symptomatic presentation, they are not managed the same way. Resolving them requires radically different surgical protocols. To safely distinguish and treat these obstructions, we have to look past the macroscopic blockage and deconstruct how the normal vaginal canal is built from 2 separate embryological sources. The physical location and thickness of the obstruction found in the clinic today are dictated entirely by specific timeline errors during fetal development. This animated sagittal cross-section shows the developing female pelvis. The upper 1/3 of the vagina, highlighted in blue, develops from the fused caudal portion of the Müllerian ducts. It is entirely mesodermal in origin. The lower 2/3 of the vagina develop from an entirely different source, the sinovaginal bulbs. Derived from the urogenital sinus, this lower section is endodermal. During development, these distinct structures grow toward each other and physically meet. The complete vagina is a composite organ built from 2 different embryological blueprints. The location where the mesoderm and endoderm collide creates a natural structural vulnerability. At the initial meeting point between the upper mesodermal tissue and the lower endodermal tissue, the canal is not open. A solid, horizontally oriented barrier forms here, known as the temporary transverse septum. By approximately 20 weeks of gestation, this transverse septum normally dissolves entirely, a process called canalization. This leaves a single, unified tract. Once canalization is complete, the continuous vaginal tract is lined by a uniform layer of non-keratinized stratified squamous epithelium. Further down, at the precise junction where the endodermal sinovaginal bulb meets the urogenital sinus proper, a residual membrane is left behind. This is the normal hymen, which maintains a small opening to allow menstrual blood to exit. Normal canalization requires strict adherence to this 20-week schedule. If this resorption process halts prematurely, the temporary anatomical walls are left in place, creating permanent physical obstructions. Vaginal agenesis is a complete developmental failure of these structures. Frequently associated with Müllerian agenesis, it clinically presents as an entirely absent vaginal introitus. If the 20-week resorption process fails at the mesoderm-endoderm junction, the result is a transverse vaginal septum. This blockage sits high in the vaginal tract at the junction of the upper 1/3 and lower 2/3. On physical exam, it presents as a thick, fibrous band deep in the canal. There is no bulging hymen and no impulse felt upon coughing. Because the obstruction is situated high up, the resulting internal blood collection creates hematoculpus in the upper vagina. The elevated pressure causes retrograde pooling, resulting in hematometra within the uterus and hematosalpinx in the fallopian tubes. Conversely, an imperforated hymen is a highly localized failure, occurring strictly at the terminal membrane. Because the obstruction is at the exact opening of the vagina, the retained blood pools in the lower tract. This produces a tense, bulging hymen with a bluish discoloration from trapped blood and a clearly palpable impulse when coughing. The severity of retrograde pooling and the physical thickness of the barrier felt on exam are dictated strictly by exactly where the embryological timeline stalled. This split-screen algorithm outlines the immediate clinical approach for cryptomenorrhea. The physical exam quickly differentiates the initial defect. Look for an absent introitus, a bulging bluish hymen, or a deeply recessed, thick fibrous band. Abdominal exams may reveal a suprapubic bulge, caused either by a distended bladder or a uterus swollen with trapped blood. In virgin patients, pervaginal examinations are strictly contraindicated. Anatomical checks must rely on perrectal examinations instead. Pelvic ultrasound is the mandatory first-line investigation. It confirms the presence of the uterus and maps the initial location of the trapped blood collections. If the physical exam and ultrasound leave the specific location of the obstruction unclear, the diagnostic pathway diverges to magnetic resonance imaging. While a physical exam confirms that an obstruction exists, only precise imaging provides the spatial data required to differentiate a thin superficial membrane from deep structural dysplasia. Bringing the cross-section back, you can see why an MRI of the pelvis is strictly mandatory whenever a transverse vaginal septum is suspected. The MRI maps the precise anatomical site, measures the exact thickness of the fibrous septum, and rules out anomalies in the renal and urinary tracts, which are highly associated with this specific mesodermal failure. The imperforate hymen is a much simpler endodermal error. It is rarely associated with urinary anomalies and can be resolved rapidly with a localized cruciate incision to drain the tract. A cruciate incision will fail against a transverse vaginal septum. Because the septum is a thick, integrated fibrous band, it mandates complete, complex surgical excision and resection. Vaginal agenesis bypasses these immediate drainage procedures entirely, requiring a separate, comprehensive evaluation for combined Müllerian tract anomalies. The presenting symptoms of cryptomenorrhea are identical across these cases. Accurate diagnosis and safe surgical intervention require tracing the macroscopic pathology directly back to its dual origin embryological roots. The precise moment of fertilization sets an unalterable chromosomal blueprint into motion, rapidly triggering a highly complex cellular cascade. This development follows a tripartite system: chromosomal sex, which determines gonadal sex, which then dictates phenotypic sex, the internal and external genitalia. The father's Y chromosome is the decisive factor. Specifically, the SRY gene on the short arm of the Y chromosome functions as the testis determining factor, utilizing zinc as a micronutrient to activate the testicular pathway. While the absence of SRY leads to an ovarian pathway, both X chromosomes are required for proper ovarian maintenance. In Turner syndrome, a 45XO karyotype results in the degradation of ovaries into streak gonads. The final phenotypic architecture is built by a regulated cascade of anti-Müllerian hormone, testosterone, and DHT, interacting with competent hormone receptors. Mapping this healthy phenotypic dimorphism allows clinicians to reverse engineer and diagnose the specific molecular lesions responsible for ambiguous genitalia and disorders of sex development. At week 5 of development, both sexes share an identical bipotential genital ridge. Post 6 weeks, the SRY gene in an XY fetus activates SOX9 to form testes. In an XX fetus, the absence of this signal leads to ovaries, which remain hormonally silent during fetal life. In the XY pathway, fetal testes use two distinct cell populations. Sertoli cells, stimulated by FSH, produce inhibin B and anti-Müllerian hormone, or AMH. Leydig cells are initially driven by fetal HCG before luteinizing hormone takes over. AMH causes the Müllerian duct to regress in males, leaving only the prostatic eutrodrol. Simultaneously, Leydig cells produce testosterone, driving the Wolffian duct to differentiate into the epididymis, vas deferens, and seminal vesicles. In the XX pathway, a lack of AMH allows the Müllerian duct to persist, forming the fallopian tubes, uterus, and upper vagina. Absent testosterone causes the Wolffian duct to regress, leaving behind the epioophoron, paraoophoron, and Gartner duct. Internal genital formation does not require fetal estrogen. However, low estrogen states like Kallmann or Turner syndrome will result in a hypoplastic or infantile uterus later at puberty. Internal anatomy is therefore dictated by the presence per absence of two testicular hormones, AMH and testosterone. To masculinize external genitalia, testosterone converts to DHT via 5-alpha reductase. Both act through the same androgen receptor. Without androgens, structures follow the default female pattern. The genital tubercle becomes the clitoris, swellings become the labia majora, and folds become the labia minora. These structures are homologous. The male prostate correlates to the female Skene's glands, and the bulbourethral gland correlates to the superficial Bartholin gland. Testicular descent is guided by the gubernaculum, which is homologous to the female round ligament. On ultrasound, the appearance of testicular cords confirms testis development. Ambiguous genitalia, including clitoromegaly, micropenis, or labioscrotal fusion, mandates an immediate physical exam to check for palpable gonads. Adrenal androgens in 46XX fetuses do not cause true male external development. Therefore, palpable inguinal gonads suggest a 46XY karyotype, requiring definitive chromosomal typing. Congenital adrenal hyperplasia refers to inherited defects in adrenal steroid synthesis that disrupt the production of cortisol, aldosterone, and androgens. The pathology centers on the loss of cortisol, removing negative feedback on ACTH. In 21-hydroxylase deficiency, this block lowers aldosterone and cortisol, shunting ACTH drive into the androgen pathway. The results include salt wasting, hyponatremia, and hyperkalemia. In a 46XX fetus, excess adrenal androgens cause ambiguous genitalia, while 46XY infants remain male or appear virilized.
This is screened using 17-hydroxyprogesterone levels. Values below 200 are normal, while levels above 800 confirm the diagnosis. An 11-beta-hydroxylase deficiency also lowers cortisol, causing ambiguous genitalia in 46XX individuals. Conversely, a 17-alpha-hydroxylase block causes androgen starvation, leading to 46XY infants with ambiguous or female-looking genitalia. A 3-beta-HSD deficiency lowers aldosterone, cortisol, and testosterone, but increases DHEA. This causes ambiguous genitalia in both sexes, weak androgen exposure in XX fetuses, and testosterone deficiency in XY fetuses. P450 oxidoreductase deficiency involves a failure of the electron donor for multiple enzymes. This presents with ambiguous genitalia in both sexes, alongside skeletal anomalies like craniosynostosis. Prenatal management involves starting dexamethasone at 4 to 5 weeks to suppress fetal androgens. After a CVS at 10 weeks, treatment only continues if the fetus is an affected female. Congenital adrenal hyperplasia demonstrates how an upstream enzymatic block in the adrenal gland overwrites the chromosomal external phenotype through either androgen excess or starvation. In 46XY disorders of sex development, primary amenorrhea paired with a bilateral inguinal hernia is a classic indicator of undescended testes. Because undescended testes carry a risk of gonadoblastoma or germinoma, a gonadectomy is eventually required. In complete androgen insensitivity syndrome, or CAIS, testes and hormone production are normal, but androgen receptors are unresponsive. AMH regresses the Müllerian system, but because receptors cannot process testosterone or DHT, the Wolffian system fails, defaulting external genitalia to the female pattern. These patients present with a female phenotype, a blind-ending vagina, and no uterus. Their hormonal profile shows high LH, normal FSH, and male-range testosterone. At puberty, testosterone aromatizes to estrogen, resulting in breast development, but pubic and axillary hair remain scanty. Gonadectomy is typically delayed until breast development is complete. Partial androgen insensitivity, the most common cause of 46XY ambiguous genitalia, presents with clitoromegaly at birth and requires early gonadectomy to manage virilization risks. Swyer syndrome involves 46XY gonadal dysgenesis, often from an SRY mutation. The streak gonads produce no AMH and no testosterone. Because AMH is absent, a uterus is present. Because testosterone and DHT are absent, the external genitalia are female. This requires early gonadectomy and estrogen and progesterone replacement. In 5-alpha reductase deficiency, the testes and AMH production are normal, but the conversion of testosterone to DHT fails. This results in male internal anatomy and no uterus, but female external genitalia at birth. At puberty, a surge in testosterone causes rapid virilization and the appearance of clitoromegaly. These 46XY disorders demonstrate that even with functional testes, an inability to process or convert androgens locally prevents male phenotypic expression. Diagnosing these conditions requires cross-referencing the karyotype, the status of internal anatomy, like the uterus, and the timing of virilization. A 46XX newborn with ambiguous genitalia is most commonly a case of congenital adrenal hyperplasia. A 46XY patient who is female at birth but virilizes at puberty has 5-alpha reductase deficiency. A 46XY patient with primary amenorrhea, full breast development, and scanty hair
likely has complete androgen insensitivity. A 46XY patient with female genitalia and a confirmed uterus suggests Swyer syndrome. Biological sex development functions as an actively engineered contingent biochemical sequence. The anatomical default is female. Masculine dimorphism is achieved and maintained through uninterrupted hormonal signaling.
Female reproductive maturation follows a strict chronological sequence. When that biological clock stalls, it signals a deeper systemic error. Clinically, we define this failure as primary amenorrhea. The diagnosis applies if a patient reaches age 13 with no secondary sexual characteristics, or age 15 if those characteristics are present. To evaluate this, physicians rely on Tanner staging. The critical milestone to look for is Tanner stage 2, which marks the onset of breast budding. This specific marker is vital because breast development reliably precedes a first menstrual period by exactly 2 to 3 years. Primary amenorrhea itself is a symptom. To find the exact cause, we have to look at the patient's physical presentation and trace it back to the underlying biochemical reality. This diagram visualizes the hypothalamic pituitary ovarian uterine, or HPOU, axis. Menstruation is simply the final visible event of this complex neuroendocrine circuit. The sequence starts at the top. The hypothalamus releases pulsatile GnRH. That signal hits the anterior pituitary gland, which responds by secreting two gonadotropins, FSH and LH. These gonadotropins travel to the ovaries. FSH drives follicular growth and estrogen production, while LH triggers ovulation and the release of progesterone. Finally, estrogen and progesterone prepare the uterine endometrium. If the structural outflow tract is open, the cycle completes with menstruation. Because this pathway is strictly sequential, a single point of failure anywhere along the line will shut down the entire biological circuit. Let's model a failure at the top of the circuit. Here, either the hypothalamus or the pituitary gland fails to initiate the cascade. Without that initial burst of GnRH, the downstream levels of FSH and LH plummet. The ovaries remain completely unstimulated. Consequently, they produce zero estrogen. On physical exam, this lack of estrogen manifests as delayed or entirely absent breast development. We define this specific pattern as hypogonadotropic hypogonadism. The physical engine is intact, but it is starved of its neuroendocrine ignition spark. Now, let's shift the locus of failure to the third node. The brain is firing, but the ovaries are defective. Because the ovaries produce no estrogen, the system loses its negative feedback loop. The pituitary attempts to compensate by driving FSH and LH higher and higher, trying to force a response from gonads that cannot react. We classify this high gonadotropin, low estrogen state as hypergonadotropic hypogonadism. The most common cause is Turner syndrome. Patients with this condition have a 45XO karyotype, which causes the ovaries to develop into non-functional streaks of fibrous tissue. The genetic absence of the second X chromosome includes the loss of the SHOX gene, leading to pronounced short stature. Clinicians will also note a characteristic webbed neck and a broad chest. This karyotype also disrupts multiple organ systems. The diagnostic workup must heavily screen for severe comorbidities, particularly a bicuspid aortic valve, coarctation of the aorta, and renal anomalies. In Turner syndrome, the extreme elevation of gonadotropins on a blood test proves that the pituitary gland is functioning perfectly, but it is effectively screaming at an empty room. Managing Turner syndrome requires a strict protocol. After confirming the 45XO karyotype, physicians must secure an echocardiogram, a renal ultrasound, and complete thyroid screening. Because the height deficit is severe, growth hormone therapy must be initiated early, ideally before the patient reaches 8 years of age, to maximize final adult height. To simulate the missing ovarian function, the patient requires exogenous estrogen replacement. This artificially induces breast development and pubertal maturation. However, this creates a secondary risk. After 1 year of estrogen therapy, physicians must add progesterone to the regimen. Providing estrogen alone will continuously stimulate the uterine lining. Adding progesterone halts that unchecked growth, acting as a non-negotiable shield against endometrial hyperplasia and cancer. The diagnostic pathway diverges sharply for patients who present with primary amenorrhea but have normal breast development. Breasts indicate that the top 3 nodes are producing estrogen perfectly. The problem is structural. The first structural condition is Müllerian agenesis, or MRKH. This is a genetically 46XX female with fully functional ovaries, but during fetal development, the Müllerian ducts fail to form the uterus and upper vagina. Because her ovaries function normally, she produces estrogen, yielding normal breast development. She also produces normal levels of androgens, resulting in typical pubic and axillary hair. Compare this to complete androgen insensitivity syndrome, or AIS. This patient is genetically 46XY. They develop testes, which produce Müllerian inhibiting substance. This substance actively prevents a uterus from forming. These testes also produce male-range testosterone, but a severe receptor defect means the body's tissues cannot respond to it. Unable to act on the hair follicles, pubic hair remains scanty or entirely absent. Meanwhile, the excess testosterone is converted into estrogen via aromatization, which stimulates breast development. By simply checking for the presence or absence of pubic hair during a physical exam, a clinician can instantly differentiate a female anatomical defect from a male hormone receptor failure. The final failure point requires an intact neuroendocrine circuit and fully formed uterus, but introduces a physical barricade at the hymen or vaginal septum. This creates a condition called cryptomenorrhea. The patient is menstruating internally on a regular monthly cycle, but the blood is trapped behind an anatomical seal. The trapped blood accumulates inside the uterus, creating a mass known as hematometra. The patient presents with primary amenorrhea, but suffers from acute cyclic pelvic pain. The biological machine is operating flawlessly. The pathology is entirely driven by retrograde mechanical pressure. This diagram synthesizes all of these nodes into a precise bedside diagnostic algorithm. First, verify the Tanner criteria, rule out pregnancy, and establish baseline FSH and LH levels. If breasts are absent, the hormone levels dictate the diagnosis. Low FSH and LH point to a central failure in the brain, while high levels indicate ovarian failure, such as Turner syndrome. If breasts are present, the neuroendocrine system is working. A pelvic ultrasound is then used to determine if the uterus is intact. If the uterus is present, cyclic pain points to cryptomenorrhea. If the uterus is absent, the presence of pubic hair identifies MRKH, while scanty hair isolates androgen insensitivity syndrome. Primary amenorrhea is a symptom. By mapping the patient's physical presentation directly to their physiology, a clinician can reverse engineer the exact biological locus where the reproductive sequence stalled. Evaluating gynecologic pathology requires navigating a complex spatial matrix. Clinicians must gather distinct data from thick muscular walls, inner collapsed cavities, immediate adnexal structures, and the broader peritoneal space. To map these overlapping compartments, we rely on a specific sequence of diagnostic modalities: ultrasound, saline infusion sonography, MRI, hysterosalpingography, hysteroscopy, laparoscopy, and PET scans. As we look at this 3D model, lighting up distinct layers of the pelvic anatomy, you can see the diagnostic problem. Retrieving accurate data from each of these compartments requires matching the exact biophysics of a modality to the target tissue type. Non-invasive acoustic and magnetic imaging tools are strictly governed by the physical limits of sound waves and magnetic resonance. When those limits are reached, the clinician is forced to physically enter the anatomy using invasive, fluid-distended endoscopy. Because no single diagnostic test can capture every compartment simultaneously, resolving clinical uncertainty requires systematically rotating through different modalities to bypass the physical blind spots of the previous tool. Ultrasound serves as the universal baseline for evaluating abnormal uterine bleeding, fibroids, and general pelvic pathology. It is entirely non-invasive and perfectly safe during pregnancy. This diagram shows the core biophysical rule governing all sonography. The top waveform demonstrates how low frequency yields deep tissue penetration but low resolution. The bottom waveform illustrates the exact opposite. High frequency returns highly detailed, dense data, but stops at a shallow depth. Transabdominal sonography utilizes a 3 to 5 MHz transducer. This low-frequency setting deliberately sacrifices high-resolution detail to ensure acoustic waves can penetrate deeply into the pelvis.
To function, this transabdominal approach absolutely mandates a full bladder. The trapped liquid acts as an acoustic window, allowing the low-frequency sound waves to travel cleanly into the deeper anatomical structures. Transvaginal sonography takes the opposite physical approach. It utilizes a 5 to 10 MHz transducer and bypasses the liquid window entirely, applying the probe directly to the tissue to retrieve high-density data from the immediate adnexa. Because the transducer operates so close to the target tissue, transvaginal sonography requires a completely empty bladder, sacrificing global depth to achieve precise, localized detail. Acoustic physics forces a strict clinical choice between capturing broad, deep anatomical context and retrieving high-resolution, immediate views. Clinicians decode these acoustic reflections to map the anatomy. Normal endometrium reflects sound efficiently, appearing as an echogenic white line, while the denser myometrium returns a hypoechoic gray signal. Normal unruptured ovarian follicles appear entirely black because their fluid content is anechoic, meaning it absorbs the sound waves rather than reflecting them. This visualization tracks the specific thresholds required to diagnose polycystic ovary syndrome based on those black acoustic markers. While older diagnostic criteria required identifying 12 or more follicles, updated American and European criteria now require counting 20 or more distinct follicles. High-resolution transvaginal access has strict anatomical limits. The approach can be difficult or completely impossible in virginal patients or individuals with severe vaginal narrowing. Additionally, postmenopausal atrophy can alter the vaginal architecture enough to physically block transvaginal transducer placement. When high-frequency sound waves either fail to differentiate dense layers or cannot physically reach the target, the clinician must deploy a different biophysical tool. Magnetic resonance imaging is the gold standard for mapping congenital malformations and executing detailed soft tissue characterization. On a standard T2-weighted sequence, the normal spatial radiodensity closely mirrors ultrasound contrast. The endometrium is hyperintense, appearing bright white, while the myometrium remains hypointense and gray. T2-weighted sequences are particularly critical because they provide the sharpest contrast required to evaluate the ovaries. Looking at this precise caliper measurement, we can evaluate the transitional zone between the endometrium and myometrium. A boundary layer under 8 mm is normal. If that thickness exceeds 12 mm, it supports a diagnosis of adenomyosis. MRI provides the structural mapping necessary for oncologic staging. It dictates the surgical approach by precisely measuring myometrial invasion in endometrial cancer and tracking parametrial invasion in cervical carcinoma. For highly specific oncologic tracking, particularly nodal metastases in ovarian cancer, the investigation of choice isolates metabolic activity using a PET scan. While MRI maps solid tissue architecture flawlessly, it lacks the dynamic contrast necessary to evaluate empty, collapsed potential spaces found deep inside the uterus. The normal uterine cavity is not an open room, it is a collapsed potential space. The opposing walls press against each other, rendering small intracavitary lesions invisible to standard sonography. Watch as saline is instilled through a catheter directly into the space. The fluid mechanically distends the cavity, physically forcing the walls apart to reveal a small mass hanging inside. This is saline infusion sonography. The saline introduces a purely anechoic, black background, radically improving the acoustic contrast against the gray tissue walls.
By artificially creating this contrast window, saline infusion sonography becomes the superior targeted test for isolating endometrial polyps and submucous fibroids. Manipulating the acoustic environment with fluid solves central cavity visualization, but it yields zero diagnostic data regarding the actual patency of the fallopian tubes. To map the narrow lumens extending outward from the cavity, clinicians rely on hysterosalpingography. This radiologic study injects water-soluble iodinated dye directly into the uterus using a Leach-Wilkinson cannula. The clinical objective is twofold: outline physical defects within the cavity and prove tubal patency by observing the dye spill freely into the peritoneal space on serial X-rays. This test runs on a strict timeline. It must be performed in the pre-ovulatory phase, precisely on days 7 to 10 of the menstrual cycle, to guarantee the flush of dye does not disturb an unrecognized early pregnancy. The procedure carries absolute contraindications. It cannot be performed if the patient has a positive pregnancy test, active pelvic infection, or current genital tuberculosis. In the case of tuberculosis, anti-tubercular treatment must be completed before imaging begins. These cavity outlines illustrate how we interpret the structural blockages. A smooth filling defect points to a polyp or a submucous fibroid. Conversely, irregular, moth-eaten multiple defects indicate intrauterine adhesions or Asherman syndrome. The dye injection frequently triggers cornual spasm, a muscular contraction where the fallopian tube connects to the uterus. This spasm can mimic a complete tubal block, causing a frustrating false positive obstruction. Hysterosalpingography can be a painful procedure that purely maps the internal dimensions of the lumens. It provides absolutely no information about the external surfaces of the uterus or the tubes. To transition from shadow outlines to direct physical intervention, the clinician moves the patient into the lithotomy position for hysteroscopy. During the procedure, the operator faces the patient's head end. Because of this specific approach angle, the left and right visual field on the monitor will appear perfectly mirrored relative to the patient's true anatomy. Direct visualization still requires separating the walls of the potential space. While carbon dioxide gas is used for purely diagnostic looks, active therapeutics demand continuous liquid distension media. This logic tree charts out the strict pairing of fluid and electricity. Electrolyte-rich media, like normal saline, conducts electricity and mandates the use of bipolar instruments only. Electrolyte-deficient media, such as glycine or sorbitol, prevents dispersion and allows for both monopolar and bipolar surgical tools. Pumping liquid into a vascular open tissue bed creates immediate systemic risk. The central safety metric is the fluid deficit, calculated precisely as the total fluid infused minus the total fluid recovered. When using an electrolyte-rich medium, surgery must stop at a 2.5-liter deficit. Because electrolyte-deficient media carry a severe risk of hyponatremia and water intoxication, the procedure must be terminated at a strict 1-liter deficit. Active infection, obstructing cervical cancer, or pregnancy absolutely contraindicate hysteroscopy. Cardiopulmonary disease presents a particular barrier, as any fluid overload risks triggering pulmonary edema or acute heart failure. Hysteroscopy grants unparalleled internal visualization and surgical capability, but forces the clinician to execute the procedure under strict hemodynamic time limits, leaving the external pelvic cavity completely unexamined. To evaluate the external surface of the uterus and the surrounding pelvic architecture, clinicians utilize laparoscopy. Operating from the head end and facing the patient's feet, the surgeon's visual field naturally matches the patient's true left and right side. This external access makes laparoscopy the definitive investigation of choice for identifying complex pathologies outside the uterine walls, including endometriosis, chronic pelvic pain, and pelvic inflammatory disease. As we observe this tubular structure, we see chromoperturbation in action. Dye injected from below travels through the reproductive tract and spills freely from the fimbriae, making laparoscopy the absolute gold standard for confirming tubal patency. Combining laparoscopy with hysteroscopy allows clinicians to resolve false bilateral corneal blocks seen on previous imaging and precisely map out ambiguous congenital malformations. Executing both external and internal endoscopy provides total spatial visualization, systematically bypassing the physical barriers that constrain non-invasive scans. Diagnostic precision in gynecologic practice relies on instantly deploying the correct physical modality to match the specific tissue target and anatomical constraint. Ultrasound operates as the universal first-line evaluation tool, while MRI provides the undisputed gold standard for mapping soft tissue invasion and deep structural malformations. Tubal patency is mapped first by hysterosalpingography between day 7 and 10 of the cycle, but definitive confirmation relies entirely on laparoscopy with chromoperturbation. For intracavitary spaces, saline infusion sonography isolates polyps and submucous fibroids, while hysteroscopy provides direct surgical access, governed entirely by strict 1 or 2.5-liter fluid deficit limits. This decision matrix maps out the complete algorithm. Resolving complex pathology requires a relentless progression through acoustics, magnetics, radiopaque dyes, and endoscopic optics. Clinical management of the female reproductive tract requires a precise map of patient anatomy. and that map is drawn long before physical structures form. We verify this baseline using karyotyping, the most definitive method for sex determination. A normal female karyotype registers as 46XX, while a normal male registers as 46XY. This formulaic breakdown visualizes the state of the X chromosomes at the cellular level. To calculate the number of inactive X chromosomes, known as bar bodies, you subtract 1 from the total number of X chromosomes. A typical 46XX female produces exactly 1 bar body, while a 46XY male produces 0. When the physical expression of these genetics deviates, clinicians encounter ambiguous genitalia. In these presentations, the external anatomical landmarks do not allow for a clear clinical assignment of sex at birth. Patients presenting with these anatomical variations are categorized and treated under the clinical umbrella of disorders of sexual development, or DSD. The entire field of gynecological anatomy, from standard variations to complex congenital malformations, is built entirely on these chromosomal blueprints. The genetic code dictates the physical development that follows. During that development, the internal reproductive organs arise from 2 distinct embryological tissues. Structures derived from the genital duct, such as the upper reproductive tract, originate strictly from mesoderm. The lower portion of the system emerges from a completely separate source. Structures originating from the genital sinus dictate the formation of the lower genital tract, specifically the lower vagina. Pinpointing the exact developmental source reveals that the vaginal bulb, a specialized structure of the genital sinus, drives the formation of this lower vaginal segment. Tracing these structures back to their distinct embryological roots is a mandatory clinical exercise. The precise origin tissue determines the specific patterns of congenital anomalies a patient might develop, and dictates the exact classification of tumors that can arise there later in life. Mapping the blood supply of the mature reproductive tract begins high in the abdomen. The ovarian artery branches directly off the abdominal aorta at the level of the L2 vertebra, creating a long vertical descent into the pelvis. Looking at this map of the posterior abdominal vasculature, we observe a highly asymmetric venous drainage system for the ovaries. The return pathways on the right and left sides do not match. The right ovarian vein takes a direct route, emptying straight into the inferior vena cava. The left ovarian vein, however, must first route into the left renal vein before reaching the central circulation. The neurological wiring for this region descends alongside the vasculature. The T10 and T11 nerve roots feed through the ovarian plexus, supplying the ovary, the lateral part of the fallopian tube, and the broad ligament. The fallopian tube itself relies on a dual arterial supply. The uterine artery perfuses the medial 2/3, while the ovarian artery supplies the remaining lateral 1/3. As demonstrated by this localized mass expanding outward against a biological boundary, an unruptured ectopic pregnancy places immense mechanical stress on the fallopian wall. The physical stretching of this highly innervated tissue is the direct cause of severe pain. Because of the specific neural pathways feeding the tube, this distress does not present as localized pelvic pain. Instead, it is referred upward along the T11, T12, and L1 dermatomes. The lymphatic drainage splits along similar lines. The vast majority of the fallopian tube drains high into the para-aortic lymph nodes. However, the intramural portion of the tube and the round ligament drain downward into the superficial inguinal nodes. The segmented neurovascular wiring of this upper tract dictates exactly where and how catastrophic emergencies, like an expanding ectopic mass, will present in a clinical setting. Moving centrally, the uterus draws 80% of its blood volume from the uterine artery, a direct branch of the internal iliac's anterior division. The remaining 20% arrives via an anastomotic branch from the ovarian artery. This cross-section of the uterine wall illustrates the sequential branching of the arterial tree. The high-pressure flow first enters the outer layer through the arcuate arteries. From the arcuate network, the blood channels inward into the radial arteries, penetrating deeper into the myometrium. The radial arteries then narrow and transition into the basal arteries, supplying the permanent bottom layer of the endometrium. Finally, the network terminates at the innermost spiral arteries. These specific vessels undergo cyclical necrosis and shedding. They are the direct source of menstrual bleeding. Approaching the uterus, the main uterine artery crosses directly over the ureter at a point roughly 2 centimeters lateral to the internal cervical os.
Surgeons memorize this exact crossing as water under the bridge, where the ureter is the water and the artery is the bridge. During a hysterectomy, this relationship dictates the primary surgical rule. The uterine artery must be clamped as close to the physical edge of the uterus as possible to avoid lacerating or ligating the underlying ureter. This main arterial pathway is also the access point for uterine artery embolization, a targeted endovascular procedure used to arrest postpartum hemorrhage and shrink fibroids by cutting off their blood supply. The orientation of the uterus dictates how these structures sit in the pelvis.
An anteverted uterus has its fundus pointing anteriorly toward the pubic symphysis, while a retroverted fundus points posteriorly toward the rectum. The round ligament, running from the uterine cornua through the abdominal wall and superficial inguinal ring to terminate in the labia majora, provides the constant forward mechanical pull required to maintain that anteverted position. The tight spatial intersection of the ureter and the uterine artery constitutes the most severe iatrogenic risk zone in the female pelvis. It is the defining anatomical landmark that governs all hysterectomy protocols. Below the uterus, the vascular network separates. The vaginal artery branches directly from the internal iliac system. It is distinctly separate from, and not a branch of, the uterine artery. The vaginal innervation is similarly divided. The upper segment receives input from the S2 through S4 nerve roots, while the lower segment is innervated by the pudendal nerve. Lymphatic clearance follows this same split. The upper two-thirds of the vagina drains internally to the internal iliac nodes, while the lower one-third, along with the external vulva, drains outward to the superficial inguinal nodes. At the cellular level, the type of tissue lining these structures predicts their oncological risks. The endocervix, hidden inside the cervical canal, is lined by columnar epithelium. Malignant transformation here results in adenocarcinoma. The visible outer surface, the exocervix, is lined by stratified squamous epithelium. Cancer arising in this specific tissue presents as squamous cell carcinoma, which accounts for the vast majority of all cervical cancers. This non-keratinized stratified squamous epithelium continues downward, forming the continuous lining of both the vaginal vault and the hymen. This microscopic map of the Bartholin gland separates the structure into 3 distinct epithelial zones. The deep gland itself is lined by cuboidal epithelium, meaning tumors originating here are adenocarcinomas. Moving outward, the transport duct is lined by transitional epithelium. Malignancy in this specific segment generates transitional cell carcinoma. Finally, the external opening of the gland is lined by squamous epithelium, making it capable of generating squamous cell carcinoma. These microscopic, abrupt transitions between cell types function as strict territorial borders. The exact location of a malignant mutation determines exactly which type of cancer will emerge. In clinical practice, evaluating this anatomy begins with the speculum examination. The immediate visual landmarks include the vaginal walls with their characteristic rugosities, the smooth exocervix, and the central opening of the external os. Clinicians rely on distinct color profiles during inspection. The supravaginal endocervix, normally hidden from view, appears red due to its columnar lining, while the visible portio vaginalis of the exocervix presents as pale pink. This split-screen comparison shows how parity permanently alters cervical anatomy. In a nulliparous female, who has never given birth, the external os maintains a tight pinpoint shape. In a multiparous female, mechanical dilation permanently stretches the opening into a transverse slit. This external os serves as the gateway opening into the vagina, while the internal os marks the tight upper boundary connecting the cervical canal into the main cavity of the uterus. The speculum exam provides the bridge between external evaluation and internal anatomy, but the findings require interpretation, as baseline structures are permanently modified by physiological events like parity. Accessing the upper tract requires specialized mechanical instruments. The SIM speculum features a broader and a narrower blade, requiring insertion at a right angle to effectively retract the posterior vaginal wall. Because of its design, it typically requires an assistant to hold it in place. To secure the opposing tissue, the anterior vaginal wall retractor is deployed. It is instantly identifiable by its large terminal loops and transverse serrations, distinct from instruments featuring sharp or blunt edges. As we see in this close-up of interlocking ratchet teeth, the Vulcellum uses a specialized locking mechanism. its curved blades end in sharp, rat-like teeth that bite into and secure the anterior lip of the cervix, a grip exclusively utilized in non-pregnant patients. This technical layout compares diagnostic tools. The uterine sound is engineered with a distinctive curve, precise depth calibrations, and a rounded olive tip. Clinicians use it to safely measure the depth of the cavity and confirm if the uterus is anteverted or retroverted. In contrast, the bladder sound serves a different diagnostic function and physically lacks both the protective olive tip and the measurement calibrations found on the uterine model. If the internal os requires opening, clinicians use a series of smooth cervical dilators. The strict protocol requires sequential advancement from the smallest diameter up to the largest, carefully expanding the tissue up to the internal os. Following dilation, a curette is introduced into the cavity. The decision to use a blunt curette versus a sharp curette is dictated entirely by the patient's pregnancy status to prevent perforation of the myometrial wall. Every curve, ratchet, and calibration mark on these tools is an engineered solution, explicitly designed to navigate the strict anatomical constraints of the female pelvis safely.
We are going to deconstruct the female reproductive system, mapping the exact spatial and functional architecture of the uterus and the uterine adnexa. This system operates as a continuous physiological axis, running from the lateral pelvic wall straight to the midline. To understand how it functions, we will chart the gross dimensions, trace the embryonic derivations, map the fascial anchors, and examine the cellular histology. We will move laterally to medially, starting at the ovary, tracking through the fallopian tube, and terminating inside the uterine architecture. Navigating this structural continuity is the absolute prerequisite for predicting physiological outcomes and executing safe surgical interventions. This wireframe visualizes the ovary. Its baseline dimensions are 3 by 2 by 1 centimeters, with a normal volume of 6 to 7 cubic centimeters. Expanding to 10 cubic centimeters or greater supports a clinical diagnosis of polycystic ovary syndrome. Spatially, it sits within the ovarian fossa of Waldeyer on the lateral pelvic wall. It is a posteriorly placed organ, meaning if it is clearly visible in an anatomical image, the viewpoint is from the posterior aspect. During fetal development, the ovary descends into the pelvis, guided by the gubernaculum, stopping only when the expanding uterus blocks its path. This gubernaculum eventually forms two distinct attachments, the round ligament and the ovarian ligament, connecting to the uterine cornu. Further anchoring the system is the infundibulopelvic ligament, also called the suspensory ligament. This connects the ovary to the lateral pelvic wall and serves as the primary conduit for ovarian vessels and nerves. This creates a strict surgical rule. During a hysterectomy where the ovary must be preserved, cutting the infundibulopelvic ligament will sever the ovarian blood supply. This diagram plots the tight spatial relations surrounding the ovary. Superior and anterior to the organ is the external iliac artery. Inferiorly, we find the ureter and the internal iliac artery. Positioned laterally is the obturator nerve. Because of this exact proximity, a large expanding ovarian mass can physically compress the obturator nerve, presenting clinically as referred pain along the medial side of the thigh. The ligamentous network surrounding the ovary acts simultaneously as a vascular lifeline and a boundary map for avoiding iatrogenic injury. Moving inward to the microarchitecture, the outermost layer is a single layer of cuboidal surface epithelium, followed immediately by the tunica albuginea. This cross-section reveals two primary functional zones. The outer cortex is populated by developing follicles, while the inner medulla serves as the highly vascular core. Deep within this medulla are hilar cells, the biological homologs to interstitial cells in the testes. Rarely, these hilar cells undergo malignant transformation. Because they actively secrete androgens, tumors here produce masculinizing clinical effects. Returning to the cortex, we find the primary unit of reproduction, the follicle. A follicle is a primary oocyte surrounded by supporting follicular cells. This timeline charts the distinct cellular stages of maturation. The primordial follicle begins with flattened cells. In the primary stage, these become cuboidal granulosa. By the secondary stage, the oocyte is encased in multiple layers of granulosa cells. Next is the antral stage, marked by the sudden appearance of a fluid-filled cavity.
This peaks at the Graafian follicle stage, the most mature form, spherical, and reaching 20 millimeters in diameter. Differentiating alongside this are supporting structures. Theca cells divide into theca interna and externa, while a bridge of granulosa cells, the cumulus oophorus, separates the oocyte from the antral fluid. This highly coordinated, physically expansive sequence of folliculogenesis is strictly confined to the cortex, preparing the biological environment for ovulation and gestation. Once released, the ovum enters the 10-centimeter fallopian tube. This pathway receives the ovum, acts as the site of fertilization, and transports the zygote. This diagram maps the tube from medial to lateral into 4 distinct parts. Inside the uterine wall is the interstitial part. It is the narrowest zone, functions as the anatomical sphincter, and is the exact target site for hysteroscopic tubal ligations utilizing the Ure device. Moving laterally, we hit the isthmus. This second narrowest section acts as the physiological sphincter and is the standard site for laparoscopic tubal ligation. Further out is the ampulla. It is the widest and longest segment, containing maximum mucosal folds, making it the usual site for fertilization or ectopic pregnancies. Finally, the tube terminates at the infundibulum, a funnel-shaped opening bordered by fimbriae. Lining this entire pathway is a specialized epithelium containing distinct structures called PEG cells, whose exact physiological function remains largely unknown. Pathogens target specific zones along this route. Genital tuberculosis heavily involves the ampulla and can cause bilateral cornual blocks, while gonococcal infections typically trigger a fimbrial block. To evaluate blockages in any of these zones, hysterosalpingography is the gold standard investigation for testing tubal patency. The fallopian tube is a highly segmented sequence of sphincters and chambers. These structural variations dictate exactly where fertilization succeeds and where pathology strikes. At the center of the axis is the macroscopic uterus. It is a pear-shaped organ measuring 3 by 2 by 1 inches, but its mass scales from a baseline of 60 grams up to 1,000 grams during pregnancy. This expansion capacity relies on tissue composition. The main bulk is smooth muscle, whereas the lower cervix consists primarily of connective tissue. Because the uterine body is dominated by smooth muscle, progesterone effectively prevents preterm labor by relaxing the myometrium across this massive volume of tissue. Looking at this top-down schematic of the uterine cornua, we find 3 structures attaching here, arranged strictly from anterior to posterior. We remember them with the mnemonic RDO, the round ligament, the fallopian tube, and the ovarian ligament. Confusing these 3 structures is a primary cause of failed tubal ligations. To avoid mistakenly ligating the round or ovarian ligaments, the fallopian tube must be definitively traced back from the fimbrial end. The rest of the uterus divides into distinct zones. The dome-shaped fundus sits above the cornua, while the central body houses true uterine fibroids. The lower cervix serves as the origin point for extrauterine fibroids. The uterine cavity itself is merely a potential space. Normally, its anterior and posterior walls lie flush. It holds a non-pregnant volume of roughly 10 milliliters, expanding up to 5 liters at term, appearing triangular in a coronal view, but slit-like in a sagittal section. Because walls naturally collapse, excessive surgical curettage can leave raw opposing surfaces. Healing together creates intrauterine adhesions known as Asherman syndrome. The unique geometry and muscle dominance of the uterus allow for extreme spatial scaling while maintaining precise anatomical borders. This chart visualizes how the lower boundary of the uterus is dynamic. The cervix to corpus ratio shifts from 2 to 1 before puberty to 1 to 2 at puberty, stretching to 1 to 4 during reproductive age, and reverting to 1 to 1 after menopause. The anatomical internal os is the physical point where the broad cavity narrows into the cervical canal. The histological internal os is the distinct microscopic boundary where the endometrial lining changes to cervical lining. Trapped exactly between the anatomical os above and the histological os below is the isthmus. In a non-pregnant female, it measures half a centimeter. At term, it stretches to 5 centimeters to form the lower uterine segment. During labor, the cervix undergoes effacement. It is taken up into the lower uterine segment, so the 2 structures combine to create a full 10-centimeter opening.
Externally, the anterior peritoneum reflects from the bladder onto the uterus exactly at the isthmus, marking the lower uterine segment. Posteriorly, the reflection between the uterus and rectum forms the pouch of Douglas, extending deeply to the upper one-third of the posterior vagina. The cervico-uterine boundary actively changes shape throughout life, acting as the definitive roadmap for lower segment surgical entry. Zooming into the microlayers of the uterine wall, we find three distinct strata: the inner endometrium, the middle myometrium, and the outer serosa. This cross-section shows the inner endometrium deconstructing into three subzones. The compacta and spongiosa tightly group to form the functional layer. This combined layer is entirely shed during menstruation, leaving only the zona basalis behind to regenerate the tissue. This regeneration drives massive thickness changes. The endometrium measures 1 to 2 millimeters immediately post-menses, scales up to a maximum of 16 millimeters in the secretory phase, and shrinks to under 4 millimeters after menopause. Just beneath this cycling lining lies the thick, smooth muscle of the myometrium, which houses a specialized middle layer termed the living ligator. Its muscle fibers run in a distinct crisscross pattern. After placental delivery, this biological net tightly compresses the traversing blood vessels to forcefully arrest postpartum bleeding. The uterine wall is an autonomous regulatory machine, cyclically rebuilding its inner lining for implantation while deploying a built-in muscular tourniquet to guarantee maternal survival. Zooming out from the cellular level, the continuous pathway from the lateral pelvic wall to the midline stands as an exquisitely engineered biological sequence. The system operates through distinct functional zones: the androgen-secreting ovarian medulla, the perfectly segmented physiological sphincters of the fallopian tube, and the autonomous hemostasis of the living ligator. Surrounding this machinery is a network of high-stakes surgical landmarks, demanding precise identification of the vulnerable obturator nerve, the vital infundibulopelvic ligament, and the strict anatomical order of the RDO structures at the uterine cornua. From the deep peritoneal reflection of the pouch of Douglas down to the microscopic architecture of the myometrium, absolute spatial mastery of the ovarian uterine axis is the non-negotiable foundation for diagnostic and surgical excellence.
The lower female reproductive tract operates as a continuously remodeling, hyperdynamic structure. Memorizing its macroscopic shape is insufficient. To understand how this system actually functions, we have to map its hidden connective tissues, track its histological transitions, and isolate the exact biochemical inputs that control its resident microbiome. Mastering this specific microarchitecture is the only reliable way to anticipate and manage severe clinical pathologies. Invisible cellular changes dictate the exact site of cervical oncogenesis, and the physical alignment of connective tissue determines whether a cervix can withstand the mechanical forces of labor. In obstetrics and gynecology, gross anatomy and microecology are completely inseparable. Anatomically, the cervix is the lowermost segment of the uterus. It communicates upward with the uterine cavity through the internal os, and downward with the vagina through the external os. Though it is contiguous with the uterus, its composition is radically different. The uterus is a powerful muscular organ, but the cervix is built almost entirely from a dense, collagen-rich connective tissue matrix. It contains only 10 to 15% smooth muscle fibers. This high concentration of collagen is responsible for the mechanics of labor effacement. To allow a fetus to pass, the cervix must shorten and soften. It does this by physically breaking down its collagen matrix. The tissue absorbs water, causing the remaining fibers to swell, separate, and ultimately yield. Clinically, the cervix is divided by visibility. The endocervix lines the internal canal and remains hidden, while the exocervix projects into the vaginal vault and presents as a pink surface during a standard speculum exam. Looking at this comparative graphic, we can see how parity permanently alters the macroscopic shape of the external os. A nulliparous female presents with a pinpoint or circular opening, while a multiparous female retains a permanent transverse slit. The unique collagenous composition of the cervix directly engineers its ability to withstand the extreme mechanical forces of a growing pregnancy and eventually yield to the forces of labor. The structural division between the inner and outer cervix is marked by a sharp histological border. The hidden endocervix is lined by a single layer of columnar epithelium, while the exposed exocervix is covered by stratified squamous epithelium. At birth, the squamo-columnar junction sits at the external os. At puberty, rising estrogen pushes the squamous epithelium upward. This migration leaves behind the transformation zone. Due to active metaplasia, this highly unstable area is the most common site for cervical squamous cell carcinoma. Cervical adenocarcinoma follows a different etiology. It arises directly from the glandular columnar cells of the endocervix, entirely separate from this transformation process. Sometimes the red endocervical epithelium moves in the opposite direction, pushing outward past the external os. This physiological state is called ectropion or eversin. Ectropion is driven by states of high estrogen. It is a highly predictable, standard physiological presentation during pregnancy. The clinical consequence of ectropion is fragility. The exposed, single-layer columnar cells bleed easily, frequently resulting in postcoital bleeding. Because it is a benign physiological response to estrogen, no biopsy is indicated. The continuous, hormonally driven cellular metaplasia across the cervix creates an inherent, anatomically localized window where cancer is most likely to develop. The descending cervical artery, a branch of the uterine artery, anchors precisely at the 3 and 9 o'clock positions. Administering a paracervical block here carries extreme risk of severe vascular hemorrhage. Safe injection zones are shifted to 2, 4, 8, and 10 o'clock. The lymphatic drainage pathways of the cervix follow a specific, predictable route, easily tracked using the acronym HOPE: hypogastric, obturator, paracervical, and external iliac nodes. The critical oncological rule here is a strict negative. The cervix does not drain into the superficial inguinal lymph nodes. If those superficial nodes show malignant involvement, it guarantees stage 4B distant metastasis. Final topographical constraints include the neural supply, governed by sacral roots S2 through S4, and the unequal peritoneal draping. The anterior surface lacks peritoneal coverage entirely, while the posterior surface is covered. Memorizing these exact spatial coordinates is a clinician's only reliable defense against catastrophic iatrogenic injury during blind procedures. Below the cervix sits the vagina, a fibromuscular tube lined with characteristic transverse folds called rugosities, which reliably identify the mucosal surface. The tube is asymmetrical. Its posterior wall is approximately 2 centimeters longer than its anterior wall. This sagittal vector map shows the internal spatial orientation. The vagina intersects the cervix at a strict 90-degree angle, while maintaining a 45-degree offset from the horizontal plane of the body. Where the vagina meets the cervix, it forms 4 surrounding recesses known as fornices. Because of the elongated posterior vaginal wall, the posterior fornix is structurally the deepest of the 4. This depth pushes the upper posterior third of the vagina directly against the peritoneum, creating a specific recess known as the pouch of Douglas. This schematic demonstrates coldocentesis. A needle is passed through the deep posterior fornix, piercing the vaginal wall to gain direct access to the pouch of Douglas. The primary clinical indication for this procedure is to aspirate free fluid, allowing a physician to rapidly confirm a ruptured ectopic pregnancy. The unique angulation and elongated depth of the posterior vagina engineer a critical non-surgical diagnostic window directly into the deep pelvis. Histologically, the vagina presents a counterintuitive fact. Despite maintaining a constant level of moisture, its non-keratinized stratified squamous epithelium possesses 0 native glands. All vaginal secretions are imported. The fluid originates superiorly from the cervix and endometrium and inferiorly from the Bartholin glands during intercourse. Systemic estrogen locks into epithelial cells, driving the deposition of glycogen. The resident microbiome takes over. Doderline bacilli consume these glycogen stores, converting them entirely into lactic acid. This conversion maintains a highly protective acidic vaginal pH of 4.0 to 4.5 during reproductive years. Because this environment is strictly dependent on estrogen, the pH shifts predictably across life stages. In prepuberty and menopause, low estrogen results in an alkaline environment.
During pregnancy, peak estrogen drives the pH into an even deeper acidic state. We can assess a patient's systemic endocrine status directly by sampling vaginal cytology from the upper lateral wall, which is the most hormonally sensitive region. The cytology presents in 3 distinct states. An estrogen-dominant system produces superficial, eosinophilic pink cells. Progesterone dominance yields intermediate, basophilic blue cells. If no hormone dominates, the smear shows parabasal cells with distinctively hazy borders. The vaginal microenvironment operates as a highly responsive, continuous barometer of a patient's systemic endocrine health. The gross structural coordinates of the lower reproductive tract dictate strict clinical boundaries. The clock face arterial supply creates rigid exclusion zones for anesthetics, and the deep posterior fornix provides a precise diagnostic window into the pelvic cavity. At the microscopic level, dynamic migrating histology at the squamo-columnar junction continuously drives local oncogenic risk. And underpinning it all, the microbiome hormone axis acts as the invisible engineer of the tract's protective, acidic ecology. True clinical mastery requires abandoning the view of anatomy as a static textbook drawing. It must be assessed and treated as a continuously remodeling neurovascular and biochemical ecosystem. This wireframe maps the female external genitalia in the lithotomy position, collectively called the vulva or pudendum. Diagnosing vulvovaginal lesions requires coordinate-based surface anatomy. Moving superficial to deep, we map the labia, the vestibule's 6 openings, and finally the superficial perineal pouch and Bartholin gland. Viewing the vulva through this spatial grid organizes the differential by anatomical localization, which then dictates the specific requirements for histopathological workup or surgical intervention. The most superior boundary is the mons pubis. This is a prominent fat-containing eminence sitting directly over the pubic symphysis. Developmentally, the mons pubis becomes covered with hair at puberty. The appearance of this pubic hair corresponds directly to Tanner stage 3 and is driven by local androgenic activity. Moving inferiorly, this anatomical map isolates the labia majora. Histologically composed of standard skin, the layers contain active hair follicles, sweat glands, sebaceous glands, and subcutaneous tissue, meeting posteriorly at the posterior commissure. Because of their dense cellular makeup and subcutaneous padding, the labia majora act as a standard physiological perimeter, shielding the highly specialized, delicate tissues positioned deeper within the vulva. Positioned directly medial to the labia majora are the labia minora. These inner lips typically measure between 1.5 to 2 centimeters in length. Unlike the majora, their cellular structure is specialized. They are strictly hairless and contain absolutely 0 sweat glands, though they do retain active sebaceous glands. The labia minora also serve an anchoring function for the clitoris, the primary female erectile organ. The minora fold around it, creating the prepuce superiorly and the frenulum inferiorly. This microscopic cross-section reveals a structural division. The medial surface is non-keratinized epithelium, while the lateral is keratinized. Their exact border is the heart line, the highest risk primary site for vulvar cancer. The labia minora operate as a volatile histological frontier, making visual inspection of this specific boundary a mandatory step in oncological screening. Moving into the vestibule, bounded by the clitoris, fourchette, and inner lips, we find 6 specific openings. Anteriorly, the central urethral opening is flanked by paired Skene glands. Fourth is the vaginal introitus, guarded by the hymen. If a patient presents with primary amenorrhea and cyclic pelvic pain, the anatomical findings often reveal an imperforate hymen, a complete membrane fusion that entirely obstructs menstrual outflow. The final 2 openings are located posterolaterally. These are the paired ducts of the Bartholin glands. Directly behind the introitus lies a shallow depression called the fossa navicularis. Moving further back, you hit the fourchette, where the labia minora meet. Finally, the outermost point is the posterior commissure, where the labia majora connect. Because the vestibule rapidly consolidates the termination points of the urinary, reproductive, and glandular systems into a single tight area, it is a focal point for clinical examination and anatomical testing.
The Bartholin gland is officially designated in anatomical texts as the greater vestibular gland. Deep within the superficial perineal pouch, the Bartholin gland sits between the majora and minora. Its duct routes medially, piercing the vestibule outside the introitus at the 4 and 8 o'clock positions. In a healthy state, the gland secretes an alkaline mucus to lubricate the vestibule during intercourse. Crucially, a normal Bartholin gland is never palpable upon physical examination.
This cross-section isolates benign pathology. On the left, mechanical duct occlusion traps mucus, forming a painless, unilateral Bartholin cyst. On the right, infected fluid creates a Bartholin abscess, marked by severe pain, warmth, tenderness, and palpable trapped pus. Management scales with severity. Conservative treatment, relying strictly on sitz baths and analgesics, is reserved exclusively for small, completely asymptomatic cysts under 3 centimeters in diameter. Once a lesion becomes symptomatic or progresses to an abscess, conservative measures are insufficient. The primary intervention is incision and drainage, combined with the immediate insertion of a word catheter. A simple incision will rapidly heal over, potentially sealing the infection back inside. The word catheter acts as a physical stent. It forces continuous drainage and prevents premature tissue reepithelialization, reducing the risk of recurrence. If conservative management and catheterization both fail, the final step is marsupialization, suturing the opened cyst wall directly to the surrounding skin to create a permanent drainage tract. This is generally reserved for highly recurrent lesions. Benign Bartholin pathology is managed via a strict clinical algorithm. The choice of intervention is determined by the presence of pain and the frequency of recurrence. There are specific clinical thresholds where standard drainage protocols must immediately be bypassed in favor of a malignancy workup. Demographic indicators are central to this decision. A biopsy is required for any recurrent cyst in a woman over the age of 40. Furthermore, any newly enlarged Bartholin gland in a postmenopausal woman must be treated as suspicious. During the physical exam, 3 specific findings require an immediate biopsy: a solid mass on palpation, a physically fixed lesion, or tethered to surrounding structures. These clinical signs prioritize the exclusion of the primary differential diagnosis, Bartholin gland carcinoma. In clinical and academic contexts, it is important to note that the most common histological variant of this malignancy is adenocarcinoma, and it predominantly affects the postmenopausal demographic. While a glandular swelling in a younger patient is often a localized obstruction, the same physical finding in an older patient, especially if the mass is fixed and immobile, necessitates a high-stakes oncological evaluation. This logic matrix organizes pelvic cystic lesions by anatomical coordinates. While symptoms can be ambiguous, localization provides a reliable framework. If a mass is situated directly adjacent to the urethra, localized near the anterior vestibule, it points to a periurethral or Skene's gland cyst. If the cyst is embedded in the lateral wall of the vagina, placing it structurally outside the vulvar boundaries, it indicates a Gartner cyst. If the mass occupies the 4 or 8 o'clock positions in the vestibule, it is a Bartholin lesion. The presence or absence of pain then differentiates a benign cyst from an abscess. For rapid anatomical recall, the terms vulva and pudendum are interchangeable. The vestibule houses exactly 6 openings. The introitus is partially covered by the hymen. For clinical management, the word catheter prevents reepithelialization following drainage, and solid, fixed Bartholin masses in patients aged 40 and older require biopsy to exclude adenocarcinoma. Clinical proficiency in managing the external female genitalia is achieved by treating the region as a predictable anatomical grid, where location dictates the diagnostic path.
Hysterectomy is the baseline extirpative procedure in gynecology. Surgeons rely on it to manage benign diseases and secure clear oncologic margins during cancer resections. But navigating the female pelvis requires strict adherence to anatomical rules. Avoiding severe complications means choosing the correct operative route, executing the precise procedural classification, and, above all else, mastering the exact course of the ureter. The ureter enters the pelvis laterally, exactly 3 centimeters from the median sacral artery, weaving medially through primary vascular highways. It sits trapped in an arterial sandwich, bordered anteriorly by the ovarian and uterine arteries, and posteriorly by the iliac arteries. Because of this dense entrapment, simply knowing where the ureter should be is insufficient. Surgeons must actively verify its exact location in the operative field by closely observing its active peristalsis. The ureter acts as the definitive architectural boundary of the pelvis. It dictates the absolute physical limits of what can be safely cut, clamped, or removed. As the ureter traverses this space, it is systematically endangered at 3 predictable anatomical junctions. First, at the pelvic brim, crossing the common iliac artery. Second, near the infundibulopelvic ligament, vulnerable when removing ovaries. Third, the most common site is water under the bridge, where the uterine artery crosses the ureter, exactly 2 centimeters lateral to the cervix's internal os. Surrounding these danger zones is the perimetrium, a matrix of connective tissue that includes the cardinal and uterosacral ligaments, tightly enveloping the cervix and lower uterus. The ureter runs directly through or immediately adjacent to this dense broad ligament and perimetrial tissue. Any procedure requiring the resection of the perimetrium directly threatens the ureter. This proximity forms the exact baseline for evaluating the risk profiles of advanced hysterectomies. Surgical radicality is categorized by the Piver-Rutledge classification matrix. It scales the extent of an operation based entirely on how much of the perimetrium and upper vagina are resected alongside the uterus. A type 1 simple total abdominal hysterectomy removes only the uterus and cervix, sparing the perimetrium, vagina, and lymph nodes. To maintain this tight boundary, the uterine artery is clamped right at the internal os, keeping safe distance from the ureter. In a standard type 1 procedure, the fallopian tubes and ovaries are left intact to prevent sudden surgical menopause in younger patients. If a patient has a strong oncologic indication or a high risk of ovarian cancer, the surgeon performs a panhysterectomy, explicitly adding a bilateral salpingo-oophorectomy to the procedure. Alternatively, in severe emergencies like postpartum hemorrhage, surgeons may opt for a supracervical hysterectomy, amputating the uterus but retaining the cervix to achieve rapid control. Because a type 1 resection avoids the perimetrial matrix, it is the standard for benign lesions and carries the absolute lowest risk of ureteric injury. This introduces a striking anatomical paradox. The absolute highest risk of ureteric injury does not occur in the most extreme radical surgery. It occurs in the modified radical procedure. The type 2 Wertheim hysterectomy removes the uterus, cervix, and upper third of the vagina, plus the medial half of the perimetrium. This requires dissecting the medial cardinal and uterosacral ligaments.
The uterine artery is clamped outward after the uterine branch. By isolating and excising exactly the medial half of this tissue, the surgeon's instruments are forced to operate in the tightest, most inescapable proximity to the ureter's path. This localized hunt deep within the medial perimetrium makes a type 2 resection the statistical apex of iatrogenic ureteric injury. Scaling up to the maximum oncologic resection brings us to the type 3, or radical hysterectomy. The footprint expands to the pelvic sidewalls. The surgeon removes the uterus, cervix, upper 2/3 of the vagina, and entire perimetrium, clearing the complete cardinal and uterosacral ligaments. To clear this tissue, the uterine artery is clamped exactly at its origin. Despite removing significantly more tissue than a type 2 procedure, a type 3 actually isolates the ureter early and completely unroofs it from the perimetrium. Because the dissection plane sweeps past the ureter rather than threading tightly alongside it, the localized risk to the ureter is slightly lower. Surgical complication risk does not scale linearly with the volume of tissue removed. It scales with the exact geometry of how the dissection plane intersects the ureter's conduit. The volume of tissue dictates the classification, but the physical sequence of dismantling that tissue depends entirely on the operative route. Through an open abdominal access route, the breakdown follows a strict top-to-bottom progression. The surgeon clamps the round ligament, then the fallopian tube and ovarian ligament. They secure the uterine artery, then drop deeper to clamp the cardinal and uterosacral ligaments. When performing a vaginal hysterectomy, the sequence is perfectly reversed, operating bottom to top. The surgeon first takes the uterosacral ligament, then the cardinal ligament. They secure the uterine artery third,
finishing at the top with the round ligament and tubo-ovarian complex. The dense structural integrity of the pelvic matrix can be dismantled in perfectly reversible sequences, provided the surgeon understands the spatial orientation of the ligaments. The route chosen heavily impacts recovery. The vaginal route offers a shorter return to normal activity, but is capped by a 16 to 18-week uterine volume limit. Abdominal access allows for unrestricted sizing, but requires a large open incision. Laparoscopy bridges this gap with small incisions and fast recovery. However, the heavy reliance on energy devices introduces a profound invisible danger: unrecognized thermal spread, where heat radiates past the instrument and burns adjacent tissues, like the ureter. Robotic hysterectomy improves upon standard laparoscopy by giving the surgeon true three-dimensional vision, a far greater range of precise movement, superior access to deep pelvic spaces, and easier knot tying. These advantages come at the cost of extreme financial overhead and equipment that limits assistant movement. More critically, operating from a console totally eliminates tactile, haptic feedback. The surgeon cannot physically feel the tension of the tissues they are cutting. Whether navigating the rigid mechanical constraints of a Type 2 Wertheim resection or compensating for the haptic blindness of a robotic console, the baseline requirement remains identical. Mastery in pelvic surgery relies on maintaining an unbreakable three-dimensional mental map of the pelvic architecture. It is an unforgiving matrix, permanently anchored by the hidden course of the ureter. The human menstrual cycle is defined by the concurrent, synchronized functioning of both the ovarian and uterine cycles. This coordination is essential for normal puberty, regular ovulation, and the endometrial preparation required for pregnancy. The system is governed by the hypothalamic-pituitary-ovarian axis. It begins in the hypothalamic, which acts as the cycle's primary initiator. The hypothalamic releases gonadotropin-releasing hormone, or GnRH, in a strictly pulsatile manner. Continuous secretion of this hormone would actually suppress the release of downstream gonadotropins. These pulses stimulate the anterior pituitary to release follicle-stimulating hormone and luteinizing hormone, which then travel through the bloodstream to the ovary. In response, the ovary functions as a hormone factory, synthesizing estrogen, progesterone, inhibins, AMH, and androgens. The reproductive cycle functions as a top-down neuroendocrine chain, where the brain continuously dictates the ovary's hormonal output. The structural unit of the ovary is the follicle, consisting of a single primary oocyte encased in supporting follicular cells. Development begins with the primordial follicle, where the oocyte is surrounded by a single flat layer of cells. As it transitions into a primary follicle, these cells become cuboidal. During the secondary or pre-antral stage, the supporting cells differentiate into two specialized layers, the inner granulosa cells and the outer theca cells. Fluid eventually accumulates to form an antrum. This cavity expands until the structure becomes a mature Graafian follicle, ready for ovulation. This journey from a primordial state to a fully mature Graafian follicle takes approximately 85 days. Throughout this 3-month timeline, the follicle's needs change. Its early growth is independent of the pituitary, while its later development relies strictly on FSH. This shift occurs at the pre-antral stage, which is precisely when granulosa cells acquire their FSH receptors. The dominant follicle releasing an egg this month actually began its maturation nearly 3 months ago, developing steadily until it reached the final hormone-sensitive window. Estrogen synthesis depends on multiple cell types because no single cell in the follicle possesses the full enzymatic machinery required for the process. In the two-cell, two-gonadotropin theory, LH first stimulates the theca cell. Using 17-alpha-hydroxylase, it produces androgens. Lacking aromatase, theca cells cannot convert these further. The androgens cross into the granulosa cell, where FSH activates aromatase, converting them into estrogen. FSH stimulation of the granulosa cells also produces inhibin B and anti-Müllerian hormone, or AMH. Since AMH is produced specifically by pre-antral and small antral follicles, its serum level serves as a direct proxy for a patient's ovarian reserve. This explains the presentation of granulosa cell tumors.
These are hormonally active, estrogen-secreting tumors that use inhibin B and AMH as clinical markers. Estrogen production is a specialized tag team effort. A receptor failure or enzymatic block in either cell type will arrest the entire system. Estrogen dominates the follicular phase, driving the proliferation of the uterine endometrium. Because of this rapid tissue growth, giving unopposed estrogen to a woman with an intact uterus significantly increases the risk of endometrial hyperplasia and carcinoma. As the follicle matures and produces more estrogen, it exerts negative feedback on the pituitary, causing FSH levels to drop. This drop in FSH starves the recruited follicles, leading to atresia for all but one.
The dominant follicle survives by having the highest density of FSH receptors, thriving on minimal FSH, and begins expressing LH receptors. When estrogen exceeds 200 picograms per milliliter for 48 hours, positive feedback triggers a massive LH surge. Estrogen acts as a biological throttle, first thinning the field to ensure only the strongest follicle survives, then triggering the surge that releases the egg. The timing is precise. The estrogen peak occurs 14 to 24 hours before the LH peak. The LH surge begins roughly 32 to 36 hours before ovulation and hits its peak 10 to 12 hours before the follicle ruptures. This surge luteinizes the granulosa cells, increases androgen production in the theca cells, and triggers the oocyte to complete meiosis I. During ovulation, the mature Graafian follicle finally ruptures under pressure, actively releasing the newly formed secondary oocyte out into the surrounding pelvic cavity. This rupture can cause mid-cycle pelvic pain, or Mittelschmerz, as antral fluid irritates the peritoneum. Ovulation is a rapid, pressure-driven rupture, orchestrated by a precise 48-hour neuroendocrine countdown. Following ovulation, LH transforms the remaining follicular structure into the corpus luteum. The luteinized granulosa cells shift their output, making progesterone the dominant hormone of this phase. The corpus luteum reaches its peak activity 8 days after ovulation. In a standard 28-day cycle, this occurs on day 22, with progesterone levels reaching roughly 15 nanograms per milliliter. Day 22 is therefore the most accurate time to draw serum progesterone to confirm that ovulation occurred. While the length of the follicular phase varies, the luteal phase is a biological constant, fixed at 14 days. Consequently, ovulation always occurs exactly 14 days before the start of the next menstruation, regardless of total cycle length. While the follicular buildup can be delayed, the post-ovulatory window follows a non-negotiable 2-week timer. Progesterone converts the endometrium into its secretory phase to support a potential pregnancy. The endometrium consists of 3 layers: the zona compacta, the zona spongiosa, and the zona basalis. The compacta and spongiosa form the zona functionalis, the layer that sheds during menstruation, while the zona basalis remains to regenerate the lining. The basal layer is supplied by straight basal arteries, but the functional layer relies on highly hormone-sensitive spiral arteries. These changes are visible on ultrasound. A single line indicates the early proliferative phase, a triple line marks the late proliferative phase, and a thick lining with posterior enhancement confirms the secretory phase. The endometrium is a disposable tissue organ grown from scratch each month, relying on a delicate and specific vascular supply. If pregnancy does not occur, the corpus luteum expires at 14 days, leading to a total withdrawal of progesterone. This withdrawal causes the spiral arteries to constrict and release PGF2-alpha, resulting in ischemia and the sloughing of the functional layer. The release of PGF2-alpha causes the painful cramping of primary dysmenorrhea, which serves as a physical indicator of a normal ovulatory cycle. This pain can be managed by blocking prostaglandins with NSAIDs or by using oral contraceptive pills to suppress ovulation. In pregnancy, the implanted blastocyst produces HCG, which rescues the corpus luteum from degradation. This rescued corpus luteum maintains progesterone production for 10 to 12 weeks until the placenta takes over. Menstruation represents the active vascular collapse of the uterine lining following the sudden biological withdrawal of progesterone. This logic explains anovulatory cycles. Without ovulation, no corpus luteum forms, and no progesterone is produced. Without progesterone to stabilize the lining, unopposed estrogen causes the endometrium to proliferate until it outgrows its blood supply and breaks down.
This estrogen breakthrough bleeding is typically irregular, heavy, and painless. It often manifests as oligomenorrhea, defined as having fewer than 9 cycles per year. Physicians use the progesterone withdrawal test to assess this. If stopping exogenous progesterone induces bleeding, it confirms that estrogen priming and the functional layer are intact, identifying anovulation as the primary issue. Surgical procedures are similarly layer-specific. A DNC scrapes away the functional layer, but because the basal layer remains, the tissue will eventually regenerate. Endometrial ablation, however, destroys both the functional and basal layers, permanently stopping bleeding, but ending future fertility. By mastering the cellular hardware and hormonal software of the HPO axis, clinical presentations, from missed periods to hemorrhage, can be logically deduced and managed.
In reproductive endocrinology, clinical intervention reduces to 2 choices. You are either replacing a hormone that is deficient, or you are suppressing one that is excessive. The primary signal for this axis is gonadotropin-releasing hormone, or GnRH. It is a decapeptide, a 10-amino acid chain, secreted by the arcuate nucleus of the hypothalamus. GnRH neurons originate in the olfactory placode, physically migrating along the olfactory pathway to reach the hypothalamus. If migration fails, the result is Kallmann syndrome. This X-linked recessive mutation in the CAL1 gene leaves the neurons stranded before reaching the axis. Because GnRH never reaches the pituitary, patients experience delayed puberty, primary amenorrhea, and infertility. Despite these developmental delays, their height is typically normal. A specific finding differentiates Kallmann from other causes of delayed puberty. Because the neurons share a pathway with the olfactory system, these patients also present with hyposmia, or a total inability to smell. The biochemical result is a total collapse of the cascade. Low GnRH leads to low LH and FSH and insufficient estrogen and androgens. Since the underlying issue is a spatial deficiency of the hormone, management requires exogenous replacement. We use synthetic pulsatile GnRH to provide the signal that the hypothalamus cannot. The HPG axis is sensitive to timing. Endogenous GnRH has a half-life of 2 to 4 minutes, clearing rapidly. This allows pulse frequency to determine output. Low-frequency pulses release FSH, while high-frequency pulses shift the pituitary toward LH. Synthetic GnRH analogs, typically identified by the len or relen suffixes, cannot be taken orally. To bypass digestion, they are administered through subcutaneous injection. When we deliver these analogs in pulses, they mimic normal physiology. This stimulates the axis to treat delayed puberty or to induce ovulation. Given continuously, the response changes. A constant GnRH stream prevents receptors from resetting. Initially, a flare phase releases stored gonadotropins, causing a surge in LH, FSH, and estrogen. Then, receptors downregulate. The pituitary becomes unresponsive, dropping hormone levels to near zero. This suppression provides a predictable method for inducing pharmacological menopause. It is used to treat hormone-sensitive conditions like endometriosis, fibroids, precocious puberty, and prostate cancer. Extended use of continuous GnRH causes side effects consistent with low estrogen, like hot flashes, vaginal dryness, and a decrease in bone density. To counter these effects, treatments lasting longer than 6 months include add-back therapy. Using norethindrone provides baseline estrogenic action to protect bones without re-stimulating the disease. GnRH antagonists, such as elagolix, provide a faster alternative. They achieve immediate suppression by blocking receptors directly, bypassing the initial flare phase. In this system, the physical kinetics of exposure, the time between doses, is what determines whether the axis is activated or shut down. The gonadotropins, LH and FSH, are complex glycoprotein hormones secreted by the anterior pituitary into the systemic circulation. Both share a 2-part structure. Each has a unique beta subunit for its specific role, but they utilize an identical alpha subunit. This alpha subunit isn't unique to gonadotropins. It's the same component found in TSH and HCG. These hormones achieve gender-specific effects through target receptors. FSH binds to Sertoli cells in males and granulosa cells in females to regulate gametogenesis. Similarly, LH receptors locate on Leydig cells to stimulate androgens and on theca cells in females. During follicular development, FSH also induces the expression of LH receptors on the granulosa cells of the dominant follicle, preparing it for the next phase. The distinct physiological roles of these hormones are a direct product of where their receptors are expressed on these somatic support cells. At the start of each menstrual cycle, FSH recruits a cohort of follicles to begin growth. Follicular growth is divided into two phases. The early preantral phase is independent of FSH, but the transition from the late preantral stage to granulosa formation is entirely FSH dependent. By day 8, the system selects a dominant follicle. The follicle with the highest density of FSH receptors monopolizes the available hormone, while the others regress. FSH also assists in the mechanical breakdown of collagen within the follicle wall, which is strictly necessary for the final release of the ovum. LH then takes over to trigger the physical event of ovulation. After the ovum is released, LH maintains the corpus luteum to support progesterone production. In males, LH remains focused on the Leydig cells, providing the continuous stimulus required for critical androgen synthesis. Reproduction relies on this transition, from the selective growth phase driven by FSH to the systemic trigger provided by LH. Normally, LH and FSH levels move in synchronous tandem below 10 international units. During menopause, estrogen stops, removing negative feedback and causing LH and FSH to rise sharply. Conversely, during pregnancy, high estrogen and progesterone provide intense negative feedback, suppressing gonadotropins near zero. However, when estrogen levels exceed 200 picograms during the menstrual cycle, the feedback loop briefly flips from negative to positive. This shift triggers the LH surge required for ovulation. There are cases where LH and FSH do not move together. In PCOS and androgen insensitivity syndrome, LH is pathologically high while FSH remains within the normal range. To address gonadotropin deficiencies, we use human menopausal gonadotropin, or HMG. This is harvested from the urine of postmenopausal women, where LH and FSH are naturally high and excreted in large quantities. Each vial is standardized to contain 75 units of LH and 75 units of FSH. It is used for ovulation induction, IVF, and in cases where the pituitary has been ablated. HMG use carries significant risks. There is a 30% incidence of multifetal pregnancy, as well as the risk of ovarian hyperstimulation syndrome, where the ovaries become dangerously enlarged. The HPG axis operates through a set of spatial receptors and temporal kinetics. Controlling it requires either mimicking those rhythms to replace what is missing, or maintaining a continuous signal to force the system to shut down. The female reproductive system operates under the strict governance of two steroid molecules. They are nearly identical, separated only by a slight variation in their carbon skeletons. Estrogens are C18 steroids. Progesterone is a C21 steroid. That 3-carbon difference dictates a massive systemic antagonism. Estrogen is the builder. It drives tissue proliferation and triggers salt and water retention. Progesterone is the stabilizer. It drives secretory transformation, opposes proliferation, and relaxes smooth muscle. Together, these two molecules orchestrate the menstrual cycle. They command endometrial growth, dictate the precise cellular makeup of the cervical and vaginal epithelia, and heavily regulate bone metabolism. To understand reproductive endocrinology, we have to trace these hormones from their initial enzymatic synthesis pathways all the way to modern targeted synthetic pharmacotherapies like SERMs and SPERMs. Every clinical symptom and pharmacological intervention we look at is a direct downstream consequence of this exact biochemical push and pull. Let's start at the molecular source. Both hormones are synthesized from lipid precursors, but they follow highly distinct enzymatic pathways. This diagram illustrates the estrogen synthesis pathway. Cholesterol is first converted into androgens via the enzyme 17-hydroxylase. Those androgens are then converted into estrogens by aromatase. That pathway yields 4 naturally occurring estrogens. Estradiol, or E2, is the primary estrogen in reproductive age females, produced by the granulosa cells of the ovary. Estrone, E1, becomes dominant in menopause and obesity because adipose tissue continues to convert adrenal androgens via aromatase long after ovarian follicles deplete. And estriol, E3, is the highly specific estrogen produced by the placenta during pregnancy. Progesterone synthesis, on the other hand, relies on LDL cholesterol. The LDL is converted to pregnenolone, which is then converted directly to progesterone. The key enzyme driving this step is 3-beta-hydroxysteroid dehydrogenase. In the non-pregnant state and early pregnancy, this production happens almost entirely in the corpus luteum. As pregnancy progresses to the later stages, the placenta takes over the manufacturing process. As seen in this split-cell comparison, once synthesized, these hormones target completely different cellular zones. Estrogen binds to intranuclear receptors directly at the site of DNA. Progesterone receptors are intracytoplasmic. The ligand must bind in the cytoplasm first, and then the entire receptor complex moves into the nucleus to function. They also travel through the bloodstream differently. Estrogen is roughly 99% protein-bound, attaching heavily to sex hormone-binding globulin before eventually degrading into glucuronide. Progesterone is 98% protein-bound, preferring albumin and cortisol-binding globulin before breaking down into pregnaniol. These distinct carrier proteins and receptor translocations directly dictate their differing biological half-lives. It explains why one hormone acts rapidly, while the other takes time to stabilize a target tissue. This division of labor extends across major organ systems. In the breast, estrogen drives ductal growth and fat deposition, while progesterone handles glandular development. In the fallopian tubes, estrogen increases motility to propel the egg. Progesterone, true to its nature, decreases tubal motility by relaxing smooth muscle. This carries a specific clinical risk. If a patient relies on a progesterone-only contraceptive and it fails, that delayed tubal transit increases the risk of an ectopic pregnancy. In bone tissue, the workload is completely one-sided. Estrogen promotes mineralization, increases bone mass, and drives epiphyseal closure. Progesterone lacks any major action here. Because of this tight control, excess estrogen in precocious puberty triggers premature epiphyseal closure, stunting final height. Conversely, the sharp drop in estrogen after menopause removes that mineralizing effect, directly causing osteoporosis. Look at this risk matrix correlating estrogen concentration with blood coagulation. Estrogen explicitly amplifies clotting factors 2, 7, 8, and 10. Because of this steep increase, any estrogen-containing therapy is strictly contraindicated for patients with a history of venous thromboembolism, stroke, or smokers over the age of 35. At the control center, the hypothalamus and pituitary, estrogen exerts negative feedback on FSH and LH, but it has a highly specific threshold. If estrogen levels hit or exceed 200 picograms per milliliter for 48 continuous hours, it flips to positive feedback, triggering the massive LH surge that causes ovulation. This feedback loop gives clinicians a reliable diagnostic role. If a patient's LH and FSH are low, the defect lies in the hypothalamus or pituitary. If LH and FSH are high but sex steroids are low, it indicates gonadal failure. The pituitary is signaling, but the ovaries cannot respond. Whether a patient presents with a deep vein thrombosis or unexplained short stature, the symptom profile usually points directly to which half of this steroidal dual is dominating their physiology. Clinicians don't need continuous blood draws to track this daily hormonal battle. The patient's exact endocrine status is physically encoded right into their tissue histology. Under the microscope, the estrogen-driven proliferative phase of the endometrium appears as simple tubular glands with pseudo-stratified nuclei. As progesterone takes over during the secretory phase, that architecture drastically changes. This timeline maps the exact sequence of secretory changes on an endometrial biopsy. Around day 16 or 17, subnuclear vacuoles appear. This is the earliest histological sign of ovulation. Over the next week, the simple tubes twist into highly tortuous, corkscrew-shaped glands, followed by stromal edema and finally lymphocytic infiltration. If you take an endometrial biopsy on day 22 and see those corkscrew glands, you have proof that ovulation occurred and progesterone is active. If you only see simple tubular glands, ovulation failed, and the patient remains in an estrogen-dominant proliferative state. The evidence is also visible in cervical secretions. Estrogen makes cervical mucus thin, perfuse, and highly elastic. You can stretch it between your fingers, a property called spinbarque. Under a microscope, high sodium and chloride levels in this fluid dry into a distinct fern-like pattern. This thin, watery state facilitates sperm ascent. Progesterone actively reverses this. It turns the mucus thick, scanty, and viscous. It breaks when you try to stretch it, and the ferning pattern disappears entirely.
Clinically, the absence of ferning on day 22 is a rapid, natural marker that ovulation has successfully occurred. Even the shedding cells of the vagina act as a record. High estrogen drives a predominance of superficial cells. If a patient presents with an ovarian mass and heavily superficial vaginal cytology, it points strongly to a feminizing, estrogen-secreting granulosa cell tumor. Progesterone, conversely, drives intermediate cell shedding. This bar chart tracks the maturation index, the proportion of parabasal, intermediate, and superficial cells. An ovulatory secretory phase yields a ratio of roughly 0 to 70 to 30. But look at the menopausal state, 100 to 0 to 0. It is 100% parabasal cells. That absolute lack of intermediate and superficial cells occurs because the vagina has no glands of its own. It relies entirely on estrogen for moisture. That menopausal ratio directly correlates to senile vaginitis, which is managed effectively with topical estrogen creams or gels. By tracking the glandular spirals, the stretch of the mucus, and the shedding of the cells, clinicians can read a simple glass slide as a direct physical readout of the entire hypothalamic-pituitary-ovarian axis. Natural hormones break down quickly, so long-term oral therapies require synthetic manipulation. To achieve this, biochemists developed synthetic estrogens that far exceed natural potency, with ethinyl estradiol topping the hierarchy above natural E2, E1, and E3. Early oral contraceptives utilized massive amounts of these synthetics. Even today, pill categories are defined entirely by their synthetic estrogen content, ranging from high-dose pills containing 50 micrograms or more, down to very low-dose formulations under 20 micrograms. This chart tracks the primary evolution in synthetic contraceptives, the progestins. Because synthetic progestins are structurally related to testosterone, early first-generation drugs like norethindrone carried heavy androgenic cross-reactivity. Over 4 generations, biochemists engineered these molecules to strip away those side effects, culminating in 3rd-generation desogestrel and 4th-generation drospirenone. This downward trend in androgenic activity gives these later generations high clinical utility. For a patient managing PCOS and hirsutism, a 3rd or 4th-generation progestin suppresses ovarian androgen production without adding systemic androgenic side effects. For patients where estrogen is completely contraindicated, like breastfeeding mothers or those with a prior history of venous thrombosis, progestin-only pills provide a safe, effective alternative. Progestin engineering also led to the levonorgestrel IUD. By releasing a 2nd-generation progestin locally, it severely thickens cervical mucus. This hostile barrier prevents sperm penetration, while simultaneously lowering the risk of pelvic inflammatory disease compared to copper devices. The history of contraceptive pharmacology is a relentless engineering effort to isolate the precise therapeutic benefits of C18 and C21 steroids while systematically eliminating their metabolic liabilities. When that steroidal axis loses balance, unchecked estrogen drives severe pathology. Hyperestrogenic states fuel precocious puberty, endometriosis, fibroid growth, and both endometrial and ovarian cancers. However, there is a strict distinction here. Cervical cancer is not a hyperestrogenic condition. Early menarche and late menopause increase the risk for endometrial cancer, but they have no bearing on cervical pathology. True hyperestrogenic conditions share common risk factors like obesity and nulliparity, and protective factors like multiparity and physical exercise. Counterintuitively, smoking is also listed as a protective factor, specifically because it inhibits the aromatase enzyme, lowering local estrogen synthesis. We can intervene in this overproliferation using several mechanisms. We can prescribe progesterone to force anti-proliferative secretory changes. We can use letrozole to block aromatase. We can use danazol, though its androgenic effects limit its use. Or we can deploy continuous GnRH antagonists to shut down the pituitary entirely. But the most precise interventions utilize selective estrogen receptor modulators, or SERMs. Look at this anatomical map. A single SERM can bind to estrogen receptors across the body, but act as a strict antagonist in one tissue, like the breast, while acting as an active agonist in another, like the bone. Clomiphene acts at the hypothalamus for ovulation induction. Raloxifene acts as an agonist in the bone to treat osteoporosis. Tamoxifen acts as an antagonist to treat breast cancer. However, tamoxifen acts as a potent agonist in the uterus, carrying a very specific risk of inducing endometrial cancer. Other SERMs are engineered for highly targeted complaints. Ospemifene targets vaginal dryness. Basodoxifene treats hot flashes without risking the endometrium, and ormeloxifene serves as a non-steroidal oral contraceptive. This selectivity also exists on the progesterone side. Selective progesterone receptor modulators, or SPRMs, include ulipristal, which is used for fibroid management and emergency contraception. There are also direct progesterone antagonists, like mifepristone, utilized heavily in medical abortions. SERMs and SPRMs represent the pinnacle of targeted endocrine therapy. They allow clinicians to selectively edit these physiological effects on an organ-by-organ basis. The physiological duel running through the female reproductive system never breaks character. Estrogen constantly builds, proliferates, and prepares. Progesterone arrives to stabilize, secrete, and eventually induce atrophy. This massive systemic network of tissue development and organ feedback originates entirely from a single variation in carbon ring structure. Clinicians track this chemical battle directly through physical artifacts: the coiling of endometrial glands, the ferning of stretched mucus, and the cellular shedding measured by a maturation index. And when that system falters, pharmacology no longer relies solely on massive doses of broad-spectrum synthetics. It relies on the absolute precision of tissue-specific receptor modulators. True mastery of reproductive pharmacology means viewing every disease state, every symptom, and every medication not as isolated variables, but as a solvable imbalance within the foundational C18 and C21 steroid axis.
Puberty is the highly complex neuroendocrine transitional period that physically bridges early childhood and full adult reproductive maturity. Clinically, this transition is marked by three distinct developments: the appearance of secondary sexual characteristics, the acquisition of reproductive capacity, and specific behavioral shifts, including increased aggression, attraction to the opposite sex, and conflict with parents. The physiological timeline for these changes operates within strict normal parameters. In females, the onset of puberty typically occurs around 10.5 years of age. In males, it begins slightly later, at approximately 11.5 years. This schematic maps the pathway from the hypothalamus down to the pituitary gland and to the ovary. Physical maturation is the visible result of this exact neurological pathway, the sudden reactivation of a dormant hormonal engine known as the hypothalamic pituitary ovarian, or HPO, axis. Mastering pubertal medicine requires tracking the exact biochemical sequence of how this axis disinhibits. Clinical emergencies, such as pubertal menorrhagia or precocious puberty, are specific mechanical or chronologic failures along this developmental timeline. The HPO axis is fully active during intrauterine life. However, immediately after birth, it shuts down, remaining completely dormant until the onset of puberty. This schematic of the prepubertal hypothalamus illustrates how that dormancy is maintained. High levels of inhibitory neurotransmitters, specifically GABA and neuropeptide Y, exert heavy downward pressure on the system. The hypothalamus at this stage is highly sensitive to even trace amounts of circulating estrogen, which maintains strict negative feedback. Those trace estrogen levels, measuring less than 10 picograms, are generated peripherally. Adrenal androgens enter adipose tissue, where the enzyme aromatase converts them into small amounts of estrogen. This subtle peripheral output is enough to keep the central axis suppressed. The onset of puberty requires a precise neurochemical shift. Inhibitory neurotransmitters like GABA and neuropeptide Y decrease, paired with a surge in excitatory neurotransmitters like glutamate. This biochemical environment culminates in kisspeptin. Kisspeptin acts as the master excitatory neurotransmitter, directly triggering the pulsatile release of GnRH from the hypothalamus. This switch also relies on permissive signals from the body. Leptin, a hormone produced by adipose tissue, signals that energy reserves are sufficient for reproduction, which explains why higher adiposity is often associated with earlier pubertal onset in females. Once activated, the hypothalamus releases GnRH in distinct pulses. Initially, these pulses occur strictly at night and at a low frequency. A low GnRH pulse frequency heavily favors the pituitary release of follicle-stimulating hormone, or FSH, over luteinizing hormone. Over the next 1 to 3 years, these pulses mature. They expand into the daytime, increase in frequency, and establish luteinizing hormone, or LH, dominance. This LH surge is an absolute physiological requirement for ovulation. Because early, low-frequency GnRH pulses cannot trigger an LH surge, the first few post-pubertal menstrual cycles are inherently anovulatory. This physiological immaturity creates a predictable window for early clinical bleeding disorders. This timeline charts the strict clinical sequence of normal female puberty. It begins with the initial growth spurt, followed by thalarchy, or breast budding. Then comes pubarchy, peak height velocity, and finally menarche, which predictably occurs about 2 years after the onset of puberty and 6 months after peak height velocity. Comparing this to the male timeline below, the sequence differs. Testicular enlargement presents first, followed by penile enlargement, pubarchy, and a significantly delayed peak height velocity. Because the male growth spurt starts later but lasts longer, boys eventually attain a greater final height. While estrogen initiates the growth spurt, drives bone mineralization, and eventually causes epiphyseal closure, it is not the hormone directly responsible for linear growth. That mechanical expansion is mediated entirely by growth hormone and insulin-like growth factor. Clinicians track this physical progression using Tanner staging. High-yield diagnostic correlations include stage 2 for initial breast budding, stage 3 for the appearance of pubic hair strictly on the mons pubis, and stage 5 when pubic hair extends to the medial thigh. It is crucial to separate true pubertal development from adrenarche. Occurring around 6 years of age, adrenarche is the independent adrenal production of androgens, marked by a DHEA sulfate level of 40 or higher. It drives axillary hair, pubic hair, and libido, but functions entirely independent of HPO axis activation. Mapping the exact chronological sequence allows clinicians to pinpoint pathology. A missing milestone or a premature appearance immediately dictates which specific glandular system is malfunctioning. When the immature HPO axis falters, it often presents as puberty menorrhagia, abnormal uterine bleeding in a pubertal girl. The most common cause is the anovulatory nature of early cycles. Without ovulation, the ovary produces no progesterone. Unopposed estrogen continues to build a thick, unstable endometrium that eventually sheds heavily and unpredictably. While anovulation is the primary driver, secondary causes must be systematically ruled out. Coagulation defects are the second most common cause and should be highly suspected if the patient exhibits easy bruising, heavy bleeding at menarche, or profuse bleeding from minor wounds. Thyroid dysfunction can also disrupt the bleeding profile. Physical evaluation requires assessing the patient for signs of general anemia and determining her exact Tanner stage. However, performing a per-vaginal examination is strictly contraindicated in virginal girls. The routine biochemical workup is direct. It requires a hemoglobin level, a TSA assay, and a complete coagulation profile detailing bleeding, clotting, and prothrombin times. A urine pregnancy test is indicated only if sexual activity is possible, and a routine pelvic ultrasound is not mandatory for initial diagnosis. In a pubertal bleeding emergency, the diagnostic priority is biochemical profiling to confirm axis immaturity and exclude underlying coagulopathies, rather than relying on advanced imaging. This clinical decision tree organizes the exact management algorithm for pubertal menorrhagia. Interventions are categorized entirely by the severity of the patient's hemoglobin drop. The mild pathway, for hemoglobin levels between 10 and 12 grams per deciliter, is managed conservatively. Patients require oral iron supplementation, clinical reassurance, and a menstrual calendar to track ongoing cycles. Moving to the moderate pathway, where hemoglobin is between 8 and 10 grams, active intervention is required. Combined oral contraceptive pills are used to chemically suppress endogenous LH and FSH, reducing ovulation and stabilizing the lining. Expected withdrawal bleeding occurs on day 24 or 25 of the pack. If hormone therapy is refused, tranexamic acid, taken at 500 milligrams twice daily for 5 days, serves as the alternative. Severe bleeding is defined by a hemoglobin crash below 8 grams per deciliter, or profuse bleeding sustained for 15 days. Chronic severe bleeding strips the uterus, leaving a radically thinned endometrium. Administering progesterone here would fail. Exogenous estrogen must be administered first to thicken the lining and upregulate the necessary progesterone receptors. The severe protocol utilizes IV estrogen if available, or a heavy oral course of ethinyl estradiol at 50 milligrams for 5 days.
Alternatively, a high-dose OCP step-down regimen is employed, 8 tablets daily for 2 days, 12 daily for 5 days, tapering to once daily for 2 weeks. This is followed by a mandatory 6-cycle maintenance therapy. Halting severe menorrhagia requires pharmacological architectural reconstruction. The clinician must artificially provide the rigid endometrial stabilization that the patient's immature HPO axis cannot yet produce. The opposite of a delayed or immature axis is precocious puberty, defined clinically as the appearance of secondary sexual characteristics before age 8 in girls and age 9 in boys. Exposure to excess early estrogen carries severe clinical consequences, beyond significant psychological stress and increased risk of hyperestrogenic states like endometrial cancer. Premature estrogen forces early epiphyseal closure, permanently halting linear growth and resulting in a significantly short adult stature. This split-screen matrix divides the pathology into 2 distinct categories: central precocious puberty on the left and peripheral on the right. Central precocious puberty, accounting for 80% of cases, is true puberty. The HPO axis activates prematurely, resulting in elevated GnRH, high LH, high FSH, and high estrogen. Because the entire axis is active, premature ovulation and menarche can occur. Peripheral precocious puberty accounts for the remaining 20%. It operates completely independent of the HPO axis. Excess localized estrogen or androgen from a peripheral source suppresses the brain. This results in heavily depressed LH and FSH levels and no premature ovulation. Because of this clear mechanistic divide, serum LH and FSH assays serve as the definitive tests to distinguish between a brain that has awakened too early and a peripheral tumor acting autonomously. The etiology of central precocious puberty is most commonly idiopathic. Secondary causes include brain tumors, such as hamartomas and gliomas, or CNS infections like tubercular meningitis. Because central activation follows a normal female pathway, it is always isosexual, producing female-type traits in a girl. Peripheral precocious puberty can also be isosexual. This is driven by granulosa cell tumors of the ovary, McCune-Albright syndrome due to an activating mutation in the FSH receptor's G protein signaling, or chronic hypothyroidism, where TSH structural similarity causes cross-reactivity at the ovarian receptors. If peripheral precocious puberty presents as heterosexual, meaning male-type traits develop in a female, the hormonal driver is androgenic. This points directly to an androgen-producing ovarian tumor or congenital adrenal hyperplasia. This universal diagnostic panel is required for all precocious puberty patients. It includes bone age estimation, LH, FSH, estrogen, TSH, a pelvic ultrasound, and a mandatory brain MRI. If heterosexual traits are present, the sub-branch triggers testing for testosterone, DHEA sulfate, and 17-hydroxyprogesterone to isolate an adrenal versus ovarian source. Treatment pathways diverge strictly based on the etiology. Central disease is managed by administering continuous GnRH analogs to overwhelm and shut down the HPO axis. Peripheral disease requires targeted removal of the underlying tumor or correction of the specific glandular defect. Whether hunting for an adrenal tumor or suppressing a central hamartoma, the correct clinical approach relies entirely on localizing the exact point of hormonal origin. Bringing back the complete HPO axis schematic, we see that human puberty relies on the precise, timed disinhibition of this neuroendocrine network. Precocious puberty occurs when the axis is activated prematurely or bypassed entirely by a peripheral rogue source. Conversely, puberty menorrhagia is a mechanical consequence of an axis that has successfully awakened but remains biochemically immature. In reproductive endocrinology, effective intervention requires absolute precision. Whether prescribing continuous GnRH analogs to halt bone closure or calculating high-dose estrogen step-downs to arrest acute hemorrhage, success depends on identifying the patient's exact coordinate along the developing HPO axis.
Maintaining a normal human menstrual cycle requires a continuous, rhythmic sequence of cascading signals. When those signals are interrupted, menstruation stops. Clinical secondary amenorrhea is the absence of menses for at least 3 months in a woman who previously menstruated normally. The same evaluation applies to women with fewer than 9 cycles per year, which suggests significant ovulatory dysfunction. Take the menstrual history carefully. A patient may report having never menstruated, suggesting primary amenorrhea, when they have actually experienced prior bleeding they are hesitant to disclose, a situation often seen in cases of sexual abuse or incest. This diagram maps the hypothalamic, pituitary, ovarian, uterine axis. We approach the evaluation of secondary amenorrhea as a localization problem, searching for the specific compartment within this four-part system where the signaling has failed. To find that location, the diagnostic process follows a sequential biochemical algorithm that tests each of these four compartments in turn. The evaluation starts with 5 tests: urine HCG, serum prolactin, TSH, LH, FSH, and estrogen. First, rule out pregnancy. Progesterone remains high during pregnancy, produced initially by the corpus luteum, and by week 8, the placenta, which prevents the endometrium from shedding. This test is required for reproductive age women, perimenopausal women, and those with irregular or abnormal bleeding patterns. Ruling out pregnancy allows the physician to move past these baseline physiological variables and begin isolating the specific underlying pathologies. Step 2 evaluates serum prolactin and TSH. Prolactin is considered normal below 20 to 25 nanograms per milliliter. Because prolactin secretion is pulsatile and peaks in the early morning, an isolated mildly elevated value should be repeated for confirmation before proceeding. Prolactin regulation is primarily inhibitory, controlled by dopamine from the hypothalamus. However, thyrotropin-releasing hormone, or TRH, acts as a dual stimulator, increasing both TSH and prolactin. In primary hypothalamism, low T3 and T4 levels reduce negative feedback. This causes TRH to surge, which drives up both TSH and prolactin. Elevated prolactin suppresses GnRH from the hypothalamus, decreasing LH, FSH, and estrogen, resulting in amenorrhea and galactorrhea. If prolactin remains high, an MRI is used to check for a prolactinoma. Microadenomas are less than 1 centimeter. Macroadenomas, measuring 1 centimeter or more, can cause bitemporal hemianopsia and cavernous sinus syndrome due to their size and proximity to the optic chiasm. Cabergoline is generally the drug of choice for medical treatment due to its long half-life. Bromocriptine is preferred specifically when the patient is seeking treatment for infertility. Prolactinomas are typically not treated during pregnancy or lactation unless visual disturbances suggest tumor growth. Surgery is a secondary option if medical therapy fails to reduce tumor size or if prolactin remains above 50 after 4 months. Since these endocrine axes overlap, hypothyroidism must be corrected first to see if the prolactin levels normalize without further intervention. Step 3 evaluates FSH and estrogen levels to check the integrity of the ovaries. If FSH is above 25 units and estrogen is low, it indicates follicular depletion, a condition called primary ovarian insufficiency or hypogonadotropic hypogonadism. If FSH is 10 units or less, the evaluation moves to step 4, the progesterone challenge test. The patient takes 10 milligrams of medroxyprogesterone acetate daily for 5 days. If withdrawal bleeding occurs, the test is positive. This suggests polycystic ovary syndrome, where the endometrium is estrogen primed, but the patient is anovulatory. Anti-Müllerian hormone levels are also typically high in these cases. Successful bleeding proves that the failure is limited to ovulation and that the uterine anatomy is functional. If the progesterone challenge is negative, step 5 uses a combined estrogen and progesterone challenge. If there is still no bleeding, the defect is structural. This HSG scan shows the filling defects and irregular outlines characteristic of Asherman syndrome. Asherman syndrome involves intrauterine adhesions, often following endometrial trauma from postpartum curettage, a D&C, or infections like genital tuberculosis. In clinical settings, note that while menstrual irregularity is the most common symptom group, infertility is the most common single symptom reported. Treatment involves hysteroscopic adhesiolysis, followed by estrogen to regenerate the endometrium and progesterone to ensure the tissue is protected. If the estrogen-progesterone challenge does produce bleeding, the uterus is intact. This points to a failure localized in the hypothalamus or pituitary. When biochemical challenges confirm the uterus can respond to hormones, the next step is structural imaging of the brain. Step 6 uses an MRI to differentiate between central defects. A normal MRI suggests hypothalamic amenorrhea, where stress, exercise, or eating disorders lead to low levels of GnRH, LH, and FSH. An empty cella finding indicates Sheehan Syndrome, which is postpartum necrosis of the anterior pituitary following severe blood loss. During pregnancy, the anterior pituitary enlarges by 125%, making it vulnerable to ischemia if a significant postpartum hemorrhage occurs. Clinically, this presents as a failure to lactate and persistent amenorrhea. The hormones typically fail in a specific order. First, growth hormone, then LH and FSH, followed by prolactin, and finally TSH. Unlike the postpartum necrosis of Sheehan syndrome, pituitary apoplexy involves acute hemorrhage or infarction into an existing pituitary adenoma. This is a medical emergency. The sudden loss of ACTH leads to collapsed cortisol production, resulting in hypoglycemia and hemodynamic shock. Immediate treatment with corticosteroids is required. Identifying these central defects depends on the pace of onset, differentiating between chronic hormonal decline and acute, life-threatening collapse. This matrix maps hormone levels to their pathologies. Hypothalamic amenorrhea features uniformly low hormones and normal MRIs, while primary ovarian insufficiency shows high LH and FSH. PCOS is identified by a positive progesterone challenge, and Asherman syndrome by a negative estrogen-progesterone challenge. The evaluation of secondary amenorrhea functions as a process of elimination, following the specific biochemical logic of the reproductive axis to pinpoint exactly where the signaling has failed. Menopause is the final result of a resource exhaustion process that begins long before a female is born. This timeline maps the human ovarian follicle count against age. The peak physiological reserve occurs around the 5th month of intrauterine life, reaching roughly 6 to 7 million follicles. From that peak, follicles undergo continuous apoptosis. The reserve drops to between 1 and 2 million by birth and diminishes to roughly 500,000 by puberty. Menopause occurs at the moment this reserve hits absolute zero. When no follicles remain, the mechanical trigger for endocrine transition is pulled. Adult female reproductive life is broadly divided into the reproductive, perimenopausal, and menopausal phases. This progression is clinically mapped using the Stroh staging system, which identifies 7 distinct stages based on bleeding patterns and endocrine function. This localized exhaustion of microscopic follicles initiates a systemic endocrine cascade impacting every major organ system in the body. Routine menopause is a retrospective clinical diagnosis. It requires exactly 12 consecutive months of amenorrhea in a woman within the expected age group. In clinical practice, if a woman meets this 12-month threshold at the expected age, no hormonal testing is required for diagnosis. The chronological average for this transition is 51 years worldwide. It is classified as late menopause. This is clinically significant because prolonged, uninterrupted estrogen exposure increases the risk of endometrial pathology and endometrial cancer. Leading up to the final period is a 4 to 5 year transition known as perimenopause. The older term, climacteric, is now obsolete. The earliest recognizable clinical sign of perimenopause is an increase in cycle length by 7 days or more. As the follicle reserve dwindles, ovulation becomes inconsistent, leading to irregular anovulatory cycles. These chronological milestones and bleeding patterns allow clinicians to diagnose natural menopause through history alone, before relying on laboratory confirmation. As the follicles vanish, ovarian function drops. Estrogen, circulating androgens, inhibin, and anti-Müllerian hormone all plummet. Because the negative feedback loop to the pituitary gland is broken, follicle-stimulating hormone and luteinizing hormone levels rise precipitously. While total estrogen falls, the profile shifts. Estrone, or E1, becomes the predominant estrogen as adrenal androgens are converted within peripheral adipose tissue. Historically, the extreme concentration of pituitary hormones in postmenopausal urine was utilized to synthesize human menopausal gonadotropin, or HMG. This endocrine shift dictates the logic for secondary amenorrhea. The first step is to rule out pregnancy, a state where high hormone levels keep FSH and LH characteristically low. In contrast, elevated FSH and LH combined with low estrogen indicates hypergonadotropic hypogonadism. These high gonadotropin levels explicitly distinguish this state from pregnancy.
By combining this lab profile with the patient's age, a clinician can determine whether the cause is natural menopause or a pathological insufficiency. When this hypergonadotropic state and the cessation of menses occurs before age 40, it is defined as primary ovarian insufficiency, or POI. The older term, premature menopause, is technically inaccurate. Patients with POI frequently exhibit intermittent ovarian activity and occasional spontaneous ovulation. POI strictly requires laboratory confirmation. The diagnostic criteria mandate 2 separate FSH tests, drawn 1 month apart, showing levels of 25 or higher. Common presentations include secondary amenorrhea, secondary infertility, and symptoms of estrogen deprivation, such as vaginal dryness. POI etiologies include chemotherapy, high radiation sensitivity, mumps, autoimmune diseases, and Fragile X syndrome. Karyotyping is mandatory if POI is accompanied by short stature, to look for Turner syndrome. It is also required for patients with normal stature who develop POI before age 30, to rule out Turner mosaicism. POI is a distinct pathological state. It requires immediate confirmation and genetic screening to manage the systemic risks associated with decades of premature estrogen deficiency. The most common vasomotor symptom of estrogen deficiency is the hot flash.
The loss of estrogen effectively resets the hypothalamic thermostat. This temperature dysregulation is driven by an imbalance of central neurotransmitters, specifically serotonin and norepinephrine. A typical hot flash lasts 3 to 4 minutes, presenting as intense facial heat followed by sweating and palpitations, menopause, or GSM. This term replaces outdated descriptors like senile vaginitis. The vagina has no glands of its own. It relies on cervical mucus and local trophic states. Without estrogen, cervical discharge decreases, and the vaginal lining becomes thin and dry. This lack of lubrication leads to significant discomfort and dyspareunia, requiring active management during gynecological care. The collapse of a single hormone isolates the body's regulatory systems, stripping away central heat regulation while causing aggressive peripheral mucosal atrophy. Estrogen is necessary to maintain bone mass. Without it, osteoclast-mediated bone resorption outpaces osteoblast formation, creating a quantitative defect known as postmenopausal osteoporosis. This resorption does not affect the skeleton equally. The spongy network of trabecular bone is resorbed at a much higher rate than the outer cortical bone. Clinical manifestations include chronic backache and specific fractures at the neck of the femur, the ankle, and the vertebrae from T12 to L3. This is a standard DEXA scan report, the investigation of choice for bone mineral density. Screening is recommended for women over 65, targeting the lumbar spine or the neck of the femur. The T-score compares the patient's density to a young, healthy woman. A score between 0 and -1 is normal. -1 to -2.5 indicates osteopenia, and anything below -2.5 confirms osteoporosis. The Z-score compares the patient to an age-matched woman. A low Z-score indicates the bone loss is not caused by age alone, requiring an investigation into secondary causes like heparin exposure. Estrogen's skeletal protection is a measurable physical barrier. Its removal leaves the architecture of the bone compromised, requiring precise quantitative tracking to prevent fractures that lead to a permanent loss of mobility. For severe hot flashes, the first-line treatment is hormone replacement therapy. This remains the primary indication for postmenopausal HRT. If HRT is contraindicated, clinicians use SSRIs or SNRIs to stabilize the neurotransmitter pathways that regulate the hypothalamic thermostat. Management of GSM relies on localized estrogen therapy, creams, gels, or rings. These are still classified and monitored as a form of HRT. SERMs are generally not ideal for GSM, as they can cause or worsen vaginal dryness. Osteoporosis treatment primarily utilizes alendronate to inhibit bone resorption. Only a few drugs like teriparatide and strontium ranelate actively stimulate bone formation through osteoblasts. Nutritional requirements for menopausal females include 1,200 milligrams of calcium and 800 international units of vitamin D per day. Patients with POI require a different HRT protocol. Estrogen replacement must continue until the normal age of menopause, approximately 47 in India and 51 globally, to prevent systemic degradation. Treatment is compartmentalized by pathology.
localized therapy for mucosal atrophy, specific inhibitors for bone mass, and prolonged HRT for premature failure. Endogenous estrogen is cardioprotective. It increases high-density lipoproteins and stimulates nitric oxide release in vascular endothelial cells to facilitate vasodilation. Because coronary artery disease risk rises after menopause, medical consensus once assumed that giving exogenous estrogen would prevent cardiac disease. The Women's Health Initiative trial tested this hypothesis. The trial was halted because exogenous HRT increased the risk of coronary artery disease rather than reducing it. HRT is never used to prevent coronary artery disease. This risk increase is most significant and heavily emphasized in women older than 60 years. Formulation also matters. Estrogen-only HRT carries less coronary risk than combined estrogen-progesterone therapy. Modern clinical management of ovarian failure discards systemic prophylactic dogma in favor of precise, symptom-specific interventions.
The female endocrine axis operates in narrow margins. When breached, the system deteriorates to extremes: the systemic fallout of estrogen deficiency or virilizing androgen excess. Clinical management requires mastering two distinct objectives: restoring the system through estrogen replacement and mitigating the toxic effects of excess androgens on the ovarian follicle. Success depends on the precise manipulation of feedback loops, binding globulins, and receptor sites. A miscalculation in these pharmacological dosages risks inducing severe iatrogenic harm while failing to resolve the underlying pathology. Hormone replacement therapy functions by artificially restoring depleted estrogen levels. While it is indicated for several conditions, the primary clinical driver is the relief of severe menopausal hot flashes. We also deploy HRT across a spectrum of estrogen-deficient states, including primary ovarian insufficiency, Turner syndrome, Swyer syndrome, androgen insensitivity syndrome, and following an oophorectomy. The anatomical binary dictating every HRT protocol is the status of the uterus. When the uterus is absent, the protocol is estrogen only. When it is present, the standard shifts to combined estrogen plus progesterone. Progesterone is an absolute requirement in patients with an intact uterus. Administering unopposed estrogen in these cases directly drives endometrial hyperplasia, leading to endometrial cancer. To protect the endometrium, progesterone must be dosed for at least 12 days per cycle, and ideally for the full duration of estrogen therapy. There are strict clinical exceptions where combined therapy remains mandatory, even if the main body of the uterus is physically absent. This includes patients with a history of endometrial cancer, endometriosis, ovarian fibroids, or those who have undergone a subtotal hysterectomy where cervical stump tissue remains. The presence of functional endometrial tissue, whether native, ectopic, or residual, acts as a biological override. It demands combined therapy to prevent malignant transformation. The pharmacological standard for HRT centers on 17-beta-estradiol, which has largely superseded the historical use of conjugated equine estrogen. Administration routes dictate the starting dosage. Oral 17-beta-estradiol typically starts at 0.5 milligrams per day, while transdermal estradiol begins at 0.025 milligrams. Notably, the transdermal route carries a significantly lower risk of venous thromboembolism compared to oral administration. When progesterone is added, the primary choice is micronized progesterone at 100 to 200 milligrams per day. Dydrogesterone serves as the secondary clinical alternative. Both regimens provide systemic benefits by reducing hot flashes, preventing osteoporosis, and decreasing the risk of colorectal cancer. The addition of progesterone specifically mitigates the risk of endometrial cancer. These benefits are balanced against specific risks. All HRT regimens increase the likelihood of venous thromboembolism. Combined therapy specifically increases breast cancer risk, while the association with ovarian cancer remains statistically uncertain. We must also manage clinical expectations. HRT does not protect against coronary artery disease and may increase CAD risk in women over 60. It offers no contraceptive protection and has no impact on cervical cancer risk. If a patient requires both vasomotor control and contraception, the protocol is estrogen HRT combined with an IUD. If HRT is entirely contraindicated, a selective estrogen receptor modulator is the advised alternative for hot flashes. For most postmenopausal women, therapy is limited to 5 years. However, in cases of primary ovarian insufficiency or Turner syndrome, treatment continues until the patient reaches the normal expected age of menopause.
Absolute contraindications include a history of deep vein thrombosis, stroke, CAD, breast cancer, undiagnosed vaginal bleeding, acute liver dysfunction, or hypertriglyceridemia. Severe uncontrolled hypertension is a contraindication, though controlled hypertension is permissible. Prescribing HRT is a process of rigid risk stratification. It requires a constant balancing of cardiovascular and oncological data against a patient's quality of life. The androgen axis operates differently. In intrauterine life, the fetal adrenal glands produce androgens that are intercepted by the enzyme aromatase and converted directly into estrogens. Postnatal androgen production begins significantly at age 5 or 6 during adrenarche, marking the start of independent adrenal output. Following puberty, the primary biological sources for these hormones are the ovarian theca interna cells and the adrenal glands. Ovarian androgen production follows a strict hierarchy. Androstenedione is produced in the highest volume, followed by testosterone and DHEA. Certain androgens are explicitly not produced by the ovary. DHEA sulfate is exclusively adrenal, and dihydrotestosterone requires the enzyme 5-alpha reductase for synthesis, an enzyme clinically noted as deficient or absent in females. Normal female serum androgen levels remain below 70 to 79 nanograms per deciliter. These C19 steroids circulate bound to albumin and sex hormone-binding globulin, or SHBG. This creates an inverse relationship. Androgens decrease SHBG levels, while estrogens increase SHBG synthesis. At baseline, these hormones regulate libido and the growth of axillary and pubic hair. The female androgen state is a precarious balance. Transport globulins act as the primary chemical buffer against systemic virilization. When that balance is lost, the resulting excess androgens are folliculotoxic. They arrest follicular growth and prevent maturation, driving the system toward anovulation. Mild androgen excess manifests as hirsutism, thick male pattern hair on the upper lip, chin, chest, and linea nigra, often accompanied by male pattern alopecia and recalcitrant acne. Marked androgen excess leads to virilization. This adds male secondary sexual characteristics, including a deepened voice, breast atrophy, increased muscle mass, and clitoromegaly, defined as greater than 1 centimeter. We quantify these states using objective scoring. Hirsutism is graded via the modified Ferriman-Galway score, which evaluates 9 sites. A score of 8 or higher is diagnostic. Virilization is assessed using the Prater score. The clinical algorithm for hirsutism or severe acne begins with a serum testosterone draw, which then dictates one of 3 specific pathways. A result below 70 nanograms per deciliter indicates normal androgen levels. If hirsutism is present here, the diagnosis is idiopathic hirsutism. A result between 70 and 200 nanograms per deciliter represents mild elevation. This points toward polycystic ovary syndrome, or late-onset congenital adrenal hyperplasia. Levels exceeding 200 nanograms per deciliter indicate marked elevation, usually associated with rapid-onset virilization. This strongly suggests an androgen-secreting ovarian tumor, or severe CAH. To differentiate between PCOS and late-onset CAH, we test 17-hydroxyprogesterone. A level below 200 rules out CAH. Between 200 and 800 requires an ACTH stimulation test, and a result over 800 confirms the diagnosis of CAH. Clinical suspicion is insufficient. Rigid adherence to these specific serum thresholds is the only way to avoid diagnostic errors regarding tumors or hyperplasia. Pharmacological management follows a tiered approach, starting with a 6-month trial of combined oral contraceptive pills. OCPs utilize 4 simultaneous mechanisms. They suppress LH and FSH, reduce ovarian androgen production, and increase SHBG levels to lower circulating free testosterone. We use specific formulations for this purpose. The estrogen must be low dose, under 50 micrograms, and the progesterone must be 3rd or 4th generation to ensure minimal androgenic or maximal anti-androgenic effect. If the response to OCPs is inadequate, we escalate to the second line by adding spironolactone. Spironolactone is strictly contraindicated in pregnancy. Its anti-androgenic properties risk inducing ambiguous genitalia in male fetuses, which mandates the continued use of OCPs for contraception during treatment. Alternative systemic therapies include cyperterone acetate, flutamide, and finasteride. Topical options like eflornithine and laser hair removal also provide significant benefit. As a last resort, continuous GnRH therapy is used to aggressively suppress LH and shut down androgen production. One drug is strictly excluded, danazol. It is never used for hirsutism because the condition is a direct side effect of the drug itself. Managing androgen excess is a process of using exogenous steroids to overwrite a corrupted endogenous feedback loop. Managing the female endocrine system follows strict anatomical and biochemical logic. In states of deficiency, an intact uterus necessitates the mandatory co-administration of progesterone to prevent endometrial malignancy. In states of excess, survival and accurate diagnosis rely entirely on the numerical stratification of testosterone and 17-hydroxyprogesterone. Whether replacing depleted hormones or suppressing toxic ones, clinical success depends on mastering the interconnected feedback loops that govern the system.
Polycystic ovarian syndrome is heavily misunderstood. It is often treated in clinical practice as a single, uniform disease with a predictable presentation. In reality, it is a highly heterogeneous clinical syndrome. This juxtaposes morphological ovarian changes with the systemic hormonal web. Together, they form the core diagnostic triad: hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. Because the presentation is so heterogeneous, patient profiles vary wildly. One patient may present primarily with severe menstrual irregularity and thick, dark hair growth known as hirsutism. Another may exhibit zero dermatological symptoms, instead presenting with infertility, severe obesity, and metabolic dysfunction. Despite these completely different clinical pictures, a single pathophysiologic abnormality links them. The central engine driving the entire syndrome is the excess production of androgens. We know that genetics play the largest role in predisposing a patient to this androgen excess, combined with heavy influence from lifestyle and environmental factors. However, the exact physiological event that initiates the cycle remains unknown. Therefore, the term polycystic ovarian syndrome is a clinical misnomer. The name tricks clinicians into focusing heavily on the physical state of the ovary, rather than managing the highly complex systemic endocrine web actually driving the disorder. This node and link systems map maps out the primary biological centers of the disorder. The excess androgens originate mainly from the ovary's theca cells, with a secondary contribution coming from the adrenal glands, a contribution clinically marked by elevated DHEAS levels. The first major defect driving this production occurs at the top of the axis. The GnRH pulse frequency firing from the hypothalamus is pathologically increased, hammering the pituitary node and triggering an overproduction of luteinizing hormone. This rapid pulsing creates a state of persistently high LH without a mid-cycle LH surge. It shifts the standard 1-to-1 ratio of LH to FSH into a highly skewed ratio of 1-to-2, or even 1-to-3. The secondary engine is metabolic. Insulin resistance creates a direct pathway where high circulating insulin overstimulates those exact same theca cells, forcing them to pump out even more androgens. Watch this new path form. Both the excess insulin and the excess androgens travel to the liver, where they depress the liver's production of sex hormone binding globulin, or SHBG. Without enough SHBG to bind the hormones, the patient experiences a massive spike in unbound free testosterone. It is this unbound free testosterone circulating in the blood that binds to peripheral receptors, generating the clinical signs of hyperandrogenism, excessive facial and body hair, severe acne, and androgenic alopecia. Simultaneously, the underlying insulin resistance manifests physically. Patients frequently develop acanthosis nigricans, patches of dark, velvety, thickened skin, typically found on the nape of the neck or the axilla. High GnRH pulses and profound insulin resistance act as dual engines. They trap the patient in a self-reinforcing biochemical loop, where high androgens cause low SHBG, which guarantees even higher free androgens in a constant, unbroken cycle. High concentrations of intra-ovarian androgens are physically folliculotoxic. The hostile environment abruptly halts the natural development of growing ovarian follicles. This medical illustration clarifies the morphology. The classic necklace appearance seen on ultrasound is an accumulation of small, unruptured peripheral follicles. They are not true cysts, which are typically large and fluid-filled. Because follicular development is arrested, a dominant follicle never forms. The patient does not ovulate. Without ovulation, a corpus luteum cannot form, leaving the patient with chronically low progesterone levels. This quantitative scale demonstrates how obesity accelerates the pathology. Excess adipose tissue acts as an active endocrine organ by peripherally aromatizing androgens into estrone. This process actively inverts the healthy 2:1 estradiol to estrone ratio into an abnormal 1:2 ratio. The result is a highly estrogenic environment, completely unopposed by progesterone. Clinically, this causes frequent breakthrough bleeding and places the patient at a highly elevated risk of developing endometrial hyperplasia and eventual endometrial cancer. The polycystic ultrasound image is nearly a visual symptom of a hostile, androgen-soaked, and ovulatory environment. It is the end result of the metabolic dysfunction, not the primary cause of the patient's infertility. This graphic outlines the Rotterdam criteria, the clinical standard for diagnosing PCOS. A positive diagnosis requires any two of three core features: hyperandrogenism, ovulatory dysfunction, or polycystic ovaries on an ultrasound. Notably, obesity, insulin resistance, and an abnormal LH to FSH ratio are explicitly excluded from the diagnostic criteria. The strict threshold for confirming polycystic ovaries on ultrasound is observing 12 or more follicles measuring 2 to 9 millimeters, or measuring an ovarian volume greater than 10 cubic centimeters.
Some newer society guidelines push this threshold to 20 follicles, but the Rotterdam standard remains 12. Because the criteria only require 2 of the 3 signs, completely normal ovaries on an ultrasound do not exclude a PCOS diagnosis. Before confirming the diagnosis, a secondary Amenorrhea workup must be performed. This requires checking a pregnancy test, LH, FSH, estrogen, TSH, and prolactin. Clinicians will also use the progesterone challenge test. Administering progesterone for 5 days and observing a withdrawal bleed proves the patient's endometrium is thick enough to shed, meaning it has already been primed by unopposed estrogen. Here we see the flowchart for 17-hydroxyprogesterone testing. This test is mandatory because late-onset congenital adrenal hyperplasia perfectly mimics PCOS. If the serum level is under 200 nanograms per deciliter, CAH is definitively excluded. Values between 200 and 800 require an ACTH stimulation test, while anything above 800 confirms CAH. You must also differentiate PCOS from premature ovarian insufficiency. POI presents with high FSH and critically low anti-Müllerian hormone. In stark contrast, PCOS presents with normal FSH and high anti-Müllerian hormone due to the high volume of arrested follicles. A PCOS diagnosis is a diagnosis of exclusion. You must biochemically prove the androgen excess and anovulation aren't being manufactured by an adrenal tumor, a thyroid defect, or early glandular failure before you settle on the syndrome. The universal first-line treatment for all PCOS patients, regardless of their specific presentation, is lifestyle modification and weight loss. Dropping excess adipose tissue reduces peripheral estrogen conversion and can restore spontaneous ovulation in up to 10% of cases. Returning to our systems map, dropping combined oral contraceptive pills onto the pituitary node blocks the release of LH and FSH. This suppresses ovarian androgen production and simultaneously forces the liver to raise SHBG levels, making OCPs the first-line defense for menstrual irregularity and hirsutism. If treating severe hirsutism, spironolactone effectively blocks androgen receptors, but it must be avoided entirely if the patient desires a pregnancy. Anti-androgens carry a severe risk of causing ambiguous genitalia in a male fetus. For infertility, Lexazole is the absolute drug of choice. It attacks the adipose node by blocking peripheral aromatase. Lowering systemic estrogen removes the negative feedback on the pituitary, allowing FSH levels to rise and stimulate ovulation. Letrozole replaces older treatments because it yields higher live birth rates, does not cause anti-estrogenic endometrial thinning, and carries a much lower multiple pregnancy risk, sitting at just 3 to 7%. Clomiphene citrate is now the second-line choice. It acts as a selective estrogen receptor modulator, tricking the hypothalamus with a false low estrogen signal. However, it triggers adverse peripheral effects, inducing a thin endometrium and highly viscous, thick cervical mucus that impedes sperm transport. This sequence models laparoscopic ovarian drilling, reserved for refractory cases. The thermal energy destroys androgen-producing theca cells in the ovarian stroma.
Surgeons follow a strict rule of 4 to avoid causing premature menopause. They burn exactly 4 sites for 4 seconds at 40 watts. For severe metabolic symptoms, metformin maps directly to the insulin resistance node. They improves insulin sensitivity, accelerates weight loss, and has a proven safety profile, allowing it to be continued into early pregnancy. There is no single pill to cure the syndrome. Clinical management is entirely complaint-driven. You evaluate the patient's immediate goal, isolate the specific biochemical loop causing the friction, and deploy targeted pharmacology to break the node. If the endocrine loop is left unmanaged, the excess androgens and severe insulin resistance inflict heavy damage on the cardiovascular system. Patients face elevated risks for severe dyslipidemia, coronary artery disease, non-alcoholic steatohepatitis, and sleep apnea. Obstetric and gynecologic risks compound over time. Beyond persistent infertility, patients who do conceive face high rates of gestational diabetes. Long-term, the chronic anovulation guarantees an unopposed estrogen environment, accelerating the risk of endometrial hyperplasia and cancer. To catch metabolic decline early, clinicians enforce a strict systemic surveillance rule. An oral glucose tolerance test is required every 2 years, escalating to yearly testing the moment insulin resistance is confirmed. This transvaginal ultrasound highlights the critical 12 mm threshold. In any reproductive age woman with PCOS, if the endometrial thickness exceeds 12 mm, an endometrial biopsy should be immediately considered to rule out malignancy. PCOS is a lifelong neuroendocrine and metabolic state. It requires constant diagnostic vigilance, rigorous exclusion of mimics, and targeted medical disruption to protect both the patient's immediate reproductive goals and their long-term survival. The menstrual cycle has 2 coordinated systems, the ovarian and uterine cycles. Clinically, day 1 is defined as the first day of menstrual bleeding. This comparative table shows the new normal parameters. Cycle length is 24 to 38 days, bleeding duration 4.5 to 8 days, and blood loss 20 to 80 milliliters. The standard 28-day cycle is actually a minority, experienced by only 15% of females. Because of these updated parameters, legacy terminologies are no longer preferred. Oligomenorrhea for cycles over 38 days, polymenorrhea for cycles under 24 days, hypomenorrhea for bleeding under 3 days, and menorrhagia for bleeding over 8 days. Modern clinical descriptions rely on temporal and volume metrics. We classify deviations as prolonged, shortened, irregular, intermenstrual, or heavy menstrual bleeding. Similarly, dysfunctional uterine bleeding has been subsumed under abnormal uterine bleeding, specifically representing cases of ovulatory dysfunction. By replacing symptom-based labels with precise metrics, clinicians move away from treating vague complaints and identify the specific etiologies driving the bleeding. This split screen illustrates the Palm-Cohen system for abnormal bleeding. Structural causes, PALM, include polyps, adenomyosis, leiomyosis, and malignancy. Non-structural, Cohen, covers coagulopathy, iatrogenic, and not classified. The O is ovulatory dysfunction. Without ovulation, progesterone flatlines, while estrogen stimulates the endometrium until unstable shedding occurs. This hormonal pattern is common during puberty, perimenopause, and in conditions like PCOS or obesity, where peripheral aromatization converts androgens into estrogen. AUBE represents endometrial causes. These patients have regular cycles and a normal-sized uterus, yet suffer heavy menstrual bleeding. In these cases, progesterone levels are normal. The bleeding is caused by localized hemostatic defects, specifically an altered ratio of prostaglandins and increased local fibrinolytic activity. Categorizing into Palm or Cohen determines the management plan: surgical intervention for a physical structure or medical therapy for a physiological error. Before investigating structural or hormonal causes, the initial history must screen for bleeding disorders. In young patients with heavy bleeding, clinicians must ask about easy bruising, excessive bleeding from minor wounds, and any family history of coagulopathy. The physical examination includes general and systemic evaluations, using bimanual and per speculum exams to assess uterine size, contour, and the presence of cervical lesions. There is one absolute clinical exception to this. Per Bartholin bimanual pelvic examinations are strictly contraindicated in a virgin adolescent female.
Baseline investigations for all AUB patients include a hemoglobin trot, a complete blood count, a urine pregnancy test, and cervical cytology. Specific coagulation tests are only indicated for patients with puberty menorrhagia, existing thrombocytopenia, or a positive family history of bleeding disorders. Once laboratory tests are complete, transvaginal ultrasonography serves as the primary imaging modality to identify the structural lesions classified under PALM. These initial steps allow the clinician to rule out pregnancy, cervical cancer, and systemic clotting errors before focusing directly on the endometrial lining. When investigating endometrial pathology, sampling is the preferred diagnostic method. It is an outpatient procedure performed using instruments like the Vabra aspirator or Carman's cannula. This logic gate illustrates the age-stratified biopsy algorithm. The decision to perform a biopsy is determined by the patient's biological age and sonographic endometrial thickness. For women of reproductive age, the pathway requires a negative pregnancy test followed by a transvaginal ultrasound to evaluate for structural findings. In this demographic, a biopsy is indicated if the endometrial thickness is greater than 12 millimeters, if bleeding persists despite a normal ultrasound, or if high-risk factors like obesity or PCOS are present. The perimenopausal demographic is defined internationally as over 45 years of age, or over age 40 in some regional guidelines.
In perimenopausal women with abnormal bleeding, an endometrial biopsy is mandatory regardless of ultrasound findings, due to the higher risk of endometrial hyperplasia. If a postmenopausal woman presents with bleeding, transvaginal ultrasound is the first step used to check the endometrial thickness against a 4 millimeter threshold. If the thickness is less than 4 millimeters, tranexamic acid is given first. Biopsy is only indicated if the thickness exceeds 4 millimeters, if bleeding persists, or if oncologic risk factors are present. If outpatient sampling is insufficient, the gold standard for diagnosis is hysteroscopy with fractional curettage under anesthesia, sampling the endocervix, fundus, cornua, and uterine body. Endometrial thickness is not a universal metric. Its diagnostic value depends entirely on the patient's biological age. In cases of acute severe bleeding where pregnancy and biopsy are negative, management focuses on rapid clinical stabilization. Acute hemorrhage is controlled using high-dose hormones. Options include intravenous estrogen, 50 milligrams of ethinyl estradiol for 5 days, or a high-dose oral contraceptive regimen taken every 4 to 8 hours for 2 days before tapering to a daily dose. After stabilization, chronic management for stable AUB begins with non-hormonal options. This chart details the primary non-hormonal interventions. Tranexamic acid is an antifibrinolytic that reduces bleeding volume by approximately 50% when taken at a dose of 1 gram 3 times daily for 3 to 4 days. Mefenamic acid, taken at 500 milligrams 3 times daily, is a prostaglandin inhibitor used when bleeding is accompanied by dysmenorrhea. Ethansalate is not recommended as it is clinically ineffective for this condition. For mild to moderate bleeding, combined oral contraceptives are generally preferred over oral progesterone due to lower cost and better tolerability. Prescription follows a hemoglobin-based rule. If hemoglobin is below 10 grams per deciliter, continuous OCPs are prescribed for 3 months to stop shedding and allow the patient to rebuild iron stores. If hemoglobin is above 10 grams per deciliter, the patient is prescribed a cyclical regimen of 21 days on and 7 days off for 3 cycles. First-line medical therapy functions by stabilizing the coagulation cascade or suppressing the patient's existing hormonal feedback loops. When treating prolonged bleeding, clinicians must consider the state of the endometrial lining. If the endometrium is thin, progesterone alone often fails because the tissue lacks the estrogen priming needed to create progesterone receptors. For most reproductive and perimenopausal women, the levonorgestrel intrauterine device, or Mirena, is the preferred progesterone method, achieving cycle control in 30 to 40% of cases. If oral progesterone is used, it must be administered for a minimum of 12 days per month to provide adequate protection against endometrial hyperplasia. When medical therapy is insufficient, blood transfusion is indicated for puberty menorrhagia with hemoglobin under 7, or for any patient with hemoglobin under 5, or preoperative hemoglobin under 10 grams per deciliter. Second-line medical therapies include GnRH analogs, limited to 6 months of use, and ormalixifene, a selective estrogen receptor modulator taken twice weekly. This triage flowchart illustrates surgical escalation, which is reserved for patients who have failed medical therapy and completed their families.
The three primary options are ablation, embolization, and hysterectomy. Endometrial ablation involves the destruction of the uterine lining to adapt to 4 to 6 millimeters. However, ablation must never be performed on suspected hyperplasia or cancer. Residual tissue can become malignant beneath the surgical scarring, where it can no longer be effectively monitored. The diagnostic sequence for AUB is a structured framework, using patient age and sonography to determine the biopsy threshold and guide the clinician toward a specific structural or pharmacological intervention. Abnormal uterine bleeding driven by structural pathology typically traces back to one of three distinct anomalies: endometrial polyps, adenomyosis, or leiomyomas, commonly known as fibroids. While clinical history and physical examination provide the necessary starting point, definitive differentiation between these pathologies depends on identifying specific morphovascular sonographic signatures and mapping the lesion's precise topology. This diagnostic precision is especially important in cases of postmenopausal bleeding. While malignancy is often the primary concern, current clinical data clarifies that other structural and atrophic changes are statistically more frequent findings. This chart outlines the modern statistical breakdown for postmenopausal bleeding. Endometrial polyps account for about 37% of cases, followed by endometrial atrophy at 30%. In this hierarchy, endometrial cancer occurs less frequently than these benign causes. Because of this distribution, any patient presenting with structural abnormal uterine bleeding must undergo a strict baseline protocol. This requires a urine pregnancy test and a transvaginal ultrasound. Furthermore, if the patient is 40 years or older, an endometrial biopsy is mandatory. Executing this baseline protocol achieves a critical objective. It definitively separates hyperplastic or malignant mucosal lesions from benign structural pathology, ensuring the clinical path is clear before proceeding to intervention. An endometrial polyp is a focal, localized overgrowth of the endometrium that projects directly into the uterine cavity. While they occur across all age groups, their frequency peaks between 40 and 49 years. Their development is also linked to the use of tamoxifen for breast cancer treatment, which can stimulate endometrial proliferation. Clinically, a polyp presents with irregular or intermenstrual bleeding. However, because the lesion is entirely intracavitary and relatively small, both the abdominal and bimanual pelvic examinations will typically be normal. The uterus does not enlarge. When visualized directly via hysteroscopy, the polyp appears as a red, fleshy, and shiny mass. It extends from a narrow base and lacks the whorled fibrous appearance seen in other smooth muscle tumors. This 2D sonographic schematic isolates the definitive Doppler ultrasound signature of a polyp. Notice the single central feeder vessel running directly into the core of the narrow-based mass. This distinct vascular architecture is the primary method used to distinguish a polyp from a submucous fibroid on imaging. Management depends on exact location. An endometrial polyp requires hysteroscopic polypectomy, utilizing the camera for both diagnosis and targeted treatment. Conversely, an endocervical polyp is removed using a specialized polypectomy hook. Because polyps are strictly intracavitary vascular extensions, they are highly amenable to this targeted extraction. The underlying myometrial integrity remains uncompromised. This microscopic cross-section visualizes adenomyosis. Here, the basal layer of endometrial glands and stroma infiltrates downward, embedding directly within the smooth muscle fibers. This creates a different demographic profile compared to polyps. Adenomyosis primarily affects multiparous women over the age of 40 and shares a high clinical association with endometriosis. The condition drives cyclic bleeding inside the uterine wall itself. Consequently, the single most important clinical symptom reported by patients is menorrhagia, often accompanied by intense secondary dysmenorrhea. On physical exam, this internal infiltration manifests as a symmetrically enlarged globular uterus. It typically reaches a size comparable to a 10 to 12-week pregnancy, rarely exceeding 14 weeks. Palpation reveals another distinct clinical differentiator. The uterus is tender to the touch, a physical exam finding known as the Halban sign. This schematic shows ultrasound findings of adenomyosis. Trapped blood presents as myometrial cysts, while hemorrhagic changes create the Venetian blind appearance. Equivocal cases use MRI. A transition zone of 12 millimeters or greater supports adenomyosis, while under 8 millimeters rules it out. Because the glands are embedded in the muscle, management pathways are direct.
The gold standard is a total abdominal hysterectomy with preservation of the ovaries. If surgery is refused, a levonorgestrel IUD is utilized to induce targeted endometrial atrophy. Adenomyosis symmetrically distorts the myometrial architecture. Definitive resolution, therefore, requires extraction of the organ or localized hormonal suppression to halt the internal cyclic bleeding. A leiomyoma, or fibroid, is a benign smooth muscle tumor arising from the myometrium. Its growth is responsive to the hormonal environment. Estrogen drives proliferation, while progesterone inhibits cellular apoptosis, allowing the tumor to persist. Fibroids are firm, white, and display a classic whorled appearance. They expand from a broad base, compressing the myometrium to generate a vascularized pseudocapsule. Growth topology defines their subtype. They can be intramural, submucous, subserous, or cervical. When extending into the broad ligament, the relationship to the ureter is the key anatomical landmark. Medial positioning indicates a pseudo-broad ligament fibroid, while lateral positioning defines a true broad ligament fibroid.
This diagram isolates the FIGO classification for submucous fibroids. Type 0 is completely intracavitary. Type 1 projects over 50% into the cavity. Conversely, type 2 has less than 50% in the cavity, buried within the muscle. Type 8 designates extrauterine fibroids. This specific mapping dictates surgical feasibility. Type 0 and type 1 lesions allow for hysteroscopic removal. A type 2 lesion, however, is more deeply embedded and requires a laparoscopic approach. A tumor's raw size does not dictate the surgical method. The precise FIGO anatomical mapping determines the surgical route and the likelihood of safe, complete extraction. Symptomatic fibroids most commonly present with heavy menstrual bleeding on regular cycles. Submucous fibroids can cause subfertility by distorting the cavity, but they are only diagnosed as the cause of infertility after all other factors, especially male factor via semen analysis, are ruled out. When pressure symptoms occur, they track to cervical positioning. An anterior cervical fibroid compresses the bladder, causing urinary frequency. A posterior cervical fibroid compresses the urethra, causing urinary retention. Bimanual examination reveals a uterus that is irregularly enlarged, firm, mobile, and notably non-tender. This lack of symmetry and pain directly contrasts with the findings of adenomyosis. This schematic maps the Doppler ultrasound signature of a fibroid. The vascularity is peripheral, hugging the outer pseudocapsule of the broad-based hypoechoic mass. This is the visual inverse of the polyp's single central vessel. Fibroids can undergo specific degenerations over time. Hyaline degeneration is the most common, where the tumor loses its whorled pattern. Calcareous degeneration, typically seen in subserous variants, deposits calcium, resulting in womb stones visible on X-ray. Malignancy is rare, occurring in less than 0.5% of cases as sarcomatosis degeneration. Histologically, it is defined by the presence of 10 or more mitoses per high-power field. Tumors with 5 to 10 mitoses are classified as stump, smooth muscle tumors of uncertain malignant potential. During the second half of pregnancy, rapid growth can outpace blood supply, causing vascular thrombosis. This triggers red degeneration, characterized by acute pain, a salmon-pink tumor appearance, and a fishy odor. Because red degeneration is driven by internal thrombosis, it is an aseptic process. Recognizing this mechanism prevents mismanagement. The condition requires conservative analgesics and intravenous fluids, while strictly forbidding the use of antibiotics, termination, or surgical myomectomy. Modern management protocols have discarded the older 12-week rule for removal. Today, asymptomatic fibroids do not require treatment regardless of their size, with 2 exceptions: submucous fibroids and bilateral corneal intramural fibroids that are causing infertility. For symptomatic patients, first-line medical therapies like tranexamic and oral contraceptives reduce bleeding only. Second-line medications, such as continuous GnRH agonists and antagonists, can shrink the tumor volume while controlling the hemorrhage. When medical therapy is insufficient and the patient's family is complete, non-surgical necrosis techniques are utilized. These include high-intensity focused ultrasound, or uterine artery embolization, where particles are injected via the femoral artery to occlude the uterine blood supply. If the patient requires preserved fertility, a myomectomy is indicated.
This carries preoperative prerequisites, an endometrial biopsy to rule out hyperplasia, anemia correction, and scheduling the surgery during the pre-ovulatory phase. To manage the bleeding risk from the tumor's pseudocapsule, pharmacological protocols include hypotensive anesthesia and direct local vasopressin injections into the myometrium. This anatomical vector schematic shows a mechanical blood loss reduction technique utilizing the bonus myomectomy clamp. Applied in 20-minute intervals, the clamp occludes both the bilateral uterine arteries and the round ligament simultaneously. Surgical extraction of a fibroid is a precisely constrained procedure. It relies on preoperative shrinkage and intraoperative vascular isolation to bypass the tumor's high-flow pseudocapsule and prevent excessive blood loss. Diagnosing structural abnormal uterine bleeding requires a disciplined approach. Clinicians must synthesize the patient's clinical history and physical findings with strict morphovascular imaging data. This clinical matrix outlines the final differential framework. The endometrial polyp is defined by intermenstrual or postmenopausal bleeding, attached by a narrow base and fed by a single central vessel. Adenomyosis presents with severe menorrhagia. It is identified by a symmetrically enlarged, tender globular uterus and supported by an MRI transition zone measuring 12 millimeters or greater. Finally, the leiomyoma frequently presents as a firm, irregular, non-tender mass. Its diagnosis hinges on peripheral sonographic vascularity, and surgical intervention is governed by its FIGO mapping parameters. By isolating precise sonographic signatures and topological mapping, clinicians move beyond general assessment to secure an evidence-based diagnosis, ensuring the safest and most effective patient outcomes. Endometriosis is defined by a specific anatomical error, the presence of functional endometrial glands and stroma located outside the uterine cavity. This microscopic simulation shows how that ectopic tissue behaves. Because it remains hormonally responsive, primarily to estrogen, it undergoes the same cycle of proliferation, engorgement, and shedding as the normal uterine lining. During normal menstruation, this shed tissue and blood have a clear anatomical exit. But when this biological process occurs in ectopic locations, like the ovaries or the peritoneal cavity, the bleeding is structurally trapped. With no way for the blood to escape, the body mounts an immune response. Repeated monthly bleeding at these ectopic sites triggers localized inflammation, which builds into dense fibrosis, adhesion formation, and the gross distortion of pelvic anatomy. The disease state is tied to the patient's hormonal cycle. When estrogen levels fall and progesterone predominates, as happens during pregnancy, or when estrogen levels drop during menopause, the ectopic tissue naturally regresses. Misplacing functional, actively cycling tissue into a confined anatomical space generates a progressive, debilitating, and chronically inflammatory condition. The clinical occurrence of endometriosis tracks with reproductive hormone cycling, peaking in incidence among women between the ages of 25 and 35. This timeline illustrates the concept of cumulative estrogen exposure, a life cycle marked by early menarche, late menopause, nulliparity, and short menstrual cycles increases the total number of periods a woman experiences. More cycles result in a higher lifetime estrogen burden, which accelerates disease risk. When endometriosis presents in an adolescent, diagnostic priorities shift. The immediate requirement is to rule out structural outflow obstructions, such as an imperforate hymen or other Müllerian anomalies, which mechanically force menstrual blood backward. There is also a clear genetic component. The disease clusters in families, often appearing in mothers and sisters, with researchers linking the KRAS gene mutation to increased predisposition. Conversely, anything that suppresses total local estrogenic stimulation acts as a protective factor. Multiparity creates longer windows of progesterone dominance. Oral contraceptives suppress endometrial proliferation. Even smoking decreases local estrogen production and inhibits aromatase. Total cumulative estrogen volume is the primary accelerator of the disease. A patient's reproductive timeline is the main predictor of risk. Understanding how functional endometrial tissue escapes the uterus to seed itself in systemic locations requires examining 4 distinct trajectories. This diagram illustrates Sampson's implantation theory. During menstruation, debris flows backward through the fallopian tubes, entering the peritoneal cavity. This explains the predictable hierarchy of pelvic distribution. The ovary is the most common target, followed by the pouch of Douglas, broad ligament, and uterosacral ligament. Retrograde flow cannot easily explain lesions found far outside the pelvis. For that, Albin's theory of lymphatic spread accounts for how ectopic tissue travels through the lymphatic network to reach distant, non-contiguous sites, such as the umbilicus. To explain findings in remote areas like the lungs, Even's theory of coelomic metaplasia proposes that peritoneal tissue transforms into endometrial tissue under specific hormonal or inflammatory stressors. Finally, direct implantation occurs when endometrial cells are mechanically transferred during surgical procedures, causing scar endometrial cells following cesarean sections or episiotomies. Together, these four mechanisms explain a disease capable of infiltrating virtually any physiological system in the body. It is critical to separate endometriosis from overlapping gynecological conditions. Fibroids and adenomyosis typically manifest as bleeding disorders. Endometriosis is a pain disorder. The classic diagnostic triad consists of secondary dysmenorrhea, dyspareunia, and infertility. In practice, the combination of secondary dysmenorrhea and painful intercourse in a nulliparous woman provides a highly reliable diagnostic heuristic pointing to endometriosis. Because the ectopic tissue responds to monthly hormonal cues, patients may experience vicarious menstruation, bleeding from abnormal sites during their period, such as epistaxis or bleeding from the umbilicus. Similarly, cyclical hematuria points to bladder wall involvement, while catamenial pneumothorax, a collapsed lung occurring strictly during menstruation, confirms pleural infiltration. The symptoms are dictated by the precise anatomical location where the ectopic implant bleeds. The infertility caused by endometriosis is driven by structural failures. The inflammatory state leads to abnormal follicular growth, anovulation, and distorted tubo-ovarian anatomy caused by physical adhesions. At the cellular level, the trapped bleeding creates an inflammatory peritoneal environment that degrades oocyte quality and reduces the overall ovarian reserve. Pelvic pain is driven by local prostaglandin production, the tearing of internal adhesions, and direct physical irritation of pelvic nerves. This cross-section highlights a vital diagnostic rule. A wide, superficial spread of lesions generates less neurological involvement than a single, deeply penetrating lesion involving a nerve root. The severity of a patient's pain correlates with the depth of the invasion, not the overall surface area. Macroscopic visual extent is a poor proxy for predicting patient morbidity. Microscopic depth dictates the clinical severity. Physical evaluation reveals the first specific evidence of anatomical distortion. A classic finding is a retroverted, fixed uterus. This immobility differentiates the fibrotic tethering of endometriosis from the manually correctable retroversion seen in a standard uterine prolapse. Transvaginal sonography serves as the mandatory first-line screening modality, primarily used to assess the ovaries for obvious ectopic disease. This split screen compares a simple cyst against an ovarian endometrioma. A simple cyst presents as a clear anechoic void. In contrast, the endometrioma contains accumulated hemosiderin-stained blood, creating a dense array of homogeneous internal echoes and a distinct ground glass appearance. Initial imaging carries an absolute limitation. The absence of a chocolate cyst on ultrasound does not rule out the presence of systemic endometriosis elsewhere in the pelvis. Advanced diagnostics also have distinct boundaries. Biomarkers like CA-125 can elevate above 100 IU, but this lacks the specificity required for diagnosis. MRI is largely reserved for mapping deep infiltrating disease, such as rectosigmoid involvement. Therefore, laparoscopy remains the definitive investigation of choice, allowing clinicians to bypass imaging artifacts and achieve dual diagnostic and therapeutic access. Direct visualization allows for accurate staging based on lesion morphology. Fresh implants present as bright red flame lesions, while chronic disease appears as bluish-black powder-burn nodules. The gold standard for diagnosis requires surgical extraction and histopathology, confirming the presence of both endometrial glands and stroma. A definitive diagnosis requires direct surgical visualization and microscopic tissue biopsy. Managing endometriosis requires balancing immediate symptom control against long-term fertility preservation.
For mild presentations, baseline medical therapy mimics the treatment for primary dysmenorrhea, utilizing NSAIDs and ovulation suppression to limit cyclic bleeding. Escalating therapy requires hormonal suppression to reduce the estrogenic stimulation of ectopic tissue. Options include oral progesterone, levonorgestrel IUDs, letrozole, and GnRH agonists or antagonists. Misoprostol is contraindicated. Because it is prostaglandin-driven, it will actively exacerbate patient pain. Escalation to surgery is indicated when medical therapy fails, when there is structural distortion, or when dealing with chocolate cysts and deep bowel or bladder involvement. Surgical interventions range from laparoscopic adhesiolysis and nerve ablation to total abdominal hysterectomy, designed to eliminate the source of retrograde menstruation. Medical therapy chemically arrests disease progression, while surgery seeks mechanical correction. OATs have limitations in resolving chronic pain if structural damage or nerve involvement is extensive. When a patient seeks pregnancy, management depends on disease severity. Minimal to mild endometriosis is treated as unexplained infertility, utilizing clomiphene citrate and IUI for up to 3 cycles. For moderate to severe disease, clinicians bypass IUI and proceed directly to in vitro fertilization. This brings us to the protocol for managing an endometrioma in a patient desiring pregnancy. In this decision tree, a patient desiring pregnancy routes directly to IVF. Surgery is avoided because it permanently compromises ovarian reserve. If pregnancy isn't desired, cysts under 5 centimeters are observed. Larger or symptomatic cysts require laparoscopic cystectomy and histopathology. Endometriosis is an estrogen-fueled inflammatory state. Accurate diagnosis demands direct visualization, and clinical management requires absolute respect for the patient's reproductive timeline.
When a patient presents with vaginal discharge, it is one of the most common complaints in gynecology. Yet the underlying cause can be anything from completely normal physiology to a severe upper tract infection. The clinician's first task is not to immediately identify the pathogen. The immediate goal is to determine exactly what kind of discharge is present and precisely where the problem is located anatomically. This requires stepping back from immediate treatment and relying on 3 targeted physical examinations: a speculum exam to view the cervix, a bimanual or pervaginal exam to feel the pelvic organs, and targeted microscopy of the secretions. Not all discharge is a sign of disease. A normal, healthy patient experiences physiological leukorrhea, an odorless, colorless, or white secretion that naturally fluctuates in volume and consistency around ovulation and menstruation. Consistency alone cannot prove infection. To treat pathological discharge effectively, a clinician has to abandon microbiological guesswork. They must instead rely on strict clinical pattern recognition to map specific symptoms to their precise anatomical zones. The healthy vagina functions as an active, armed ecosystem. It is a biological space that is far from sterile. The foundation of this ecosystem is a group of gram-positive rods called Döderlein bacilli, which colonize the space from puberty until menopause. This defense system is highly dependent on estrogen. Estrogen ensures the stratified squamous epithelium of the vaginal walls stays thick and tightly packed with glycogen. The Döderlein bacilli metabolize that released glycogen, converting it into hydrogen peroxide and lactic acid. As a result, the vaginal pH drops strictly below 4.5. This continuous, highly acidic environment acts as an invisible shield that repels most foreign pathogens attempting to colonize the tissue. Pathological vaginal discharge rarely occurs randomly. It is almost always a measurable failure of this specific pH-driven ecological defense. The most common failure of this defense is bacterial vaginosis, or BV. But BV is best understood as an ecological disturbance rather than a classic inflammatory invasion. Looking at this split-screen comparison table, the left side shows what happens in bacterial vaginosis. The acidic shield drops, and the pH rises above 4.5, allowing anaerobic bacteria like Gardnerella to overgrow. Notice the PMN to epithelial cell ratio stays below 1, indicating an almost total lack of local tissue inflammation. Clinically, this presents as a dirty, grayish-white discharge with a distinct fishy odor. Because there is minimal inflammation, patients typically do not experience significant itching or pain during urination. Diagnosis relies on Amsel's criteria. A clinician needs to observe 3 out of 4 specific markers: the elevated pH, the grayish discharge, a positive whiff test, and the presence of clue cells, epithelial cells coated in adhering bacteria, under a microscope. Vulvovaginal candidiasis, shown on the right side of the table, is the opposite. Here, the pH remains strictly below 4.5, but the PMN to epithelial cell ratio spikes above 2, signaling an intense inflammatory response. The primary culprit is Candida albicans. Unlike most pathogens, Candida is an exception to the rules. It thrives in highly acidic environments, rapidly multiplying during pregnancy, uncontrolled diabetes, or after a course of antibiotics. This fungal overgrowth triggers intense pruritus, or severe itching, along with a scanty, curdy white discharge resembling cottage cheese. The external irritation is often so severe that urine touching the inflamed vulva causes sharp burning, known as splash dysuria. A patient may report white discharge in both conditions, but the biochemical realities are entirely different. One is a non-inflammatory shift in bacterial flora, and the other is an aggressive, highly inflammatory fungal reaction. The third major vaginitis pattern comes from an external invader. Trichomonas vaginalis is a sexually transmitted, flagellated protozoan that triggers massive local inflammation. It produces a frothy, foul-smelling yellow-green discharge. The vaginal pH pushes past 4.5. The whiff test is usually positive, and a speculum exam often reveals an intensely red strawberry cervix. This map of the female reproductive tract shows a critical boundary line. Once we move from the lower vaginal canal up into the cervix, the rules of infection shift. The vaginal walls are lined with tough, resilient squamous cells, but as we highlight the inner canal, we see the endocervical columnar epithelium, a fragile, single-layer tissue that is highly vulnerable to sexually transmitted pathogens like chlamydia and gonorrhea. Inflammation here, known as cervicitis, is deceptive. Up to 80% of cases are entirely asymptomatic. When symptoms do appear, they often present as purulent discharge or postcoital bleeding. Because the symptoms overlap, you cannot separate vaginitis from cervicitis based on the patient's history alone. A speculum examination is required to visually verify if that specific columnar epithelium has been compromised. If cervicitis goes undetected, those sexually transmitted pathogens continue to ascend, moving past the cervical boundary and entering the normally sterile upper genital tract. The moment a patient reporting vaginal discharge also complains of lower abdominal pain, the diagnostic protocol pivots. The clinician must perform a bimanual per-vaginal examination. Finding uterine, adnexal, and cervical motion tenderness during this physical exam changes the diagnosis. It indicates the localized infection has escalated into pelvic inflammatory disease, or PID. Untreated PID can lead to permanent tubal scarring and infertility. The infection can even spill out of the fallopian tubes into the peritoneum, causing perihepatitis, a severe complication known as Fitzhugh-Curtis syndrome. Because the stakes are high, there is a mandatory clinical safety protocol. Before administering any PID treatment, a clinician must categorically rule out an ectopic pregnancy, typically using a simple urine pregnancy test. The bimanual exam serves as the physical firewall. It tells the clinician whether the pathogen is contained below or if it has breached the upper pelvic cavity. In high-volume clinics or resource-limited settings, waiting days for targeted microbiological cultures to confirm a pathogen is often impossible. Patients need immediate, effective care. To bypass laboratory delays, the National AIDS Control Organization, or NACO, established strict guidelines in India. They standardized treatment based entirely on observable symptom clusters. This is the core philosophy of syndromic management. It converts the findings from the physical examinations directly into the prescription of prepackaged multi-drug eradication kits. This algorithm does not ignore the underlying microbiology. Instead, it relies on mathematical probability to predict it, ensuring the most statistically likely pathogens are targeted and destroyed immediately. Looking at this flowchart, the first pathway is clear. If the speculum shows a healthy cervix and the bimanual exam is normal, the diagnosis is vaginitis. This triggers the use of the green package, designated as Kit 2. Kit 2 delivers secnitazole and fluconazole for bacterial and fungal vaginitis. Treating the sexual partner is unnecessary. The second pathway activates if the speculum reveals an unhealthy cervix with a normal bimanual exam.
The diagnosis is cervicitis, treated with the gray package, Kit 1. Kit 1 contains azithromycin and cefixamine. Since cervicitis is sexually transmitted, treating the sexual partner is mandatory. Finally, if the patient has lower abdominal pain and cervical motion tenderness, the infection has ascended. This pelvic inflammatory disease triggers the yellow package, Kit 6. Across all these algorithmic pathways, physical treatment must be paired with post-treatment protocols. Patients are advised to practice 7 days of absolute abstinence, followed by consistent condom use. Managing vaginal discharge effectively involves mapping the microscopic ecosystem, pinpointing the physical boundary of the infection, and applying the precise algorithmic strike to restore biological order.
The inner lining of the fallopian tube relies on an intricate rhythmic motion. Microscopic ciliated cells constantly sweep fluid and ovum toward the uterus. It is an incredibly delicate environment, highly vulnerable to structural disruption. Once these cells are damaged by infection, the resulting scar tissue can permanently block the pathway to conception. When a female patient presents with lower abdominal pain, abnormal discharge, menstrual disturbances, or unexplained infertility, the clinical picture is often vague. The symptoms overlap with dozens of common conditions, but buried within this nonspecific presentation are two major differential diagnoses that require immediate attention: pelvic inflammatory disease, or PID, and genital tuberculosis. At first glance, they mimic each other. Pathologically, they are entirely distinct. PID is typically an acute or subacute polymicrobial infection that ascends from the lower reproductive tract. Genital TB, conversely, is a chronic, clinically silent granulomatous disease. Despite these opposing mechanisms, both diseases converge on the exact same endpoint. They destroy the fallopian tubes, they cause severe pelvic adhesions, and they dramatically elevate the lifetime risk of an ectopic pregnancy. Because their diagnostic timelines and treatment protocols are entirely opposed, misdiagnosing one for the other guarantees the exact outcome we are trying to prevent. The clinical task is to identify the specific pathogen profile before irreversible anatomical damage occurs. PID is defined by its upward trajectory. It is an ascending polymicrobial infection, classically driven by sexually transmitted organisms like chlamydia and gonorrhea, peaking in frequency among sexually active women of reproductive age. This diagram shows exactly how upward infection is naturally or artificially halted. Because PID ascends from the lower tract, barrier contraception, like condoms, directly intercepts the pathogens. Mirena intrauterine devices offer protection by releasing progesterone, which thickens cervical mucus and physically blocks microbial ascent. In contrast, insertion of a copper T transiently increases PID risk by breaching the cervical barrier without protective hormones. Genital TB takes an entirely different route. Primary sexual transmission of tuberculosis is exceedingly rare. Instead, it is a secondary infection. Mycobacterium tuberculosis typically establishes a primary focus in the lungs, later disseminating hematogenously or through the lymphatic system directly into the pelvic organs. Because of this rich vascular supply, the fallopian tubes are the primary targets for disseminated mycobacteria. They are involved in 90 to 100% of all genital TB cases. The microscopic destruction is sequential and severe. The infection begins as endosalpingitis, then rapidly deteriorates into caseous necrosis and heavy fibrosis. As the ciliated secretory cells are destroyed, fluid accumulates in the obstructed lumen, creating a hydrosalpinx. From the tubes, the bacteria spread downward. They colonize the superficial layers of the endometrium. The ovaries are the third most common site of infection, while the vulva and vagina remain the rarest. Tracing these distinct vectors, PID climbing up the reproductive tract and TB dropping in from systemic circulation, explains why their early tissue targets and clinical warning signs are so different. PID announces itself. Patients typically present with bilateral lower abdominal pain that actively worsens around menstruation, often accompanied by vaginal discharge, dyspareunia, and fever. If the inflammation extends upward beyond the pelvis, it can reach the liver capsule. This results in right upper quadrant pain and the classic violin string adhesions between the liver and the anterior abdominal wall, a condition known as Fitzhugh-Curtis syndrome. the danger of PID demands an aggressive clinical response. The CDC minimum criteria state that lower abdominal pain, combined with cervical motion tenderness, uterine or adnexal tenderness, is sufficient to begin empirical antibiotic therapy. You do not wait for test results. Genital TB, conversely, operates quietly. It typically surfaces in women aged 20 to 30. Instead of acute pain, patients report long-term frustrating symptoms, persistent infertility, chronic and vague pelvic pain, menstrual irregularities, and systemic constitutional signs like a low-grade fever and weight loss. Certain demographic red flags must immediately shift your suspicion away from PID. If a virgin, a postmenopausal woman, or a patient with an IUD presents with chronic PID-like symptoms that refuse to clear on broad-spectrum antibiotics, genital TB must rise to the top of the differential. PID acts as a loud, painful alarm requiring immediate intervention. Genital TB is a silent structural destroyer, hiding behind atypicals. This split screen highlights a critical diagnostic rule. Both diseases can produce a visual phenomenon called the beads on string appearance, but the meaning of this descriptor changes entirely depending on the imaging modality you are using. Look at the ultrasound representation on the left. Ultrasound excels at detecting fluid and swelling. In PID, you will see tubo-ovarian masses, swollen fluid-filled tubes, and the cogwheel appearance. If you see beads on string on an ultrasound, it indicates acute inflammation and points to PID. Now look at the right pane representing hysterosalpingography, or HSG, which maps the internal contour of the tube. In genital TB, the chronic fibrotic scarring creates rigid, distorted structures, a lead pipe appearance, a tobacco pouch, a corn stick, or a bilateral cornule block. If you see the beaded tube appearance here on an HSG, it points directly to the strictures of genital TB. There is an absolute contraindication to keep in mind. You must never perform an HSG if you suspect active genital TB. Injecting contrast dye under pressure can disseminate the mycobacterial infection further into the pelvic cavity. To safely confirm TB, you need histopathological proof. Because the mycobacteria target the superficial layers of the endometrium, you collect tissue during the premenstrual phase or use first-day menstrual blood for highly specific PCR and culture testing. Relying on visual descriptors without understanding the physics of the underlying test is a trap. Precise nodality correlation ensures you are measuring the right pathology. Leaving PID untreated allows the acute inflammation to transition into permanent scarring. This leads directly to tubal factor infertility and severely increases the likelihood of a fertilized egg becoming trapped, resulting in a life-threatening ectopic pregnancy. Outpatient PID treatment relies on broad empirical suppression. The standard regimen includes a single 250 mg intramuscular injection paired with 2 oral antibiotics, typically 100 mg and 400 mg, both taken twice daily for a strict 14 days. In resource-limited settings, this is streamlined into syndromic management. After confirming a negative pregnancy test, the patient is provided the yellow kit 6, which contains the exact oral antibiotic combination, while the partner is treated with kit 1. Oral therapy isn't always enough. Inpatient intravenous admission is mandated if the patient exhibits severe illness, develops a pelvic abscess, is pregnant, or is simply unable to tolerate oral medications. IV therapy continues until 24 hours after the patient's fever resolves. They are then discharged to complete the standard 14-day oral course. Partner treatment and a minimum of 7 days of abstinence are strictly required to prevent immediate reinfection. Genital TB requires a vastly different commitment. Management relies on Category 1 anti-tubercular therapy, delivering a rigorous course of systemic, specialized antibiotics over a full 6 months. To address the severe intrauterine damage TB leaves behind, surgical interventions like hysteroscopic separation of the uterine walls, backed by a 3-month course of estrogen and progesterone, may be necessary. For patients hoping to conceive, the tubal pathology is often irreversible, making in vitro fertilization the only viable reproductive option. PID demands immediate empirical treatment to rescue the architecture of the fallopian tubes. Genital TB requires definitive molecular proof before committing a patient to a half year of systemic therapy and accepting that structural fertility may already be lost. The differential diagnosis rests on timeline and testing. PID is an acute event diagnosed at the bedside. Genital TB is a chronic disease confirmed under the microscope. Always verify the imaging modality. Beads on string on ultrasound points to PID. Beads on string on HSG points to genital TB. PID hurts first. Genital TB destroys quietly. By accurately distinguishing the painful ascending infection from the silent blood-borne mimic, you protect patients from the irreversible loss of their fertility and the heavy physical toll of unwarranted therapies.
Precise. This simulation of a heavy weight dropping onto a taut fabric hammock demonstrates the mechanical challenge of human bipedalism. The human pelvis operates as an intricate suspension bridge, locked in a lifelong fight against gravity and dynamic shifts in internal pressure. When that pressure wins, we see pelvic organ prolapse. In gynecology, this is defined strictly as a herniation of the pelvic floor. It occurs through progressive stretching, weakening, and eventual tearing of the endopelvic fascia and musculature, allowing pelvic organs to drop from their normal positions. The forces that overwhelm this barrier are both cumulative and acute. Multiparity and aging physically degrade the tissues. Connective tissue disorders like Marfan or Ehlers-Danlos syndrome weaken the biological material itself. Meanwhile, chronic spikes in intra-abdominal pressure from obesity, chronic coughing, or heavy lifting constantly stress the system until it yields. When failure occurs, it presents in two distinct clinical categories. Uterocervical prolapse involves the descent of the uterus and cervix. Managing it depends entirely on the patient's age, parity, and desire for future fertility. Vaginal prolapse, however, is the descent of the vaginal walls and nearby organs. Its management is dictated purely by identifying and repairing the specific anatomical defect. Pelvic organ prolapse is a failure of support. Correction requires identifying which specific load-bearing cables have snapped and then reconstructing the internal anatomy, rather than merely managing superficial symptoms. Because prolapse typically presents as a mass descending through the vagina, it immediately introduces a high-stakes clinical differential. The clinician must differentiate pelvic organ prolapse from its most dangerous mimic, uterine inversion. This animated sagittal cross-section demonstrates the anatomy of a uterocervical prolapse. Notice the slow, downward anatomical displacement. The anatomy remains intact, and the cervix, specifically the external os, drops down to become the lowest leading point of the herniation. Now the diagram shifts to uterine inversion. The mechanics are entirely different. The fundus collapses downward, turning completely inside out. It pushes through the cervix like a sock, leaving the fundus as the presenting mass and hiding the cervical os. The clinical realities of these two events are starkly opposed. Prolapse is a chronic, gradual condition, characterized by a painless dragging sensation. Uterine inversion is a sudden, acute, often iatrogenic obstetric complication that triggers severe pain and immediate hemorrhagic shock. Recognizing the leading edge of the herniation, verifying whether you are looking at an external os or an inverted fundus, dictates the entire clinical response. It tells the physician whether they have months to plan a meticulous surgical repair or mere minutes to save the patient's life. To understand how the pelvis fails, we have to construct its healthy architecture. The baseline geometric defense is alignment. The healthy uterus sits in an anteverted and anteflexed position. This exact angle ensures that spikes in intra-abdominal pressure are directed safely forward into the pubic bone and bladder, rather than acting as a downward piston through the open vaginal canal. This 3D superior view illustrates the muscular foundation holding that alignment in place. Inside the bony pelvis, the diamond-shaped perineum acts as the base, centered around the perineal body, a dense fibromuscular anchor where multiple support muscles converge. Above this sits the levator ani complex, the pubococcygeus, the iliococcygeus, and most importantly, the puborectalis. This muscle group forms a hammock that physically closes the urogenital hiatus. The arrows indicate its dynamic upward pull, constantly firing to resist abdominal pressure. It is equally important to know which muscles do nothing to support the uterus. The lateral muscles, the ischiocavernosus, coccygeus, piriformis, and obturator internus, are entirely uninvolved in preventing uterine descent. The muscles provide the floor, but the ligaments provide the suspension. These are condensations of endopelvic fascia. The cardinal, or Mackenrott's ligament, anchors the cervix strongly to the lateral pelvic wall.
The uterosacral ligament pulls posteriorly toward the sacrum, and the pubocervical ligament pulls anteriorly. Notably absent from the suspension network is the broad ligament. Despite its name, it is a peritoneal fold carrying vessels, fallopian tubes, and embryological remnants. It bears zero structural load. Human pelvic anatomy relies entirely on this specific matrix of fascial cables and muscular hammocks. If a single central anchor or lateral cable fails, the load shifts abruptly, compromising the entire network. The first step toward collapse is often a loss of geometric alignment. When the uterus shifts into retroversion, its axis aligns perfectly with the vaginal axis. The uterus is now positioned directly over an open drop, turning the vaginal canal into a slide. We classify the failure using Delancey's 3 levels of vaginal support. This diagram divides the vaginal canal into 3 horizontal zones. The uppermost third is level 1, suspension support, maintained by cardinal and uterosacral ligaments. Defects cause uterocervical prolapse, vault prolapse, enteroceles, and supravaginal cervical elongation. Moving down to the middle third, we find level 2, attachment support. Here, the endopelvic fascia attaches laterally to the arcus tendineus. When these lateral attachments tear, the walls collapse inward, causing anterior cystoceles and posterior rectoceles.
The lowest third is level 3, fusion support, where the vaginal wall fuses directly with surrounding structures. Breakdown results in urethroceles, low rectoceles, and deficient perineum. The term prolapse implies a single condition, but the reality is highly localized. The anatomy breaks down at specific depths and vectors, creating distinct clinical phenotypes that demand highly specific zonal repairs. To map those localized failures, the medical community abandoned Shaw's historical introitus-based grading system. It was replaced by the Pelvic Organ Prolapse Quantification System, or POPQ, an objective, reproducible, site-specific standard. This matrix represents the standard 3x3 POPQ grid. The mechanical reference point is always the hymen. Measurements taken above the hymen are recorded as negative numbers. Any prolapse tissue descending below the hymen is recorded as a positive number. 6 distinct points in A, BA, AP, BP, C, and D map the exact depth of the anterior, posterior, and apical compartments. The resulting measurements dictate the severity, from stage 0, indicating normal support, down to stage 4, known as procedentia, where there is complete eversion of the anatomy outside the body. The hardest technical challenge in this mapping process involves the posterior compartment. When the posterior wall bulges forward, the clinician must physically differentiate whether the sac contains small bowel, an enterocele, or the rectum itself, a rectocele. The clinical signs are distinctly tied to the physics of the organs. Enteroceles occur high in the upper wall. Because they contain loops of bowel, they transmit a positive cough impulse, allow transillumination of light, and are felt on the very tip of the examiner's finger. Rectoceles sit lower. They lack a cough impulse, present with significant constipation, block transillumination, and are palpated with the pulp of the finger. Objective quantification and precise physical differentiation are mandatory. If a surgeon opens the posterior wall expecting a rectal defect and encounters a herniated sac of small bowel, the operative plan must change instantly. Because of these overlapping variables, preoperative evaluation relies on a strict 7-step protocol. The clinician must repose the prolapse manually, check for occult incontinence, empty the bladder, examine each compartment separately with the Sims speculum, differentiate the contents, force maximum descent using the Valsalva maneuver, and finally measure uterocervical length to check for elongation. Step 2 of that protocol, checking for occult incontinence, uncovers a dangerous anatomical trap. This cross-section shows a massive cystocele. As the anterior wall collapses outward, it physically folds and kinks the adjacent urethra. This mechanical kink temporarily blocks urine flow, entirely masking underlying stress urinary incontinence. To find the truth, the clinician manually reposes the prolapse tissue, physically unkinking the urethra, and then asks the patient to cough with a full bladder. If this step is skipped, the surgeon will perfectly reconstruct the anatomy, only for the patient to immediately develop severe incontinence because the urethral kink is pawn. A thorough exam also targets decubitus ulcers on the prolapse tissue.
These are often misattributed to external friction, but they are actually caused by severe venous congestion and ischemia. Surgery must be delayed until they are healed through manual reduction, topical estrogen, and antiseptic packing. Restoring anatomy blindly without unmasking the body's hidden mechanical compensations, like a kinked urethra or ischemic tissue, almost guarantees that the patient will be left in a structurally correct but functionally worse state. Once the evaluation is complete, the surgical pathway branches based on a firm rule. Vaginal defects are repaired purely to correct the anatomy, while uterocervical operations are strictly governed by the patient's age, parity, and desire for future fertility. Vaginal repairs isolate the specific broken fascia level. Anterior colporrhaphy placates the pubocervical fascia to fix cystoceles. Posterior colpoperioneuraphy rebuilds the perineal body for rectoceles. And a McCall coltoplasty obliterates the pouch of Douglas to eliminate enteroceles. This flowchart maps the algorithmic path for uterocervical failure. If a patient desires future fertility, uterus-preserving slings are considered, with the modern gold standard being sacrohysteropexy. This procedure uses a mesh to anchor the cervix directly to the sacrum, preserving the uterus, though future deliveries will require a cesarean section. For women of reproductive age no longer desiring fertility, a Fothergill's or Manchester repair is an option, involving cervical amputation, which deliberately sacrifices cervical competence. Finally, for menopausal or elderly patients, vaginal hysterectomy is the preferred route. If the patient is entirely unfit for major surgery and no longer sexually active, an obliterative Lefort colpoclysis seals the vaginal canal completely. If the patient already had a hysterectomy and suffers from vault prolapse, a pure level 1 failure, sacral colpopexy is the most durable anatomical fix. Crucially, a Birch colposuspension will not fix a descending vault. It is strictly an operation for stress urinary incontinence. Managing pelvic organ prolapse requires calculating load-bearing vectors and unmasking hidden mechanical compensations. Success depends on the precise reconstruction of the fascial matrix to maintain internal anatomy against the constant force of gravity. In medical training, it's tempting to treat clinical syndromes as lists to memorize, but rote memorization is fragile, leading to inefficiency and clinical error. You don't need to memorize these lists. Major syndromes in urogynecology and reproductive endocrinology follow from basic axioms of biomechanics and molecular biology. We'll deconstruct physical support failures, map hydrostatic plumbing leaks, and trace pathological capillary cascades. Once you identify the physiological point of failure, the resulting clinical picture, from symptoms to surgical intervention, becomes predictable. Stress urinary incontinence happens when the anatomical closure system fails under physical load. This diagram shows the requirements for continence. For the urethra to stay closed, two things must work together: an active squeeze from the external urethral sphincter, and a supportive fascial hammock sitting directly beneath the bladder neck. When intra-abdominal pressure spikes from a cough or a sneeze, that force pushes down on the bladder. If the hammock is intact, it resists that force. The downward pressure compresses the urethra against the firm hammock beneath it, sealing it shut and preventing a leak. If that fascial hammock is weak, the mechanics change. The pressure pushes the bladder down, the weak hammock yields, and the urethra gapes open. This mechanical failure is why the Q-tip test works. By placing a Q-tip inside the urethra and bearing down, we visualize the hypermobility of a loose hammock. As downward pressure forces the poorly supported urethra to move, the rigid Q-tip tilts dynamically upward. The Q-tip test does not evaluate the bladder. It measures anatomical hypermobility under physical stress. To treat SUI, the goal of surgery is to restore the supportive vectors to the urethra so it can resist pressure. The Birch colposuspension takes an abdominal route to anchor the proximal urethra and bladder neck upward to the iliopectineal or Cooper's ligament. This abdominal vector provides the most durable support, which is why Birch remains the gold standard. However, it requires invasive abdominal surgery. The transobturator tape, or TOT, uses a vaginal route to suspend the mid-urethra, anchoring the tape laterally to the obturator foramen. This provides support while avoiding the retropubic space. By contrast, the tension-free vaginal tape, or TVT, also supports the mid-urethra from the low, but it passes vertically through the retropubic space, introducing direct risk to the bladder and venous plexus. Surgical selection is a calculation. You weigh the mechanical support of an abdominal vector against the safety of a vaginal approach. Urinary fistulas follow the logic of a closed plumbing system. Normally, urine travels a sealed one-way road. A fistula is a structural breach. In a ureterovaginal fistula, one ureter leaks into the vagina, causing continuous dribbling. Because the other ureter still fills the bladder normally, the patient's voiding pathway remains intact. If the breach is in the bladder itself, a vesicovaginal fistula, urine no longer waits for voiding. Fluid leaks out as soon as it arrives, losing the normal voiding pattern. If the breach is at the urethra, the system holds fluid normally, but leakage occurs at the outlet level during an attempted void. This topography is the basis for the 3-swab dye test. We fill the bladder with methylene blue dye. If the swab stain blue, the leak is from the bladder. If the upper swab gets wet with clear fluid, the breach is at the ureter. In a closed hydrostatic system, the anatomical elevation of the breach dictates the clinical presentation. Repairing these breaches is a matter of tissue biology. Suturing inflamed, swollen tissue won't hold. Recognizing a fistula immediately during surgery allows for repair while the tissue is still fresh. If more than 24 hours have passed, inflammation sets in. You must wait 6 weeks for swelling to subside before attempting a repair. Postoperative rules are strict: catheter drainage, 2 weeks of antibiotics, 3 months without vaginal exams, and 1 year without pregnancy. These protocols exist for one biological imperative: isolating the healing tissue from mechanical stress and infection until structural integrity is restored. Ovarian hyperstimulation syndrome, or OHSS, is the downstream consequence of a singular molecular chain. To build new vessels for a growing follicle, the ovary secretes vascular endothelial growth factor, or VEGF. It is the primary angiogenic signal. During pharmacological overstimulation, multiple follicles develop simultaneously. This creates massive reservoirs of intrafollicular VEGF. That VEGF is released when the chemical trigger is pulled, human chorionic gonadotropin, or HCG. The HCG binds to LH receptors, activating the CAMP and PKA pathways to release stored VEGF at once. Once released, VEGF targets capillary walls throughout the body. It separates endothelial junctions, making capillaries highly permeable and causing a systemic leak of blood plasma. If you withhold the HCG trigger when ovaries are overresponding, the pathological VEGF remains locked inside the follicle, and the syndrome is prevented. When plasma leaks out of the capillaries, it pools in the body's third spaces. Fluid in the abdomen causes ascites and peritoneal pain, while fluid in the pleural space leads to respiratory distress. Simultaneously, the loss of plasma leads to profound hemoconcentration. The remaining blood becomes thick and viscous. This completes Virchow's triad. The viscous blood causes stasis, high estrogen levels create a hypercoagulable state, and the VEGF leak process directly injures the endothelium. These factors together result in a significant clotting risk. The timeline of the syndrome depends on the source of the HCG. If OHSS occurs within the first 9 days, it is driven by the exogenous clinical injection. After 9 days, it's driven by an implanted embryo. Prevention strategies target specific nodes in the master chain. We use cabergoline to dampen VEGF signaling, coasting to let estradiol drop, or freeze all cycles to eliminate late-onset HCG from pregnancy. The risk factors, symptoms, and prevention strategies for OHSS all follow from the tracking or blocking of this capillary leak cascade. Urogynecology and reproductive endocrinology are predictable consequences of specific system failures. SUI is a physical support collapse. Urinary fistulas are topographical plumbing breaches. OHSS is a capillary wall degradation. Precisely identifying the node of mechanical or biochemical failure makes the downstream symptoms, diagnostics, and treatments predictable. Vulvar cancer accounts for 3 to 4% of all gynecologic malignancies. While it represents a smaller fraction of the overall oncological landscape, managing it requires an exacting understanding of applied anatomy. The disease presents along a highly specific demographic curve. The vast majority of cases occur in women between 50 and 70 years old, with the mean age of clinical presentation landing exactly at 65. This topographic map of the vulva highlights the typical sites of presentation. The labia majora is the absolute most common location for tumor development, followed closely by the adjacent labia minora. Before a patient ever detects a physical change, they typically present with a specific localized complaint. Pruritus, or severe itching, is the most common presenting symptom, usually preceding the discovery of a distinct visible mass, an ulcer, or localized pain. Managing this disease requires abandoning generalizations. Successful intervention is entirely dependent on precise spatial mapping, where millimeter-level depth and proximity to rigid anatomical landmarks strictly dictate a patient's survivability. This cross-section of epithelial tissue illustrates the pre-malignant phase, known as vulvar intraepithelial neoplasia, or VIN. The dysplasia is categorized into 3 strict grades based on epithelial depth. VIN 1 occupies the lower third, VIN 2 extends through the lower 2/3, and VIN 3 represents full-thickness cellular involvement. Crucially, even full-thickness VIN remains non-invasive. The pathology crosses the threshold into an invasive cancer, the precise moment cellular dysplasia breaches the basement membrane. The presentation of VIN 3 diverges sharply depending on the patient's age. In young women, the condition is heavily tied to HPV infection and will spontaneously regress 90% of the time. In older women, it frequently associates with lichen sclerosis and is highly likely to progress into invasive carcinoma. Once the lesion becomes invasive, histological typing shows clear majorities. Squamous cell carcinoma is the overwhelmingly dominant histology, with melanoma presenting as a distant second. This comparison matrix breaks squamous cell carcinoma down into 2 distinct etiologies. On the left is the keratinizing subtype, accounting for 60% of cases. It typically strikes older patients between 65 and 70, presents as a unifocal tumor, and is strongly linked to differentiated VIN and lichen sclerosis. On the right is the warty subtype, making up the remaining 40%. This variant presents slightly earlier, between ages 55 and 60, is often multifocal across the vulva, stems from undifferentiated VIN, and is heavily driven by HPV strains 16 and 18. A broader look of the patient's history will flag smoking, Paget's disease, and condyloma acuminata as high-yield risk factors. Notably absent from this list are herpes simplex, condyloma lata, and parity, which carries 0 association with vulvar cancer development. Identifying the specific histological subtype allows the clinician to immediately predict the patient's likely demographic profile, the probability of multifocal lesions, and the exact underlying cause of the tumor. While local extension and rare vascular pathways occur, lymphatic spread is by far the most common route of dissemination. Consequently, lymph node involvement remains the absolute most important prognostic marker in vulvar cancer. This 3D pelvic model maps the standard echelon of lymphatic spread. Drainage begins at the primary vulvar site and travels predictively to the absolute first line of defense, the superficial inguinal lymph nodes. If those nodes fail to contain the disease, the pathway continues inward to the deep inguinal and femoral nodes, before finally breaching the pelvic lymph node clusters. Because this primary echelon is highly predictable, surgeons can rely on a sentinel lymph node biopsy. By testing the very first draining node, they can confirm whether the disease is localized, sparing the patient from the severe morbidity of an unnecessary full node dissection. Mapping this exact sentinel node requires injecting the site with specific markers, most commonly isosulfan blue dye and technetium-99 labeled colloid. There is, however, a major anatomical exception. Lesions on the clitoris can completely bypass the superficial nodes. Instead, their lymphatics can drain straight into the deep node of Cloquet, also known as the Rosenmuller node, or even route directly into the pelvic nodes.
Patient survival drops precipitously once the lymphatic barrier is breached. Recognizing these predictable echelons and their rare exceptions forms the entire basis of the surgical plan. Establishing that plan starts with an exact diagnostic mandate. A primary biopsy via case forceps or wedge excision is strictly required to measure the true depth of invasion. Additionally, vulvoscopy is deployed to detect hidden pre-malignant disease masquerading in hypopigmented or atrophic tissue. This schematic defines FIGO staging based on the resulting biopsy. Disease fully confined to the vulva is stage 1. However, to qualify for the highly localized stage 1A, the tumor must measure 2 centimeters or less in total width, with a stromal invasion depth of exactly 1 millimeter or less. Crossing either of those strict mathematical thresholds
presenting a size greater than 2 centimeters, or an invasion deeper than 1 millimeter, immediately escalates the classification to stage 1B. Stage 2 is triggered the moment the tumor exhibits local extension, breaching the lower 1/3 of the adjacent urethra, vagina, or anus. The disease enters stage 3 the moment it successfully metastasizes into the regional lymphatic system, specifically infecting the inguinofemoral lymph nodes. Stage 4, the terminal classification, is defined by involvement of the deep pelvic nodes, fixed or ulcerated inguinofemoral nodes, extension extending into the upper 2/3 of adjacent internal structures, or any distant metastases. The line between a localized excision and systemic failure is razor thin. Every millimeter of tumor growth strictly dictates the clinical stage. Treatment algorithms divide sharply at the lymphatic barrier. Stages 1 and 2 rely on surgical resection, typically a radical partial vulvectomy, while stages 3 and 4 mandate immediate chemoradiation. This diagram illustrates the distinct surgical exception granted only to stage 1A. Because the disease is so limited, a wide local excision is entirely sufficient, provided the surgeon secures a strict 2-centimeter tumor-free margin around the entire lesion. Nodal management is governed by the rigid midline rule. Any anatomical structure sitting within 2 centimeters of the midline, including the clitoris, the fourchette, and the anterior labia minora, inherently cross-strains to the opposite side of the body. Consequently, if a tumor so much as touches this 2-centimeter midline zone, the surgeon is absolutely required to perform a bilateral inguinofemoral lymph node dissection. If nodes are clinically palpable upon exam, they must be removed and evaluated via frozen section immediately. If that section returns positive, bilateral clearance is mandatory. In cases with non-palpable nodes, surgeons can step down to a unilateral dissection only if 4 strict criteria are met. The nodes prove negative on biopsy, the tumor size is under 2 centimeters, the lesion sits strictly greater than 2 centimeters away from the midline, and there is 0 local extension. Avoiding bilateral clearance when possible is vital. The massive, raw surgical areas left behind after extensive vulvectomies highly predispose patients to severe postoperative complications, most notably deep vein thrombosis. The surgeon's scalpel follows a strict algorithmic flowchart. The exact proximity to the midline and the initial nodal status directly determine the extent of tissue removal required to secure survival. Managing vulvar cancer is entirely an exercise in calculated geometry. Treatment success depends entirely on reading the exact dimensions of depth, width, and lymphatic flow. Pacing quickens slate read for review. To recap the typical presentation, patients are generally between 50 and 70 years old, frequently presenting with localized pruritus, and the lesions appear most commonly on the labia majora. Histologically, squamous cell carcinoma dominates the diagnosis. For early-stage intervention, remember the stage 1A threshold requires the tumor to be less than or equal to 2 centimeters in size, with stromal invasion stopping exactly at or below 1 millimeter. Surgically, any lesion within 2 centimeters of the midline mandates a bilateral nodal clearance. For accurate staging, isosulfan blue and technetium-99 colloid map the essential superficial inguinal sentinel nodes. In vulvar oncology, there is no room for estimation. Mastering the strict surgical algorithms and the underlying spatial anatomy provides the only effective means of intercepting metastasis and curing the patient.
Deep within the female reproductive tract lies a critical boundary organ, the cervix. It serves as the physical and biological bridge between the protective, highly acidic environment of the vagina and the sterile environment of the upper reproductive tract. Because it spans 2 different environments, the cervix must adapt to survive. The physiological mechanism it uses to defend against vaginal acidity creates an inherent exploitable cellular vulnerability. Eradicating cervical cancer relies on mapping a sequence of biological events, from the anatomical baseline to viral integration, histological dysplasia, and definitive surgical excision. By understanding this biological timeline, clinicians can predictably intercept an opportunistic cellular transformation before those rogue cells breach the basement membrane. To understand the vulnerability, we have to look at the tissue itself. 2 distinct epithelial types meet on the cervix. The endocervix, lining the inner canal, is made of fragile, single-layer columnar cells that secrete mucus. The ectocervix, facing the vagina, is covered in a robust, multi-layered, stratified squamous epithelium built for protection. At puberty, rising estrogen levels cause glycogen to build up in the vaginal walls. Beneficial lactobacilli ferment this glycogen into lactic acid, lowering the pH to protect the reproductive tract against external pathogens. The delicate, single-layer columnar cells of the endocervix cannot tolerate this acidic bath. To survive, they remodel into tough, multi-layered squamous cells. This is an adaptive physiological process called squamous metaplasia. This architectural cross-section illustrates how that transformation works. As the columnar cells remodel, the squamo-columnar junction, the point where the two tissue types meet, migrates closer to the external os. The territory between the original junction and the newly formed junction is the transformation zone. Because this zone is an area of rapid cellular proliferation and high DNA turnover, it dictates the distribution of cervical cancer. Squamous cell carcinoma arises within this actively dividing transformation zone. In contrast, adenocarcinoma arises higher in the endocervical canal, where the native glandular columnar cells remain untouched by metaplasia. Occasionally, as the new squamous epithelium grows, it paves over and traps the secretory openings of the underlying columnar glands. Trapped mucus forms Nabothean cysts, a benign structural byproduct of this remodeling that requires no medical intervention. Squamous metaplasia is an orderly, physiological adaptation. The danger arises when an external agent targets this high-turnover environment, hijacking the remodeling process and making it disordered. That pathological state is dysplasia. In the vast majority of cases, that agent is human papillomavirus, or HPV. It is an epitheliotropic virus, meaning it lives strictly within epithelial cells. It cannot infect mature, intact tissue. Instead, it relies on microabrasions to penetrate down to the actively dividing basal and parabasal cells of the transformation zone. The virus infects the deep layers, but only completes its viral assembly as the host cells mature and migrate upward. On a pap smear, this leaves a cytological footprint called cheilocytosis. Host cells display enlarged, dark nuclei surrounded by a clear perinuclear halo, marking them as viral assembly factories. This conceptual split screen models how the virus drives transformation using two specific oncogenes. First, the viral protein E6 binds and inactivates p53. Normally, p53 senses DNA damage and triggers apoptosis, or cell suicide. With p53 disabled, the cell's ability to destroy itself in response to genetic errors is broken. Next, the viral oncogene E7 binds and inactivates the RB protein. RB regulates the G1 to S phase cell cycle checkpoint. When E7 knocks it offline, the cellular brakes fail, and the cell loses its ability to pause its replication cycle. When p53 and RB are both inactivated, the cell stops dying from accumulated DNA damage and stops pausing its replication. The result is a rogue, immortalized cell line. The severity of this hijack depends on the viral subtype. High-risk subtypes 16 and 18 account for 70% of cervical cancers globally, with type 18 specifically tied to adenocarcinoma. Types 31, 33, 35, 52, and 58 account for the remaining oncogenic burden. Low-risk subtypes like 6 and 11 do not cause cancer. Instead, they are responsible for 90% of benign genital warts and recurrent respiratory papillomatosis. Most HPV infections resolve spontaneously within 1 to 2 years. However, persistent viral presence drives the progression from dysplasia toward invasive carcinoma. Since this process typically takes 10 to 20 years, the long latency allows clinicians to intercept the disease before it becomes invasive. The most efficient way to manage cervical disease is to prevent viral integration.
Modern HPV vaccines utilize the virus's L1 major capsid protein, which self-assembles into virus-like particles. These mimic the 3D structure of the wild virus to provoke a neutralizing antibody response. Because they contain no viral DNA, they cannot cause infection. Early vaccines targeted 2 or 4 subtypes, like the quadrivalent formulation shown here,
which covers types 6, 11, 16, and 18. Today, the non-availant Gardasil 9 is the standard of care in the U.S., offering the broadest oncogenic coverage. Routine targeting focuses on pre-adolescent patients before potential sexual exposure. For ages 9 to 14, 2 doses are sufficient. Patients 15 and older require the full 3-dose series to achieve the same immunogenicity. Because no single vaccine covers every oncogenic subtype, primary vaccination and secondary cervical screening operate in parallel. One does not replace the other. This comparison illustrates the governing rule of cervical pathology. A Pap smear evaluates isolated, detached cells. This is cytology. A biopsy evaluates intact tissue architecture. This is histology. Treatment is never based on isolated cytology. It requires histological grading of cervical intraepithelial neoplasia, or CIN. CIN is graded by how far the dysplastic cells extend upward from the basement membrane. CIN1 involves dysplasia confined to the lower third of the epithelium. This carries a 1% risk of cancer. CIN2 and CIN3 occur when the disordered cells push into the middle and upper thirds of the epithelium. At this grade, the risk of malignant progression increases to 40%. If the dysplasia becomes full thickness but remains above the line, it is carcinoma in situ. The moment it breaches the basement membrane, it is invasive carcinoma. For screening, liquid-based cytology is frequently used. It mathematically filters out factors like blood and mucus and allows one sample to be used for both cellular examination and molecular HPV DNA testing. When cytology results are ambiguous, pathologists use P16 staining as a tiebreaker. Because P16 protein accumulates inside the cell when the RB pathway is destroyed by HPV's E7 protein, a causative stain confirms a precancerous process. In low-resource settings, visual screening offers an immediate alternative. Acetic acid dehydrates the dense nuclei of dysplastic cells, causing them to reflect light as aceto-white patches. Alternatively, Lugol's iodine stains the glycogen in normal cells dark brown, while dysplastic tissue lacks glycogen and remains a stark mustard yellow. Clinical screening in the U.S. follows age-based parameters. Patients under 21 are not screened, avoiding the overtreatment of transient infections. Between 21 and 65, patients receive a Pap every 3 years, or co-testing every 5 years. Screening stops after 65, provided the patient has a negative history. When a Pap returns abnormal, triage is calculated by risk. An ASC-US result in a patient over 35 triggers reflex HPV testing. However, an HSIL result at any age mandates immediate colposcopy and endocervical curettage due to the risk of underlying CIN2 or 3. The cytological screening algorithm exists to filter out transient infections and funnel statistical risk down to a visually guided tissue biopsy. Once a biopsy confirms the CIN grade, surgery is dictated by the risk of progression. Because CIN is a pre-invasive epithelial lesion, localized excision or ablation is used to preserve the uterus and the patient's future fertility. A confirmed CIN1 diagnosis justifies 2 years of active observation due to a high spontaneous regression rate. Patient counseling is vital here to explain that watchful waiting is a rigorous management strategy. However, a CIN2 or 3 diagnosis crosses the threshold of progression risk, requiring immediate localized surgical intervention. This comparison shows the mechanical difference between treatments. Cryoablation freezes and destroys tissue up to 5 millimeters deep. Its limitation is that it vaporizes the tissue, leaving no specimen to ensure an invasive cancer wasn't hidden beneath the surface. In contrast, the LLETS or LEAP procedure uses an electrified wire loop to excise a 10 millimeter deep specimen intact. This allows pathologists to verify surgical margins and rule out occult invasive disease, making LLETS the gold standard for CIN2 and 3. For cases such as suspected adenocarcinoma or a transformation zone that retreats into the canal, a deeper, cone-shaped surgical biopsy is required. However, because it removes significant cervical stroma, conization elevates the risk of future complications like cervical insufficiency. Preventing cervical cancer relies on a specific sequence of interventions, recognizing the metaplastic vulnerability, neutralizing the virus, mapping the dysplastic depth, and excising the lesion before it breaches the basement membrane.
Deep within the cervix lies an unstable cellular transition zone. When a high-risk viral infection takes hold here, it disables normal regulatory proteins, triggering rapid, chaotic cellular division. These abnormal cells pile up, exerting physical pressure downward until they force their way through the epithelial basement membrane. This penetration into the stroma grants the tumor access to vascular and lymphatic networks, shifting the disease from a localized epithelial abnormality to a systemic oncological threat. The tumor's behavior depends on its histology. Squamous cell carcinoma accounts for roughly 80% of cases, arising from the metaplastic cells of the transformation zone and linked heavily to HPV-16. While subtypes vary, the small cell variant is a highly aggressive neuroendocrine tumor characterized by rapid early metastasis. Adenocarcinoma, making up 15 to 20% of cases, operates differently. Linked to HPV-18 and prolonged oral contraceptive use, it originates from the glandular columnar epithelium deep within the endocervical canal. Its inward growth pattern frequently conceals the mass from visual inspection and routine pap smears, often delaying diagnosis until the disease has reached a later stage. Regardless of the histological origin, crossing the basement membrane sets off a predictable chain reaction. This microscopic escape dictates the physical symptoms, the route of spread, and the clinical interventions required to stop it. This graph maps the incidence of cervical cancer against patient age, revealing a specific bimodal distribution. The primary peak occurs in women aged 35 to 39. This reflects initial viral infections acquired during early sexual debut, followed by a 10 to 20-year progression through graded cellular dysplasia. A secondary peak surfaces at ages 60 to 64. This spike frequently follows a failure of continued routine screening in postmenopausal women, though it can also represent the reactivation of a dormant virus. The natural history of this disease follows a strictly contiguous spatial geometry. Mapping this physical expansion provides the primary basis for staging the disease and determining whether a patient receives radical surgery or targeted chemoradiation. To map that expansion, we must establish the three-dimensional architecture of the female pelvis. The cervix sits at the base of the uterus, bordered anteriorly by the bladder, posteriorly by the rectum, and suspended by a web of connective tissue called the perimetrium. As the tumor grows, it creates fragile neovascularization. This mechanical fragility leads to the most common presenting symptoms: irregular vaginal bleeding and postcoital bleeding caused by physical disruption of the friable mass. Untreated, the tumor expands contiguously. It moves outward into the perimetrial tissue, downward into the vagina, and eventually pushes anteriorly and posteriorly to invade the mucosal walls of the bladder and rectum. This cross-section illustrates the primary cause of mortality in cervical cancer. As the mass expands into the perimetrium, it envelops the ureters. Pinching these tubes close causes bilateral ureteral obstruction, leading to profound hydronephrosis, acute kidney injury, and fatal uremia. The virus initiates the dysplasia, but the disease kills through mechanical disruption. It dismantles the surrounding pelvic infrastructure until renal clearance is physically impossible. This wireframe maps the lymphatic route. Cells migrate in a stepwise anatomical chain from paracervical sentinel nodes up to obturator and iliac nodes, ascending to para-aortic nodes. The cervix doesn't drain to superficial inguinal nodes unless the primary tumor involves the lower vagina. Because this spread is predictable, the immediate clinical goal is to map the exact extent of the disease. The baseline step is an examination under anesthesia. The oncologist deeply palpates the tissue to determine if the tumor has fixed to the pelvic sidewall. To see what physical palpation cannot reach, modern guidelines rely on cross-sectional imaging. Pelvic MRI provides exact measurements of stromal and perimetrial invasion, while PET-CT scans identify metabolically active metastases within the lymphatic chains. Capturing this three-dimensional map of the tumor's boundaries is a mandatory prerequisite for selecting a treatment protocol. The resulting map is applied to the FIGO staging table. This matrix standardizes all oncological management, morbidity discussions, and survival prognoses based on specific anatomical landmarks. Stages 1A and 1B represent early, localized disease, defined by millimeter depth thresholds and centimeter width limits. At these points, the cancer remains contained within the cervix and upper vagina, and the perimetrium remains spared. The perimetrium is the connective tissue housing the primary vascular networks that supply the pelvic sidewall. This illustration shows the exact moment the tumor breaches the cervical border into the perimetrium. This is the stage 2B watershed. Primary surgery is no longer viable. Achieving clear margins requires cutting through dense tissue, risking severing sidewall vessels and catastrophic hemorrhage. Stage 2B marks the anatomical boundary where surgical management ends and the reliance on primary chemoradiation begins. For disease caught inside the surgical envelope, stages 1A, 1B1, and 2A1, clear margins can be achieved, though it demands extensive local tissue clearance. Stage 1A disease is addressed with tissue-clearing interventions. Depending on the invasion depth, this ranges from a cold knife chromization to a modified radical hysterectomy, which removes the uterus, cervix, and the medial half of the perimetrium. For patients with stage 1B1 tumors under 2 centimeters who desire fertility preservation, surgeons may perform a radical trachelectomy. The cervix and upper vagina are removed, but the uterine body is preserved and stitched to the vaginal vault with a permanent cerclage. Because the mechanical barrier of the cervix is gone, the patient faces a high risk for mid-trimester miscarriage and must deliver via classical cesarean section. For larger localized tumors, surgeons execute a Wertheim's radical hysterectomy. This is an en-bloc removal of the uterus, cervix, upper vagina, and the entire perimetrium. Sweeping this tissue out frequently strips the autonomic nerve plexuses supplying the bladder, which can cause chronic postoperative bladder atony. Final pathology dictates the need for further care. Intermediate risk markers, like deep stromal invasion, demand adjuvant radiotherapy. High-risk markers, such as positive margins or positive nodes, prove the cancer has escaped the surgical envelope and require immediate chemoradiation. Achieving a cure through surgery demands an intentional, highly morbid dismantling of the patient's local pelvic anatomy. When the tumor reaches stages 1B3, 2B, 3, or 4A, the surgical option is closed. Management shifts to concurrent chemoradiation. Weekly cisplatin is utilized strictly as a radiosensitizer. The drug binds to the tumor's DNA, preventing the cancer cells from repairing the double-strand breaks inflicted by radiation therapy. Radiation is delivered in 2 phases. External beam radiotherapy, or EBRT, is administered daily over 5 weeks to homogenize the entire pelvic field and sterilize microscopic disease in the draining lymph nodes. If PET scans identify stage 3C2 disease, indicating para-aortic node involvement, the external beam field is extended upward through the abdomen to the level of the renal vessels. External beams and systemic drugs establish regional control and shrink the gross mass, preparing the field for the delivery of the primary curative treatment. Intracavitary brachytherapy delivers the highest localized dose of the treatment regimen. Radioactive isotopes are placed directly inside the uterine cavity and vaginal fornices, bordering the residual tumor. This heat map visualizes the inverse square law of radiation physics. Placing the isotope centrally allows a lethal dose to destroy the cervix, while the intensity drops off sharply just millimeters away, sparing the adjacent bladder and rectum from destruction. This gradient is calculated using specific coordinates. Point A, located 2 centimeters up and 2 centimeters lateral from the cervical os, measures the dose delivered to the perimetrial nodes and the crossing of the ureter. Point B, sitting 3 centimeters lateral to point A, proxies the dose delivered to the obturator nodes along the pelvic sidewall. While brachytherapy achieves high cure rates, the local toxicity is severe and irreversible. Irradiating the pelvis guarantees ovarian failure. The resulting chronic fibrosis leads to vaginal stenosis, alongside chronic radiation cystitis and proctitis. Modern spatial staging and targeted interventions successfully halt the expansion of the tumor, but the lifelong physiological destruction required to achieve that cure underscores why this disease must be prevented through vaccination before the basement membrane is ever breached. This animation shows the single biological rule that governs the uterine lining. The endometrium proliferates entirely on estrogen's command, and it multiplies continuously until progesterone arrives to mature and restrain it. Estrogen builds the tissue, progesterone stabilizes it. When that exact hormonal balance breaks down and estrogen operates without restriction, The clinical result is abnormal uterine bleeding, specifically the category known as AUBM, which encompasses both hyperplasia and frank malignancy. This timeline illustrates a critical thesis. Endometrial hyperplasia and type 1 endometrial cancer are not distinct, unrelated diseases. They are sequential coordinates on a single biological line. Driven by unopposed estrogen, the tissue progresses from normal proliferation to cystic dilation to cellular atopia and finally to endometrioid adenocarcinoma. From this single physiological principle, we can derive the entire diagnostic workflow. The rules for ultrasound thresholds, the strict triggers for tissue sampling, and the precise FIGO surgical staging all trace back to mapping where a patient sits on this continuum. Medical learners do not need to memorize separate lists of risk factors for hyperplasia and then again for cancer. By tracing the hormonal environment from presentation to pathology, the entire management cascade becomes a strict logical deduction. This decision tree maps the immediate clinical response to a patient presenting with abnormal uterine bleeding. After ruling out pregnancy, the first mandatory investigation is transvaginal sonography. The scan measures endometrial thickness, but the threshold for triggering a biopsy depends entirely on which demographic column the patient occupies. For a woman of reproductive age, the threshold is high. You mandate a biopsy if her endometrium is greater than 12 millimeters, or, crucially, if her bleeding persists despite a trial of first-line medical therapy. In the perimenopausal group, the rules change entirely. You biopsy this patient regardless of what the ultrasound shows. This population carries the highest burden of anovulatory cycles, meaning prolonged periods of unopposed estrogen. Because of that biological reality, the index of suspicion is set to maximum. For a postmenopausal patient, the threshold drops drastically. Any endometrial thickness greater than 4 millimeters mandates immediate tissue sampling. The first critical principle of this diagnostic algorithm is that a patient's demographic risk outranks raw imaging data. For high-risk and ovulatory patients, no ultrasound measurement is low enough to guarantee safety. Once the threshold is crossed, your first diagnostic move is an endometrial biopsy, usually done with a cannula or aspirator. It is an outpatient procedure that extracts a blind representative sample of the cavity. It is fast and efficient, but because it is blind, it can miss focal lesions. This expanded diagram contrasts that simple biopsy with the surgical gold standard, fractional curettage combined with hysteroscopy. Notice the mechanical difference in the curettage path. The tissue from the endocervical canal is collected first and sealed in an entirely separate container from the tissue of the endometrial cavity. This strict physical separation is exactly how a pathologist later determines if a tumor has invaded the cervical stroma, which dictates whether the disease is classified as FIGO stage 1 or stage 2. Meanwhile, adding hysteroscopy provides a direct visual of the cavity, allowing the surgeon to target focal lesions directly. Because the gold standard requires general anesthesia, we reserve it for strict clinical triggers. You escalate to fractional curettage if the initial blind biopsy discovers atypia, if the sample is returned as insufficient, or if the patient has cervical stenosis, requiring anesthesia to dilate the canal. The remaining two triggers center on clinical failure. You escalate to surgery if the patient has hyperplasia without atypia that persists despite adequate progesterone therapy, or if she continues to bleed despite a normal biopsy and medical treatment. Persistent bleeding despite adequate therapy is medicine's most reliable signal that a blind biopsy missed something dangerous. When symptoms outlast treatment, the algorithm demands direct visual evaluation and segregated tissue sampling. This flowchart tracks the pathologist's microscopic report, which splits clinical management into 3 distinct pathways. In World A, the tissue is normal, and you manage the bleeding medically. In World B, the diagnosis is metropatia hemorrhagica, or cystic glandular hyperplasia. This presents as amenorrhea followed by a sudden, heavy bleed. It is a pure hormonal deficiency state caused by prolonged anovulation. The treatment is directly replacing the missing progesterone. World C is true hyperplasia, and it forces a mandatory clinical fork based on one finding: atypia. If there is no cellular atypia, the risk of progression to malignancy is extremely low, hovering around 1 to 3%. First-choice treatment is continuous local delivery of progesterone via a Mirena IUS or cyclic oral progesterone dosed specifically to protect the endometrium. This pathway requires a mandatory checkpoint, a repeat biopsy at 3 to 6 months. If the hyperplasia persists at that checkpoint, or if bleeding continues, the algorithm triggers an immediate escalation to fractional curettage. If the initial biopsy discovers hyperplasia with atypia, the risk calculus changes entirely. The progression to invasive cancer is dramatically higher, requiring a decisive shift in management. Look at the split screen scenario, which highlights a common clinical trap. When atypia is found, the intuitive move is to jump straight to a total hysterectomy. That is incorrect.
The correct next step is fractional curettage and hysteroscopy.
You must perform this intermediate step because the blind biopsy that found atypia might have pulled tissue from right next to an unsampled area of frank invasive carcinoma. Definitive surgery cannot proceed until you know exactly what is hiding in the cavity. Medical management with high-dose progestogens can successfully reverse the unopposed estrogen continuum in low-risk cases, but the structural presence of cellular atypia marks a hard boundary, triggering an immediate shift toward complete surgical resection. If the unopposed estrogen continuum runs its full course, the final expected outcome is type 1 endometrial cancer, typically a well-differentiated endometrioid adenocarcinoma. It relies on an early PTEN mutation, expresses estrogen receptors, and spreads primarily via direct physical extension. This graphic maps out the primary risk factors, revealing that they are simply different sources of estrogen excess.
Obesity drives risk through peripheral aromatization, where adipose tissue actively converts circulating androgens into estrogen. The drug tamoxifen also creates risk. While it blocks estrogen in breast tissue, it behaves as a partial estrogen agonist in the endometrium. The protective factors follow the exact same logic in reverse. Multiparity, pregnancy, and combined oral contraceptives protect the endometrium, strictly because they guarantee the presence of progesterone to oppose the estrogen. Type 2 endometrial cancer, however, breaks completely from this continuum. This variant includes clear cell and papillary serous carcinomas. These are aggressive, receptor-negative malignancies that arise in a hypoestrogenic, atrophic endometrium. There is no preceding hyperplastic phase. This creates a dangerous diagnostic trap for postmenopausal bleeding. If a postmenopausal patient bleeds, but her ultrasound shows a thin endometrium measuring 4 millimeters or less, she still requires close attention. If she continues to bleed despite that thin measurement, you must escalate directly to fractional curettage. A thin endometrium on an ultrasound is not a guarantee of safety. It is precisely the environment where aggressive type 2 cancers develop, and because the tissue is atrophic, a standard blind biopsy is highly likely to miss them entirely. Once cancer is confirmed, the cardinal rule of endometrial cancer evaluation applies. It is strictly a surgical diagnosis. Preoperative imaging like MRI and PET scans are necessary to plan the operation, but the official FIGO stage is only assigned after the uterus is removed and examined by pathology. This 3D model of the pelvis shows exactly how the FIGO 2009 anatomical staging works. Stage 1 disease is confined to the body of the uterus, categorized by the depth of invasion into the myometrial wall. To reach Stage 2, the tumor must physically invade the cervical stroma. Mere glandular involvement does not count. Stage 3 marks extension into the serosa, adnexa, or vagina, while Stage 4 reaches the bladder, bowel, or distant nodes. There are strict staging asymmetries here. Endometrial cancer spreading down into the cervical stroma upgrades its stage, but a primary cervical cancer spreading up into the uterine body does not change the cervical stage. Also note that superficial inguinal node involvement is universally categorized as Stage 4B across all major gynecologic cancers. The FIGO 2023 update integrated molecular classification directly into the formal staging criteria. Now, a patient whose tumor harbors a POL mutation is assigned a favorable prognostic category, regardless of the gross anatomical stage or tumor grade. Conversely, an MMMRD or microsatellite instability pathway indicates an intermediate prognosis, while a P53 genetic abnormality dictates a highly unfavorable one. The 2023 update also clarified the rules for ovarian involvement. Finding independent primary tumors in both the uterus and the ovary simultaneously is classified as a synchronous endometrioid tumor, stage I1A3, which carries a favorable prognosis. This is biologically distinct from stage I3A disease, where a single uterine tumor has metastasized outward to the ovary. Modern staging has evolved beyond mapping physical spread into a dual framework where molecular genetics can override gross anatomical findings. This three-step execution matrix resolves the entire diagnostic workflow into a definitive surgical action plan, adjusted strictly by stage, histology, and risk level. Step 1 is the core procedure. For stages 1 through 3, this is a total hysterectomy with bilateral salpingo-oophorectomy. For stage 4, the goal shifts to debulking. Specific histologies require precise add-ons. An infracolic omentectomy is mandated for papillary serous variants, and an appendectomy is required for mucinous tumors. Steps 2 and 3 are pelvic and para-aortic lymph node dissection, followed by adjuvant radiotherapy. These are executed in almost every case. There is exactly one strict exception. They are omitted for low-risk stage IA, grade 1 or 2 disease, where the morbidity of dissection outweighs the statistical risk. We can trace a final clinical example through the matrix to prove the logic. A 55-year-old woman is diagnosed with stage IB endometrioid adenocarcinoma, grade 3, with 50% myometrial invasion. For stage IB disease, she receives the standard hysterectomy and bilateral salpingo-oophorectomy. However, because her tumor is grade 3, she is immediately disqualified from the low-risk exception. The protocol therefore mandates proceeding with comprehensive lymph node dissection and subsequent adjuvant radiotherapy. Unopposed estrogen drives the underlying biological pathology. Targeted tissue sampling exposes the exact histology. And post-surgical anatomy, combined with precise molecular data, dictates the definitive cure.
The ovary occupies a unique position in human anatomy. It sits deep within the pelvis, suspended by ligaments, continuously regulating the reproductive cycle. Unlike organs encased in thick capsules or isolated by fibrous sheaths, the ovary lacks a definitive anatomical barrier. If a malignant cell develops here, there is nothing stopping it from shedding directly off the surface and into the fluid of the peritoneal cavity. The clinical result of this anatomical freedom is a silent disease. Without a confined space to build pressure or cause early pain, ovarian pathology produces vague, nonspecific symptoms: mild bloating, slight nausea, a loss of appetite. By the time a mass is discovered, it is frequently already spread across the peritoneum. Because true ovarian cancer is rare at a population level, standard screening protocols fail. Running widespread tests on asymptomatic populations yields an overwhelming number of false positives, subjecting healthy patients to the severe harm of unnecessary pelvic surgery. Clinical accuracy requires identifying what the tissue normally does and what happens when that specific function goes wrong at a given age. Since the absence of anatomical boundaries prevents us from relying on local confinement to catch early disease, identifying a mass requires mapping it against the specific biological rules of the patient's life stage. To build that map, we establish a baseline. During a patient's reproductive years, the ovary's normal job is to constantly form and rupture follicles. The default assumption for any mass found in this age window is that it represents normal physiology, slightly exaggerated. This schematic compares the normal fluid mechanics of ovulation against the 3 functional cysts. A follicular cyst is a follicle that failed to rupture. A corpus luteal cyst is a ruptured follicle that filled with fluid instead of regressing. A theca lutein cyst is driven by abnormally high levels of HCG, overstimulating the cells, as seen in molar or twin pregnancies. Because these functional cysts are self-resolving, our management changes based on physical size. Looking at this size scale, masses under 7 centimeters are observed or tracked via serial ultrasound. We intervene surgically at the greater than 7 centimeter threshold to preempt mechanical torsion or rupture, rather than to address suspected malignancy. This physiological logic dictates our pregnancy protocol. In the first trimester, the corpus luteum produces the progesterone required to maintain the pregnancy. Removing an asymptomatic cyst here risks precipitating an abortion. We wait until the second trimester, when organogenesis is complete and the placenta has taken over hormone production, to safely operate on a true tumor. The logic shifts for patients at the extremes of age. Prepubertal girls and postmenopausal women do not ovulate. Any mass appearing in these populations is inherently abnormal. Consequently, the surgical threshold drops. In a prepubertal girl, we test for specific tumor markers: AFP, HCG, or LDH. If these are elevated, we proceed to surgery. In a postmenopausal woman, we check for CA125. Because normal cyst formation has ceased, roughly 20% of postmenopausal ovarian masses are malignant, compared to about 1% in premenopausal women. That 20-fold jump in risk dictates immediate further workup. We distinguish between benign fluid and active growth using ultrasound physics. A benign functional cyst appears as a simple, thin-walled, single cavity of passive fluid. Proliferating malignant tissue has a high metabolic demand. On an ultrasound, this manifests as thick, vascular septa and irregular solid components, actively recruiting a blood supply. Age determines whether normal physiology is biologically possible. The ultrasound reveals the metabolic demand of the tissue. The core pathogenic mechanism for ovarian cancer ties back to that normal physiology. Decades of cumulative ovulation exact a mechanical toll on the epithelial tissue. Every month, an ovulating follicle physically tears through the ovarian surface epithelium. The tissue then has to rapidly replicate to repair the gap. Every repair cycle introduces a mathematical probability of DNA replication errors. This timeline tracks lifetime ovulations. Variables that extend the total number of ovulatory cycles, like early menarche, late menopause, or nulliparity, force the tissue to undergo more repair cycles, compounding the mutation risk over a patient's lifetime. That baseline mechanical risk accelerates in the presence of excess estrogen states, like obesity or hormone replacement therapy. Estrogen chemically drives epithelial proliferation, compounding the damage of the repair cycle. Local inflammatory conditions, like endometriosis, cause a similar acceleration. If a patient inherits a genetic defect in their DNA repair machinery, the risk line spikes. This occurs in Lynch syndrome, where mismatch repair genes are defective, and in BRCA1 and BRCA2 mutations, where the ability to fix double-strand DNA breaks is compromised. The BRCA1 mutation carries the highest known risk for ovarian cancer. Because the probability of faulty repair is so high and we lack a reliable screening test, the standard prophylactic intervention is a risk-reducing total abdominal hysterectomy and bilateral salpingo-oophorectomy once childbearing is complete. Protective factors consist of anything that interrupts the ovulatory cycle, such as breastfeeding, or anything that physically blocks the anatomical route that early malignant cells take from the tube to the ovary. Risk factors like early menarche or BRCA mutations are direct quantitative expressions of lifetime tissue microtrauma and estrogen exposure. The World Health Organization taxonomy assumes an ovarian tumor inherits the behavior, growth pattern, and chemical secretions of its parent cell. Looking at this tripartite cellular map of the ovary, we start with the surface lining, the epithelial tumors. Because this tissue sustains decades of ovulatory damage, these are the most common tumors. They present in older women and are driven by accumulated mutations in p53 and BRCA. Within this branch, serous tumors are the most frequent. They have a high rate of bilaterality and secrete CA125, an antigen native to this cell lineage. Histologically, they feature psammoma bodies, laminated calcifications indicative of slow calcium deposition. In contrast, mucinous tumors and Brenner tumors are typically unilateral. Mucinous tumors resemble intestinal tissue, are driven by KRAS mutations, and secrete the markers CEA and CA19-9. Brenner tumors consist of solid transitional epithelium, structurally mirroring the lining of the bladder. Endometrioid and clear cell tumors also belong to the epithelial family, sharing a pathogenic origin in endometriosis. Clear cell tumors are specifically characterized by the presence of malignant hobnail cells under a microscope. Shift tone to next category. The clinical picture for germ cell tumors is dictated by their origins. Germ cells are embryologically near totipotent. Tumors here present in young patients, inherit that inherent pluripotency, and share a specific chemotherapeutic vulnerability to the BEP regimen. The benign expression of this pluripotency is the mature cystic teratoma. It differentiates into all three germ layers, producing hair, teeth, and sebaceous fluid projecting from a solid Rokitansky nodule. On an ultrasound, this physical density creates the iceberg sign. The malignant expressions of the germ cell line are the dysderminoma and the yolk sac tumor. Dysderminomas are notable as the only highly radiosensitive ovarian tumor. Yolk sac tumors are fast-growing, unilateral, and contain glomeroid Schiller-Duval bodies, secreting AFP, a direct marker of the yolk sac lineage. Tumor morphology.
marker secretion, and chemotherapeutic vulnerability are predictable consequences of embryological lineage. Returning to our cellular map, we highlight the third family, the sex cord stromal tissue. These cells normally support follicle development and synthesize hormones. Tumors here can present at any age, and they manifest primarily through the mass effect of hormone excess symptoms. Granulosa cell tumors are driven by FOXL2 mutations. Because granulosa cells normally produce estrogen, these tumors generate massive, unopposed estrogen output. Clinically, this leads to endometrial hyperplasia in adults, or precocious puberty in young children. Histologically, they feature rosette-like Call-Exner bodies. Ovarian fibromas are benign growths of connective tissue. Their clinical significance lies in Meigs syndrome, a triad of the fibroma itself, ascites, and pleural effusion. Because this is a reactive fluid syndrome, removing the fibroma results in complete resolution of both the ascites and the effusion. Sertoli-Leydig tumors are the androgen-secreting equivalent within this tissue family. The excess production of male lineage hormones causes predictable virilization, including hirsutism and frontal balding. Finally, we must account for external metastatic disease. Not all ovarian masses originate in the ovary. Foreign malignancies can reach the ovary via retrograde lymphatic spread or by shedding into the peritoneal cavity and utilizing transcolomic seeding. The classic example is the Krukenberg tumor. This occurs when mucin-filled signet ring cells migrate from a primary gastric cancer, usually at the pylorus, and seed onto the ovaries. Because the cells are deposited via the bloodstream or lymphatics, the resulting masses are typically bilateral and symmetrical. Cysical symptoms in these categories stem from either the overproduction of native hormones or the mechanical disruption caused by a foreign metastasis. Once a tumor's identity is deduced, we must quantify its spread. Staging in ovarian cancer is a surgical necessity, not a radiological one. Imaging cannot detect microscopic seeding. We require a midline incision, an omentectomy, and direct acidic fluid cytology to confirm the extent of the disease. This geometric pelvic map visualizes the tumor's outward expansion. Stage 1 disease is confined to the ovary itself. Stage 2 occurs when the tumor breaches the ovarian capsule and spreads to adjacent pelvic organs, like the fallopian tube or the uterus. There is a critical staging exception here. In most gynecological cancers, invasion of the bladder or rectum classifies as late-stage disease. In ovarian cancer, bladder and rectal involvement keeps the classification at stage 2, simply because they share the immediate local pelvic geography. Stage 3 disease requires transcelomic spread above the pelvic brim, extending into the retroperitoneal lymph nodes or the abdominal cavity. Stage 4 is defined by distant metastases outside the abdomen entirely, such as fluid in the pleural cavity or solid tumors inside the liver parenchyma. This anatomical map determines our surgical response. Because the uterus is a primary site for adjacent spread, the definitive surgical default for ovarian malignancy is a total abdominal hysterectomy combined with a bilateral salpingo-oophorectomy. We deviate from this default only when two parameters are met. A patient must have a distinct ongoing fertility need, and the tumor must be a responsive type, like a germ cell tumor in a young patient, where effective salvage chemotherapy exists if the disease recurs. In advanced stage 3 or 4 disease, complete resection is no longer geometrically possible. We perform debulking surgery solely to reduce the total tumor burden, creating a smaller volume of disease for systemic chemotherapy to target. Clinical management follows the biology. Age defines physiological plausibility, ultrasound defines tissue physics, lineage defines the chemical marker, and staging defines the anatomical spread. The clinical definition of infertility is built on a specific timeline. For women under 35, it is defined as the inability to conceive after 12 months or more of regular unprotected intercourse. For women aged 35 and older, this medical evaluation threshold is shortened to 6 months, reflecting the accelerated decline in ovarian reserve. In healthy young couples, the probability of achieving a pregnancy in a single menstrual cycle, known as fecundability, is roughly 30%. Secondivity, the probability of achieving a live birth in that same cycle, is slightly lower. Overall, 80 to 90% of these couples will successfully conceive within 1 year of attempting. The etiological breakdown of infertility cases highlights 3 primary categories: Female factors, dominated by ovulatory dysfunction and tubal pathology, account for 40 to 55% of cases. Male factors contribute another 30 to 40%, while the remaining 10 to 20% fall into an unexplained subset, where standard tests return normal results. To begin the diagnostic process, all couples undergo a mandatory baseline workup. For the male partner, a semen analysis is the absolute cornerstone. For the female, clinicians order a day 21 serum progesterone test to confirm ovulation, alongside a hysterosalpingogram, or HSG, conducted between days 7 and 10 to verify tubal patency. If the female partner is 35 or older, anti-Müllerian hormone, or AMH, along with day 3 FSH and estradiol tests are added immediately. These biomarkers triage the remaining egg supply and determine the urgency for moving towards assisted reproductive technology. Because infertility is a couple's diagnosis, clinicians run parallel data streams on both partners. This ensures that the exact physiological failure point is isolated before any targeted intervention begins.
Ovulatory dysfunction is the leading cause of female infertility. Because ovulation relies on a specific hormonal cascade, the World Health Organization classification system categorizes the pathophysiology and dictates the corresponding treatment strategy. WHO Group 1 is hypogonadotropic hypogonadism. In this scenario, the hypothalamus or pituitary fails to secrete adequate gonadotropins, leaving the ovaries dormant. Blood tests reveal low FSH, LH, and estrogen. In conditions like Kalman syndrome, the treatment involves direct hormonal replacement via a pulsatile GnRH infusion pump or exogenous injections. Group 2 covers normogonadotropic normoestrogenic anovulation. The signaling axis is intact and estrogen is produced, but the cyclical triggers are dysregulated. Polycystic ovary syndrome, or PCOS, is the prime example. While highly treatable, the high ovarian reserve in these patients carries a severe risk of ovarian hyperstimulation syndrome during medical induction.
Group 3 is hypergonadotropic hypogonadism. Here, the follicle pool is depleted, causing the pituitary to hypersecrete FSH past 40 international units per liter in a failed feedback loop. In these cases of premature ovarian insufficiency, attempting ovulation induction is futile. A separate category exists for hyperprolactinemia, where elevated prolactin inhibits the release of GnRH. Clinicians always check serum TSH alongside prolactin because primary hypothyroidism can cause a rise in TRH, which directly cross-stimulates prolactin production. Categorizing ovulatory failure by its hormonal profile dictates the next step. It determines whether the pathology can be medically induced or if the patient requires a biological bypass using donor gametes. Evaluating ovulation requires two distinct testing timelines: retrospective tests used to confirm an egg was released in a past cycle, and predictive tests used to precisely time intercourse or artificial insemination. Retrospective markers include a history of mid-cycle pain, known as Mittelschmerz, and clinicians track a biphasic shift in basal body temperature. Clinicians also look for pre-ovulatory cervical mucus exhibiting spin-bark height, high elasticity, and a fern-like crystallization pattern under a microscope. The most objective retrospective test is day 21 serum progesterone, drawn 7 to 8 days post-ovulation. A robust level confirms release. Alternatively, an endometrial biopsy revealing secretory, glycogen-filled glands confirms an ovulatory cycle, whereas single tubular glands indicate anovulation. Predictive tests forecast the event. Over-the-counter urinary LH kits detect the hormonal surge preceding ovulation, though they are unreliable in PCOS patients who maintain chronically elevated baseline LH. Instead, transvaginal ultrasound serves as the clinical gold standard for follicular monitoring. On ultrasound, clinicians track a dominant Graafian follicle until it reaches 18 to 22 millimeters, paired with a trilaminar endometrium thicker than 7 millimeters. Ovulation is signaled when the follicle suddenly decreases in size and free fluid appears in the pouch of Douglas. For anovulatory patients, the clomiphene citrate protocol forces the cycle. Clomiphene blocks hypothalamic estrogen receptors, triggering a compensatory spike in FSH. Started on day 2 to 5, the follicle is monitored until maturity, at which point an HCG injection triggers ovulation roughly 36 hours later. Tracking and manipulating the ovulatory cycle removes physiological chance. It transforms reproductive timing into an act of predictable engineering. Ovarian reserve testing is indicated for females over 35 or those with prior ovarian surgery.
These biomarkers are used to predict how a patient will respond to IVF stimulation. They do not dictate the capacity for natural conception. AMH is a premier biochemical marker because it is cycle-independent. On ultrasound, an antral follicle count below 10 suggests diminished reserve. When testing day 3 FSH, clinicians must draw estradiol concurrently because a high estradiol level will artificially suppress FSH and mask a poor reserve. Fertilization requires patent fallopian tubes. Outpatient tests like HSG or ultrasound-guided hycosi track contrast fluid through the cavity. However, corneal spasm, a contraction of the tube, causes a 29% false positive rate for proximal blockages. Laparoscopic chromoperturbation is the gold standard for differentiating a temporary spasm from a true block. By directly visualizing dye spilling from the fimbriae, the surgeon can simultaneously diagnose and surgically treat pelvic adhesions or endometriosis. Distal blockages can result in a hydrosalpinx, where the fallopian tube distends with inflammatory fluid. This fluid is embryotoxic. Clinicians must surgically clip or remove the affected tube prior to IVF to prevent this fluid from flushing the embryo out of the uterus. Uterine factors like submucous fibroids, Asherman syndrome adhesions, or a septate uterus require hysteroscopic correction. Suspected cervical factors, once evaluated by the now obsolete Hühner test, are bypassed today using intrauterine insemination. Perfect endocrine signaling is ineffective if the physical infrastructure is compromised. Structural tubal or uterine barriers mandate mechanical correction or surgical bypass before implantation can occur. The male diagnostic vector requires strict adherence to abstinence rules. Semen analysis demands 2 to 7 days of abstinence. Violating this threshold causes false drops in sperm concentration or false spikes in cell death and DNA fragmentation. The WHO 2021 criteria established the baseline limits: at least 1.4 milliliters in volume, 16 million sperm per milliliter, and 42% total motility. Kruger's strict morphology requires 4% normal forms, which stands as the single strongest predictor of natural fertilization. Ancillary tests isolate specific defects. The eosine stain identifies dead sperm, while the hypoosmotic swelling test proves vitality for IVF use. The N-test test flags inflammatory white blood cells, and absent seminal fructose helps localize physical obstructions above the level of the seminal vesicles. This decision tree maps the algorithm for azospermia, the complete absence of sperm in the ejaculate. By profiling SSH, LH, and testosterone, clinicians filter the pathology into pretesticular signaling failures, testicular production failures, or post-testicular physical obstructions. Specific conditions emerge from this data. Elevated FSH with low testosterone points to Klinefelter syndrome. Normal hormones with an absence of the vas deferens is linked to cystic fibrosis. Meanwhile, conditions like Cartaginer syndrome produce structurally immobile sperm. Standardizing the male profile removes subjective analysis. It filters male pathology into mild deficits that can be optimized or absolute mechanical failures requiring surgical extraction. Assisted reproductive technology operates on an escalation ladder. Clinical intervention scales strictly in accordance with the physiological barriers they are required to bypass. Intrauterine insemination, or IUI, requires at least one patent fallopian tube. A concentrated, washed pellet of hypermodal sperm is injected directly into the uterine cavity. This bypasses cervical barriers and compensates for mild sperm deficits or anatomical hurdles like hypospadias. Standard in vitro fertilization requires a total motile sperm count of at least 5 million. It is indicated for absolute tubal blockages, severe endometriosis, or when a genetic biopsy of the embryo is necessary before transfer. Intracytoplasmic sperm injection, or ICSI, is the ultimate mechanical bypass. Used for severe sperm deficits or immotility, it circumvents the sperm's biological need to swim, bind, and penetrate the egg's outer membrane. When paired with surgical sperm retrieval, ICSI overcomes azospermia. PESA and MESA aspirate sperm from the epididymis for obstructive cases. For non-obstructive testicular failure, microtesy allows a surgeon to dissect and extract sperm directly from isolated tubules. The shift from artificial insemination to intracytoplasmic injection is a calculated transition. It represents a transfer of reproductive mechanics from the human body into the controlled environment of the laboratory. The modern infertility workup systematically defines the limits of the HPG axis,
verifies anatomical conduits through imaging, and measures gamete viability against strict baseline criteria. Clinical protocols do not rely on guesswork. They deploy targeted medical engineering to circumvent the specific biological barriers identified during the workup. This algorithmic framework maps the transition from natural physiology to clinical intervention. By filtering pathologies through strict criteria, the protocol provides a definitive path forward, effectively narrowing the gap between a physiological barrier and a successful birth.
Human reproduction depends on a continuous sequence of precise cellular events. Interrupting that sequence safely requires an exact physiological intervention. To master clinical contraception and permanent sterilization protocols, we have to look past the top-line brand names and evaluate the exact biological mechanisms, dosing parameters, and strict contraindications driving each method. This flow map tracks the female reproductive cascade. The biological signal drops from the hypothalamus to the pituitary glands, which then stimulates the ovary to mature and release an egg, while the uterus and cervix simultaneously prepare for its arrival. We can intercept this cascade at 3 distinct nodes. The first is pre-fertilization. Here, interventions suppress gonadotropins at the pituitary level to halt ovulation, or they deploy physical barriers at the cervix. The second intervention zone is fertilization. Instead of preventing the egg's release, agents placed in the uterus or fallopian tubes induce a hostile inflammatory response that is toxic to passing gametes. The final zone is implantation. If fertilization has already occurred, these methods specifically target the endometrium, chemically altering the lining to prevent a fertilized egg from attaching. Within these 3 nodes, every method is strictly classified by its redressability: long-acting reversible contraceptives, or LARCs, permanent surgical methods, daily use reversible pills, and coitus-dependent barriers. A method-specific interception node dictates its clinical profile. By isolating exactly where a contraceptive acts, we can accurately predict its required protocols, side effects, and strict patient contraindications. Combined oral contraceptive pills operate at the first node. They rely on a combination of estrogen and progestin to cause anovulation by suppressing follicle-stimulating hormone to a greater degree than luteinizing hormone. If that primary suppression fails, combined OCPs maintain 2 secondary backup mechanisms. They thicken cervical mucus to block sperm penetration and thin the endometrial lining to prevent implantation. The strength of these pills is determined by their ethinyl estradiol, or EE, dosage. High-dose pills contain 50 micrograms or more, but modern formulations push the estrogen limit down as low as the absolute minimum 10 microgram threshold to mitigate risk. This 4-tier matrix compares progestin generations. First-generation norethindrome has the highest androgenic side effects. Second-generation levonorgestrel is the clinical baseline. Third-generation progestins suppress androgenic conditions like PCOS. Fourth-generation drospirenone is highly effective, but introduces a strict anti-mineralicocorticoid effect, carrying a significant risk of hyperkalemia. Daily compliance is mandatory. Packs are issued in 21, 24, or 28-day sequences. If a patient starts a new pack after day 5 of their cycle, immediate protection is void, and exactly 7 days of backup contraception is required. Missing a single dose triggers specific recovery rules. Missing 1 or 2 pills early in the cycle usually requires simply doubling up, but missing 3 or more pills in week 3 completely changes the protocol. This timeline shows why week 3 is volatile. The pill-free placebo interval is already approaching. Extending the hormone-free window by missing doses creates a gap wide enough to trigger a premature LH surge and spontaneous ovulation. To recover, the patient must discard the placebo pills entirely and begin a new active pack immediately. Despite their efficacy, estrogen's properties restrict its use. Combined methods are absolutely contraindicated in patients with severe cardiovascular risks, particularly smokers over the age of 35 and any patient with a history of migraines with aura. High blood pressure presents another hard barrier. According to World Health Organization thresholds, any patient presenting with severe hypertension, a reading of 160/100 or higher, cannot safely be prescribed estrogen. We also see a sharply divided cancer risk profile. Long-term OCP use increases the relative risk of breast and cervical cancers, as well as hepatic adenomas.
Conversely, the continuous hormonal suppression actively decreases the risk of endometrial, ovarian, and colorectal cancers. Estrogen increases clotting factors. That inherent thrombogenic risk means combined hormonal methods are strictly off-limits for patients carrying baseline cardiovascular or metabolic pathologies. When estrogen is eliminated, we rely on progestin-only pills. Standard POPs do not reliably suppress ovulation. Their primary mechanism of action relies entirely on thickening cervical mucus to block sperm motility. There are exact pharmacological exceptions. Desogestrel POPs, depot injections, and subdermal implants deliver progestin at a high enough concentration to reliably force and ovulation as their primary mechanism. Progestin-only methods are mandatory for 3 specific patient profiles: lactating women whose milk supply would be suppressed by estrogen, smokers over 35, and patients with any documented history of deep vein thrombosis. DMPA, delivered as a 150 mg intramuscular injection every 3 months, offers unique secondary benefits. It reduces the frequency of sickling crises in sickle cell anemia and raises the seizure threshold for patients managing epilepsy. However, the systemic dosing of DMPA yields 2 severe drawbacks. Prolonged use aggressively depletes bone mineral density, and once discontinued, patients experience a massive 12 to 18-month delay before fertility returns. Subdermal etonestrogel implants provide 3 years of coverage without the fertility delay. If inserted after day 7 of a menstrual cycle, the patient remains vulnerable and must employ strict backup contraception for 3 days. Centchromin operates outside both hormones entirely. As a selective estrogen receptor modulator, or SERM, it pushes the endometrium out of phase, making the lining asynchronous with a fertilized egg to block implantation. Progestin-only and SERM methods successfully bypass the life-threatening risks of estrogen.
However, removing that specific hormonal regulation invariably leads to irregular, unpredictable bleeding patterns in almost all patients. Intrauterine devices offer maximum longevity. Copper T380A has copper on lateral arms for 10 years. Multilode 375 has stem copper and spurs for 5 years. Released copper ions create an intense inflammatory reaction, preventing fertilization. Systemic absorption makes them contraindicated in Wilson's disease. The Mirena IUS removes the copper entirely. Instead, it releases a daily 20 microgram dose of levonorgestrel directly into the cavity, forcing extreme endometrial atrophy. As a localized hormone depot, it carries a strict contraindication for patients with active breast cancer. For nulliparous women with smaller uterine cavities, the Gynafix frameless device discards the rigid T-shape, anchoring a flexible string of copper nodes directly into the myometrium to reduce pain and expulsion rates. When IUCD PREDs vanish, protocol is strict. Step 1 is a pelvic ultrasound to confirm location. If intrauterine, retrieve via hysteroscopy. If it has migrated into the peritoneal cavity, immediate laparoscopy is mandatory to extract it and prevent bowel adhesions. If a patient conceives with an IUCD in situ, the presence of the device prevents normal intrauterine gestations far more effectively than ectopic ones. The first clinical priority is ruling out an ectopic pregnancy. Once an intrauterine pregnancy is confirmed, action depends on the threads. If the threads are visible, the provider removes the device immediately under antibiotic cover. If the threads are invisible, blind probing risks massive infection, and the device is left in situ. Coitus-dependent mechanical barriers are identified by physical parameters. Male condoms feature a single ring with a pointed reservoir tip, while female condoms utilize a dual ring structure for intravaginal anchoring. Intrauterine and barium devices deliver superior hormone-free efficacy, but their complete reliance on precise anatomical positioning dictates that any migration or failure immediately requires specialized imaging and surgical recovery protocols. Emergency contraception operates under strict physiological countdowns. By definition, it is not abortifacient. It poses zero teratogenic risk to an existing pregnancy, and if the patient vomits within 1 hour of oral dosing, the pill must be readministered immediately. This timeline maps efficacy windows. Oral levonorgestrel closes at 72 hours. Ulipristal acetate extends the window to 120 hours. The absolute most effective intervention is the copper IUCD.
Usable up to 120 hours, it acts aggressively on both fertilization and implantation nodes. In the postpartum setting, estrogen introduces two life-threatening biological conflicts. It directly suppresses the prolactin required for lactation, and it chemically amplifies the already severe postpartum hypercoagulable state, drastically raising thrombosis risk. For a lactating patient, the pharmacological options are reduced to progestin-only pills or immediate insertion of long-acting reversible implants to protect the milk supply and bypass the clotting cascade. Postpartum IUCD insertion faces an anatomical timeline. Devices can be placed immediately within 10 minutes of placental delivery. However, attempting insertion during the gap zone, between 48 hours and 6 weeks postpartum, carries an exceptionally high risk of uterine perforation and expulsion, as the myometrium actively involutes. When intercepting an emergency ovulation or managing a postpartum uterus, timing determines viability. Missing a defined physiological window instantly turns a routine intervention into a failure. Permanent surgical sterilization requires rigid ethical adherence. Tubal ligation legally requires only the woman's informed consent. Her partner's reproductive status, including a prior vasectomy, has absolutely no bearing on her eligibility for the procedure. The WHO defines Category D conditions that mandate delaying the surgery until the patient stabilizes. These include active pelvic inflammatory disease, severe eclampsia, or puerperal sepsis. The timing of the procedure dictates the surgical approach. A mini laparotomy is performed if the ligation is done immediately postpartum. But if the surgery is performed as an interval procedure months later, laparoscopy is the standard of care. Surgeons can sever the tube using the Pomeroy excision method with absorbable sutures, or they can occlude it mechanically. Data confirms that mechanical occlusion using titanium Filshie clips yields the lowest long-term failure rates. Assure provides a transcervical hysteroscopic option, inserting a nickel titanium coil directly into the intramural tube. Crucially, the device relies on induced tissue fibrosis to block the path. This takes time. Backup contraception is strictly mandatory for 3 full months until a hysterosalpingogram confirms occlusion. Vasectomy clearance follows a similar delay. Severing the vas deferens does not clear existing sperm from the proximal tract. The patient must complete a clearance period of 12 to 16 weeks or achieve 20 ejaculations before azoospermia is confirmed. Permanent sterilization demands anatomical patience. Severing a duct or placing an occlusive device does not yield immediate physiological sterility. The architecture of clinical contraception is entirely reactive to systemic physiology. Avoiding estrogen is a calculated maneuver to bypass the coagulation cascade, protecting the patient from thrombotic risk while preserving lactation. This completed map identifies the copper IUCD as the ultimate failsafe. By generating severe inflammation at both the pre-ovulatory tubal node and the post-ovulatory endometrial node, it effectively shuts down the fertilization pathway regardless of where the egg is in the cycle. Clinical mastery requires precise execution. Every pill, implant, and device operates as a calculated override of the human endocrine system, intercepting the reproductive cascade exactly when and exactly where it is needed most.